statistically that what is the exposure level. So, and once you confirm, then again you have to do a monitoring. So it is an entire process, like we have a PDCA, same ways you have this entire process to make the protective our employee as well as the community. So in this case, we have different industrial scenario, right? Can you recognize what are the hazards over there, possible hazards? Quickly. Noise, heat stress, vibration, dust, fumes, radiation, good. Rotating parts. This is a safety features. When you say the hazard part, right, you need something which impact the health. I'm not saying it is not hazard. Rotating part, if it is there, if it is impacting the illusion part, eye stress, then yes. Otherwise, we have to see the conditions. So that's why we have to develop, whenever you do IH, we have to develop eyes to see something which affecting the health. As a IH, when you have a safety, it's an injury part. When you have doctors, both prevention and how to do a treatment part. So when you go each scenario, right, each case, you will find that what are the parameters is affecting. So generally we classify in industries parameters in chemical, physical, biological, ergonomics, right? Further when you go, yes, this is again you have so many things. Now when you tick mark this, you will come to know what exactly is there. So when we say chemical, you have gas, vapor, solid, fibers, right? Lot of things. Which is easy to control, vapor or fumes? Simple question. Go to the basics. What is easy to control? Vapor. Why? It is coming from the solid or liquid. Again, you temperature control, condensate, you get the original composition. Whereas if you do filtration and everything, again you have to do a lot of treatment and all. So wherever you identify the sources, even in the physical you have noise, vibration, right? So which one is less hazardous, noise or vibration? Okay. So normally we said any health hazard, if anything is there, until unless, if you are IH, until unless you do not evaluate, we cannot say. Even a small dust can be more hazardous than what is visible, right? And there are the different scenario. So first of all, important thing is, for that you need a sampling to confirm. Without confirm, even doctor also, if you have something, they first write down the laboratory prescription, do test, and then come, right? So as an industrial hygienist or safety professional, what we do? No need to sample. I am very expert. No, don't do that, please. Do a monitoring, evaluate, confirm, and then you say what exactly, where action is required. Because in the management, either you have two ways. Either you speak the management language or make management to understand your language. So second option will take time. So first you have to speak in management language, where you have to demonstrate what parameters are there and up to what level. So first important thing when you start sampling is to understand what is the nature of a chemical, whether it's a solid, liquid, gas. So which one is easy to control? Solid, liquid or gas? Again, as a IH, don't answer anything because it depends on a lot of other conditions. Okay? Even solid, if it is very nanoparticle or diameter is respirable, it will remain in the air. So it is more exposed. So gaseous, yes, it is easy to contact, it is easy to exposure, but it again depends on what is the substance, chemical nature, its state of matter, its quantity, right? How the person is getting frequency of exposure. So there are many factors which impact your exposure potential. So overall, wherever the higher the exposure potential, your number of sample requirement is more, whereas less exposure potential, you require less. Similar way, depends on this exposure potential and many factors, we classify the people or employees into group that is called similar exposure group. Otherwise, what will happen if you don't categorize the people based on the pattern? If you do sample, you will have a big range of data. So that range of data, something will be under control, something will be overexposure. So where you take a action, you cannot. So to make the action decision, you need to segregate people as per their exposure pattern. That is called similar exposure group. So here you need to identify similar exposure group based on their location, job, work pattern and all. Right? So this is the one activity which we are supposed to do before the sampling to be done. Okay. Now again, another steps to identify number of sample is which way that parameter is exposed to human being, whether through inhalation, ingestion, eye, skin contact. Because what we do most of the time, we use the VOC meter, do the monitoring, 100 ppm. What is that? That is airborne concentration, right? That is which is going through respiratory. But what if that chemical is entering through the skin? Then you are not calculating that. So at least we should know that thing, that how the chemical is entering into the body. Like lead, mercury, toxic chemicals, heavy metals, they even enter through the digestion, ingestion route. And even the small quantity is very important because route of entry and their target organ. There are two important parts. Route of entry and target organ. Yesterday I saw that there is a chances of silicosis. So how silicosis happen? Silica exposure through respiratory tract, goes to lung, deeper lung. So that's why we consider as a respirable silica is most important. Otherwise, which is sand, which is on seashore or riverfront, it will impact, right? So for that, that is a route of exposure and the target organ is very important. Similar way, if you have exposure in different route, nothing will happen. But if it goes to a specific target organ, it will impact more. So here we need to understand what is the route of exposure to identify their impact. Now, another is how the dose effect relationship. So if you increase the dose, right, your health impact will be higher. That is a very common sense. So that is a sigmoid curve, so which will give you, but there are certain chemicals, once they don't have a threshold, it means even an exposure to single component or fibers or crystal, it will health effect is there. So like a carcinogenic, mutagenic chemicals, right? So generally we classify chemical impact in this 4 category. You know what is acute, which affect in short time, it is acute. Something will take more time to effect, it is chronic, right? Then local means wherever the chemical or any parameter, radiation impact, and when there is impact at the site, it is a local, and when it goes to the body and affect to any target organ, it is called systemic. So normally we classify, before doing a sampling, we classify what is the pattern of the hazard, health hazard into industries. So we classify into this matrix. Can you give you take any health effect or health impact or disease, and you can, or chemical, and you can put into this grid. Just quickly one example, acute local, chromium, acute, is it acute? It is local, but it's not acute. It is dermatitis, so it will go to local and chronic, right? Quickly. Acid burn, correct. So burning is, you consider as a safety part. When you say acid exposure, burning, yes. Skin damage, that is acute and local. Acute and systemic? Fume inhalation, okay. So what will happen? Okay, good. Acute, chronic and systemic? Radiation, but is it a systemic? Noise is chronic and systemic, probably. Hand-arm vibration, okay, right. So if you consider this pattern, right. So let's say irritant, you have this part, dermatitis, pneumoconiosis, carcinogen, carbon monoxide poisoning. Where do you find, why this category is required, you know? When you find a specific action, say like antidotes. In which conditions I require antidotes? In which condition we require antidotes? Acute and systemic, correct. So here, where you require PPs? Acute and not only acute, mainly where it is a local, right? So when you have distinguished the hazard into this category, you will have what type of controls you need to focus on, and whether it is a potential for a management or a EHS manager to act upon, which is a priority to be set. So here the same thing for the sampling. When you have this kind of category, you know which area our company has a more emphasis to be done. So another parameters to define the number of sample is called TLV or OEL, right? So generally when we do the exposure, health effect could be a short term, long term we have seen. So based on that the monitoring is to be done. So like for silicosis, can you do sampling for short time? No, because it's a chronic health effect. So we generally do for a longer duration exposure. But if there is a, say like ammonia, chlorine, which having a very short time duration to impact, so we cannot wait for 8 hours to do monitoring and do the judgment. So for that we require a short term. So based on the health effect, you can find the exposure pattern or sampling strategies, that is for full shift or short time, that is, and depends on that, there are certain standards are developed, that is called TLV STEL, TLV TWS sealing, and most of the time we have thousands of chemicals, right, where you cannot find the limit for everyone. So for that, how the excursion limits to be used. So here you need some training, some knowledge, how to use that limit and how to compare it, right? And generally we compare the environmental limit to the human exposure, which is totally wrong, right? So whenever you do want to do this exposure standard, always you to do personal sampling, right? Environment monitoring is not done. And we know every chemical have their own health effect. Generally this is a GHS scenario. And one chemical have a multiple health effect. Also you have multiple chemical with the same health effect, right? So if this pattern is there, so and you can monitor only one chemical, it will also not suffice your requirement. So here you should know what is a chemical nature, what are the 2 or 3 different chemicals come together and impacting my body. So if you have 2 chemicals impacting my same target organ, same health effect, so I supposed to use as a additive effects. So calculation is totally different. So normally people, we used to do one sampling and we draw the conclusion. So that is wrong. So there are different correlation with the chemicals and parameter. Even physical parameter and chemical parameter also do a synergy. Any example of this thing? Have you heard about a term called autotoxic, OTO, autotoxic chemicals? Anyone heard about other than doctors? Right? So basically that is a chemical which affect the hearing loss. It's not only noise which cause a hearing loss. There are the chemicals which also cause a hearing loss. That is called autotoxic chemical. So wherever you have noise and autotoxic chemical exposure, say like toluene and all, right? So your hearing loss potentiality is more. You can say, oh, it's below 90, below 85. How this thing happens? Happens. Even without noise also, chemical can cause a hearing loss. So this is the pattern we need to understand. What is the hazard nature of that parameter? So depends on the sampling. So basically when you do the sampling, you have to see whether the exposure pattern is full shift, some task, 2-3 hours, or they are exposed to 15-15 minute kind of pattern, charging or cleaning activity. So before designing the sampling pattern, you need to also understand what is the task pattern. Okay. So based on that, we need to things. And even the number of samples, and NIOSH has given very good, right? And here we have 95 percentile, 90 percentile. Those statistical selections are there where you need to, depends on the total number of SEG, you need to select minimum number which represent that 90%, 95% confidence limit, right? So one is personal sample, we generally do, right, to correlate with the exposure limit. Then area sampling like asbestos and all, we're supposed to do area sampling where 100% of the air should be representative. Even surface monitoring is being done when you have skin exposure pattern. Even the nowadays biological monitoring came. So there are different way to do the monitoring these things. And ultimately you have, once you get the results, is supposed to be statistically analyzed because you have done a samples, right? Not 100% samples. So statistical analysis will give you the right indication that in entire population, right, how much exposure could be possible or is there, right? So that is called statistical analysis, and then you can draw the conclusion. So this was what we have discussed about the chemical, but same thing applicable for noise, because noise, you have different noise, continuous, intermittent, impact, right?
Excuse me, 5 minutes.
Yeah, thank you. Even when you use DRI for the noise, you will get some pattern in which activity the person is having the noise. Generally what we do, noise, sound level meter, only dB, right? Not even dBA. So whenever as a safety professional, IH professional, we have to be very careful about what parameters we are monitoring and using which equipment, because it depends on the objective. So if you are monitoring an entire day exposure pattern, generally suggests is dosimetry. If you want to evaluate the effectiveness of the control, you need a frequency analyzer. Only dB will not suffice, because 90 dB, 95 dB, only it will give the pressure part, right? Not a frequency part. So actually our human body impacting with the frequency. So dB and dBA is totally two different things. Okay, generally people put just A beside that. So when you go and learn this frequency pattern, you will come to know actually which part of the sound is more important to us to control and to impacting the health. So ultimately you have noise mapping kind of thing with the manpower distribution. So as a IH, we generally see human exposure. Where the human is more, exposure is more, our first target is area where the people are there. Same way for heat stress. When we do the heat stress, what we do? Factory Acts only talks about wet bulb, dry bulb and all, right? It doesn't know. They talks about a lot of things, right? But we need to understand the correlation. So generally in heat stress, we measure three major areas. One is environment, that is wet bulb, dry bulb, globe temperature, air velocity, air turbulence, and human activity, metabolism, and clothing factor. These are the three main areas which are supposed to be monitored in heat stress. So again, the number of samples, right, depends on this part. Radiation, if you have ionizing, non-ionizing radiation, unknown, because nowadays after COVID we are using UVC radiation, right? So many other sources for sanitation, disinfectant, and so many things. So, and nowadays laser sensors and so many things available, even microwave towers are there. So there are many source of radiations are there in around, which is also sometimes synergistic. Even right now what I am using pointer is having the laser, right? But I don't know whether it's a laser source or not. So there are so many laser sources in around us which impacting the human employees. Another important thing which is applicable everywhere is ergonomics, right? So these subjects needs to be also correlated with the heat stress, ventilation and ergonomics study. So it will give you the comfortness. Actually whatever standards or rules are developed on ventilation or anything, it depends for the comfortness. So basically we take number of tasks, manual activity, what are the tools, tackles, and accordingly we identify the number of samples that is in qualitative, and then detailed study into quantitative. Same way, biological exposure, right? Nowadays we all are expert in COVID, right, and biological hazard, but still we are not focusing on that thing. So whenever you do the biological sampling, again you need a different methodology and techniques. So once you have the samplings, also we need to consider the controls, right? So wherever available controls are effective, monitor well, you need less samples. But if you no controls, no properly maintained, then you need more samples over there. So ultimately when you see the guideline for the qualitative exposure monitoring, say I have given one sample over here. So you have to consider all the parameter while you do the sample identification. So before doing a sample matrix develop, we need to go through all the criteria to be evaluated for each task or each hazard parameter.
You have 1 minute to sum up.
So for more reference, you can utilize various sources like Occupational Exposure Sampling Strategy Manual. It is freely available online. You can go through, read and understand how the industrial hygiene samplings are defined, designed and further used. So that's it from my side. Any question, comment, please, most welcome.
Thank you, Mr. Bhav sir. It was a very lucid presentation.
Yes, Dr. Parikh has asked very good questions. I will take 1 minute in that. dB and dBA, right? So dB is what? It's a logarithmic. See, normally noise, it's a wave, right? So each wave, when you see the crest, it is a pressure variation in the air. So whatever energy I am putting, I am creating a pressure difference. So basically, noise is, in arithmetic, it is measured in the Pascal. But our range is audibility and high noise. Range is 10 raised to 21 unit Pascal. Okay, so it is so big. So to make this bigger line, it is made smaller by converting arithmetic into logarithmic. So compare with the reference, it is converted into dB, decibel, right? So within say like 30, 20 decibel to 140 decibel, we can play the entire noise. But now dBA, see actual noise, whatever is there in the atmosphere or in the machine, our human have a perception, right? Sometimes we don't hear something, sometimes we hear something loudly. So that perception is converted into a filter system. That is called a filter system for human interference, like low frequency sounds, say like 500 hertz, 700, 750 hertz and all. These are the low frequency where our ear can actually hear the noise very low. That is a mechanism of our ear, okay? But our ear have a capability to amplify certain range, 1000 to 6000 hertz frequency range, multiplication. That's why your all siren, alarm, signals are into that range, 1000 to 5000. Why? Because it's an amplification in the outer ear. So that's why scientists have what they developed to get the actual perception. dB is converted to dBA. But for that, for individual frequency, we need to measure that sound, and that individual frequency, that sound is getting corrected based on our perception. So
Thank
that
you.
is called
Thank
dB.
you, Mr. Bhavsar, for very nicely elaborating about DBA. Thank you. Thank you very much.
Can I request Chair to hand a memento to our speaker?
Hello. Now we'll call upon our next speaker, Dr. Ravish Patel. This session is sponsored by Sunshine Global. He is a consultant spine surgeon at Sunshine Global. He is trained in spine surgery. He has done specialization in spine surgery from very prestigious institutions of Singapore, Korea, South Korea, Bombay hospitals. He has got a vast experience of more than 1200 spine surgeries. He has got a 15 PubMed indexed publication in prestigious journals like World Neurosurgery, European Spinal Surgeon, Spine Journal, and British Medical Journal. He is one of the few who has been awarded with the Global Outreach Program, a scholarship, and also IASA Spine Award in USA. We'll listen more about the spine, work-related diseases, and other things from Dr. Ravish Patel. Dr. Ravish Patel, please.
Thank you for a warm welcome and thank you for giving me this opportunity. Now, when we talk about back pain in industry, the first thing that comes to our mind is ergonomics. And we believe that, ergonomics is very important. In fact, it is important indeed. But the question is ergonomics the solution to all the back problems? If that would have been the case, then it would have been very easy to treat all kind of back pain with just ergonomics. But that's not all. Because if you look at the causes of back pain, there are a lot more causes there are almost about 50 causes of low back pain which are identifiable, and there are unidentifiable causes of low back pain also. So, to decode low back pain, myself, Dr. Ravish Patel, a consultant spine surgeon from Sunshine Global Hospital, I am here to share my insight. Let me simplify back problems into a few categories. So, if we look at the etiological basis of back problems, 80% of them are degenerative. For an industry, 10% of them may be traumatic, 5% are infection related, and 5% are others, which may include non-spinal pathologies also. So let's look at the first and the most common, that is degenerative pathologies. For degeneration, it is very important to understand that there is only one surety in life, and that is, as you grow older, there are certain wear and tear changes in your body. And same thing happens with your spine also. So this is the 3D model of the spine, you can see. And there are some structural changes occurring in your spine throughout your life. You must be thinking that these degenerative changes must be occurring after 50, 60 years, but that is not the case. If you look at the literature, 50% of the population shows signs of degeneration as early as 30 years of age. So your spine, I would say 50% of the people's spine has already started aging at an age of 30 years. And that is responsible for majority of the problem. So what happens is that you can see the blue color disc which is surrounded by ligaments. This is, you can see on the right hand side is a normal disc. The water content of this disc starts to decrease, and as a result of which there is decreased flexibility. And this decreased flexibility is responsible for the commonest low back pain that we see. Let me share you an example. So a 33-year male software engineer who just bent forward to lift up something, and he got severe back pain. This is just a representative image. So the back pain was so severe that he couldn't move. Very severe back pain. And when we examine, as far as legs are concerned, everything was normal. He was just having severe back pain. So this condition is known as acute low back pain. This is a very common problem. 80 to 90% of people will have this at some stage in their life. But the good part is 90% of the people, those who have back pain, will recover without any intervention. However, it is important to treat them, because if they are not properly treated, about 20 to 80% of them may actually develop a recurrent back pain, and you see employees having chronic back pain in the lower part of the back, then some have in the upper part of the neck. So all this is because of the chronic changes that are occurring because of this repetitive stress. If you look at the treatment part, it's very simple. Medicines, physio, ergonomics, rest, and other modalities. There is no surgery, for an initial acute low back pain management. For an industrial importance, it is important to note that the management occurs in stages. So acute stage, that lasts for about first 3 weeks. Then we have subacute, that is between 3 weeks to 3 months. And then we have the longer part, that is 3 months onwards. Now, majority of the work modification that is required is only for the acute stage, and in certain cases you can stretch it for 3 weeks to 3 months. So for this, only temporary modification, maybe employees should be asked not to lift weight, not to bend their back too often, not to involve in activities which require repetitive stress. So only this much part of modification is required, and that also for a temporary period of time. What is very important is the employee should never go for complete bed rest for more than 7 days unless and until they have an infection, trauma, or they have a serious spine condition. And this has been very well described in occupational health guideline also, which clearly states that low back pain is a self-limiting condition, and the employee should either remain at work or they should come back to work early, obviously with modified activities. So that is what the conclusion of this study in 2003. And yes, we should stress the importance of exercise in the employees also, because exercise is considered the best medicine to prevent back pain. And that is what the suggestion of North American Spine Society, which says this, any type of exercise, whether you do aerobics, yoga, or cognitive behavioral therapy, all this can work and help you with the back pain. Now, if we move ahead in the degeneration cascade, some of the unfortunate patient will actually develop disc herniation, or what we commonly know as slip disc. Now, it is important to know that this slip disc is actually different from the degenerative disc, which you can see. So, the first is a normal disc. Below it is a mild disc bulge. So, many times if you must have read anyone's MRI report, there are many mentions of mild disc bulges at 4-5, at 5-1. So, that mild disc bulges are not the significant ones. The last one, which is the herniated disc, is of clinical importance. So, how do patients with slip disc present? This is a classical example. They will have back pain associated with radiculopathy. So, that is sciatica. And when we get an MRI of such a patient, you can see a large disc herniation, and which is causing significant compression. Now, when this is a common perception. When people come to me saying that I have a disc herniation, they think that I am going to push their disc back inside, but that is never going to happen. There is no treatment in this world as of today which can actually push back the herniated disc. Because a disc is like a toothpaste. Once the paste comes out, it can never go back in. The only way it can resolve is by a natural process of inflammation, which can either cause complete absorption of the disc, or there may be no absorption of the disc. And this natural healing process is the basis of the conservative treatment that we give in such patients. Be it rest, medicines, injections, within 3 to 6 months there is an 80 to 90% chance that the patient get better after a disc herniation. Only 10% of them, those who don't improve, or they are having significant weakness in their legs, or they are having problem in urine passing motion, they are the only ones that may require surgery. During an episode of slip disc, the work modification that is required is basically to avoid back flexion. So activities like lifting weight, bending forward, and prolonged sitting is to be avoided. Now, prolonged sitting is very important because I have seen that slip disc is even common in people who work in IT industry, who have to sit on computer for 8 to 9 hours. They also have back pain and they also have disc herniation. So this modification is important. The duration is debatable, and I think we should better decide on case-to-case basis. But these are the modifications that are required in case of a disc herniation. Now, moving forward in the degeneration cascade, a time will come when the disc will get collapsed totally and the bones will start rubbing with each other. And that will give rise to the osteoarthritis of the spine. So how do patients present? They will be all right throughout the day. But the moment they get up from their bed, they will take some time. They will have some back pain. And most often it will be temporary. They will get some hot massage and they will be comfortable throughout the day. So when we get an X-ray in such patients, you can see that the space between the two vertebral bodies has reduced. The doctor usually say, gap ochi thai gayi chhe, gap kam ho gayi hai. This is nothing but lumbar spondylosis. When we say lumbar spondylosis, people think, oh, I have a spondylosis, mujhe to spondylosis ki bimari hai. But trust me, it is the best end of the degeneration cascade. Because if your bones are rubbing against each other and they are stable, that will give rise to a stable ankylosis. The problem occurs when it doesn't come together properly, and that will give rise to problems like stenosis, listhesis, or a deformity. So what is stenosis? Here you can see the image on the right hand side. You can see some dots inside this marked, which are the nerve roots. And on the left hand side you can see the ligaments which are totally compressing this nerve root. So what happens is body tries to stop that movement by forming that black colored ligament, and in that process the spinal nerve roots are getting pinched. So such patients will have a different set of problem. They will be comfortable sitting throughout the day, but the moment they walk, they will be hardly able to walk 100 or 200 meters. And they will have to take frequent breaks if you have to walk long. So in such patients, if you get an MRI, you can clearly see lumbar canal stenosis. This is many times associated with slipping forward of the vertebra, which is known as spondylolisthesis. And this also presents with similar set of problem. Back pain with bilateral lower limb or unilateral lower limb pain, which is more on standing and walking. The reason why it is important to differentiate lumbar canal stenosis from a disc is because here 70% of the patient, they are not going to recover on their own. 30% of them can actually manage. And that is the reason that we can still try conservative treatment in them. But when the conservative treatment is not effective, or when their activities of daily living are affected, that is the time we suggest intervention. Now, these problems usually occur in elderly people. So some people will be comfortable walking 200 meters because their requirement is less, but some people want to walk 3 or 4 kilometers. So for them, maybe at some stage surgery is indicated. And usually weakness, paralysis, bowel bladder symptoms are very late in such type of presentations. The work modification required for this set of symptoms are totally different. Here they have to avoid standing, they have to avoid walking, and they have to avoid extension. So they cannot be employed in jobs which require prolonged standing and walking. And of course, ergonomics is still important, and so they should not be employed in activities where they have to bend forward, lift weight, or there has to be some ergonomically correct way of doing that activities. Now let us move on to the other part. This was about the degenerative. Traumatic, we won't go into the detail because that is already a different set of problem and different set of principles apply to that. But it is very important to differentiate. Whenever we are having a back pain or whenever we are seeing patients with back pain, it is important to differentiate whether it is a degenerative problem or it is something serious. So that is very important. So here is a case example. This 26-year-old male patient was working in a dairy industry. He had back pain which was there on lifting weight, but it was even then on lying down position. And he had made about 7 visits to the hospital, 4 to the OPD and 3 times in the emergency. Every time he was sent with a medicine and saying that this is the common problem, your X-ray looks okay, so you can take the medicines. But 8th time, he actually came up with paraplegia because he was having a spinal cord tumor which was not missed because he was never investigated. And there is one significant sign is that he was pain on lying down. Now if you have degeneration, that will never cause pain on lying down position. Some positions may be painful, but a patient cannot sleep because of pain is significant. And that sign should be considered a red flag sign. So there are 12 signs, I would say. 5 in the past presentation, 5 in the past history, 5 in the presentation, and 2 in the examination finding. So let's see what are this. So when we talk about past history, it is cancer, any recent history of infection, any kind of arthritis, rheumatoid or other kind of arthritis, extremes of age. Degeneration does not occur in less than 20. And for more than 50, they have a problem of osteoporotic fracture also. And the last one is the chronic steroid or immunosuppressive drugs. Similarly, when we look at the presentation, it is fever, patients presenting with weight loss, patients having problem passing urine and stool, patients having pain at lying down, and patients after trauma. I am not saying that if any of this present, they will have serious problem, but I am saying that they should at least be investigated if any of this is present. And when we talk about physical examination, we should always check for the neurological part and the numbness, especially the perianal numbness, which is important in such cases. Now, why it is important to identify such cases? Because I'll give you 2 examples just to know the importance of this. This was a 22-year-old male chap. You can see the red arrow showing an abscess without any significant bone destruction in this. This patient presented to us on time having only rest pain. We passed a needle, took out the sample. It turned out to be positive for tuberculosis. And then this patient got cured without any kind of surgery. And on the other hand, we do get cases like this. You can see with the red arrows, there is a massive tumor. Patient sat on this tumor for 2 years. When he came to us, he was in a very critical situation and he had to undergo 2 surgeries, front and back, before we could revive him. And yes, so far he is doing well, but this could have been, probably minimized or avoided if he would have presented to us earlier. Now, the last part is return to work possible after spine surgery or a spine problem? The answer is yes. Currently, the literature says that 70 to 90% if they undergo timely spine surgery, they do return to work. Some of them may require modified activities, and some of them may be able to do their normal work, which they were able to do it before also. And at our center, we follow this TEAMS protocol. So TEAMS is T for timely intervention, E for evidence-based medicine. We just don't look at the literature. We try to evaluate the patient clinically, and we check and we take into consideration their occupation. We take into consideration their values and what they want actually from us. So all this put together, what we call as evidence-based medicine. Natural is always better than repaired, and that's why we avoid unnecessary surgeries whenever we get an opportunity. And if a patient has to undergo surgery, we try to minimize intervention, and we try to do it with a small hole. For example, this gentleman who was having a slip disc, his question was, when can he walk? He was able to walk immediately after the surgery because the surgery was done with a small hole, and he went back to work in about 7 to 10 days' time. Similar thing we can do for stenosis also. We can do with a minimal invasive surgery in cases where it is possible. And even fixations. So previously we used to do open surgeries. Now also we do open surgeries in some. But majority we now do with a minimal invasive technique. So tissue destruction is less and return to work is faster. And obviously the last is S is safe spine surgery. We have cutting edge technology, be it microscope, endoscope, burrs, neuromonitoring, all this which is required to make this surgery safe and help people get back to work faster. And we are the only hospital in Baroda, we have started fusion and decompression without opening the spinal canal. So we do this technique where we go from the front, put a cage, jack up the space, decompress the nerve roots, and go back and put screws. So this was the first case in Baroda which was done about 6 months back. And it is because of these advances and because of the continued support from occupational health doctors also that we are able to create stories which were thought of as impossible at one time. So the take-home message I would like to give, yes, ergonomics is important. There is a talk on ergonomics later on. But it is equally important to identify their problem and give them a proper solution. And of course, the team's approach is very important. Thank you.
Thank you, Dr. Ravish. It was a really very wonderful pictorial presentation. Easily you can take home a lot of messages, accidents, whatever he has shown. Since he has finished the time, any question pertaining to spine? Anybody?
Can I ask one question? If at all any of the patient wants to return to work after the surgery or so, what is your advice for not to lift how much weight or what exactly you want to tell them after 10 days?
Okay, so that's a very important question. And first of all, before starting my answer, I would like to say that the answer we cannot generalize for everybody and for every kind of pathology. But in general, let's say a patient is going a single level decompression or a fusion surgery. So usually now the trend is to make them walk or move faster. So first of all, we will ask them to get back to work in about 10 to 15 days of time if they are employed in an occupation which does not require weightlifting. For example, office workers or for example, those who are supervisors, they can go back to work in about 10 days time. For people, those who are actually involved in lifting weight, the limit currently that we prescribe is about 5 kgs for initially few months in some cases and maybe about maximum to about a year in some cases. And once that pathology has healed properly, they can actually lift higher weight also. There are few of my patients who are actually doing gymnastics, who are even doing deadlifts that they lift their whole body on their head. all this is possible in some cases and with some motivation, but I think we should not generalize it for everybody.
Thank you. Thank you, Dr. Ravish.
May I request Chair to hand a memento to our speaker? Dear friends, today we are humbly obliged by the presence of Shri PM Shah sir.
She is a good, very renowned celebrity nutritionist. So their team, they helped us out in this. And the audit procedure, we identified 115 locations across India, and we audited them. And this audit was carried out with a well-defined, very well-defined parameters, which were related to health and hygiene. So we audited the dry storage area. This was the process flow of the canteen audits. The dry storage area, the cold storage area, then the cutting and chopping, then equipment handling, then kitchen hygiene, food preparation, then dishwashing, then food serving, pest control, and even up to the garbage disposal. So all these parameters, they were studied in a process flow in all these 115 canteens. By that time, when we started in 2010, even FSSAI, they were not having their well-defined guidelines. So we had to define our own guidelines for our canteens, and for this, we developed our own criteria. This criteria, like the parameters which we were studying, we allocated certain marks against these parameters depending upon their importance. So out of the total marks which any canteen they get, a hygiene index was developed. So that I will tell you later on. This hygiene index development was there in all canteens. So this assessment, based on this assessment, what we found, there is a lot of scope of improvement. So if a canteen is not getting 90%, they are getting just 60%, 70%. So a lot of things they can be done. But what to be done? That has to be seen. So I'll show you very pictorial things which will be easy for you all to see. That these audit findings, when they were assessed, after that we took the management, local management into confidence, because without taking local management into confidence, nothing can happen. So whatever your findings are, you have to audit them, you have to assess them, and then you have to brief it to the management so that necessary actions can be taken. So this was started long time back. Even Dr. R.C. Saxena sir was part of it. Then Dr. Datar, he was also part of this. So we had requested senior OH physicians to help us out in this efforts. Now, we all know that prepared food, it is very important that it should be kept at a proper temperature. Between 4 degrees centigrade to 60 degrees centigrade, if the food is kept for a long time, definitely bacterial growth will occur and the food will become unsafe after some time. So we started these observations, and there were certain observations in the dry storage area, like there were loose fitted jars and cardboard boxes for storage which were stacked on the floor. Now moisture and air, they encourage the decay of the food material by bacteria. So this was the condition when we started the audits. Then we suggested them, recommended them that all the food grade plastic and stainless steel containers, they should be kept in the storage areas, and this will prevent microbial contamination, and tight lid containers, they should prevent contamination, and periodic cleaning schedule should be maintained of these containers. Then even what we were found in the vegetable, where the vegetables were kept, it leads to loss of freshness and promotes the microbial growth, because when you keep them just mixed up and in open air, not properly stacked, then the freshness will go after some time. So we suggested, to prevent contamination and to sustain their freshness, we suggested them that you should have well ventilated vegetable baskets which should be used for storing these potatoes, onions and these vegetables. So after washing, you can place them in these separate baskets, and this will have them fresh for a long time. Now, another important thing was the first in, first out method. Because if you are not following FIFO, then the latest inventory, it will be lying in front, and the old inventory, it will be there at the back, and it will be difficult to for you to utilize this material in a proper manner. So we suggested these sort of containers, and now almost all the canteens, they are having these sort of containers, and this will reduce the expiry of the packed food items. Like when you fill in this this bin, then you have to fill it from top, and when you take it out, it will come out from the lower lid. So this will help in maintaining the first in, first out method, and this will also prevent the expired food material to be there in the storage areas. So this is also what we found at many places. These packets were lying and they were all expired. So we told them that these expired food items, they can cause food poisoning, they can cause loss of taste, and they will also be not of nutritious value. So first in, first out method was imbibed, and lot of labeled food containers were not in use. So material was just lying in the poly bags or the paper bags or in the loose fitted containers. So we told them to have proper containers with tight fitted lids, and to have the properly labeled containers. Then this dry food should not be kept directly on the floor, because it will increase the chances of contamination of the food sacks. So these sort of platforms were built in, and racks were provided to them, so that the sacks, they are 3 to 4 inch away from the walls, and the walls, they should be covered with ceramic tiles, not by just plastering. And the perishable food items, they need to be placed in they need to be not to be kept in the dry storage area. They should be properly placed in the refrigerators. And this will help in sustaining the freshness for a longer period of time. It will prevent the microbial growth also. So all food items, they should be appropriately placed, and they should be easily accessible by following the first in, first out method. Then, to avoid mixing up of the food, cleaning items should not be kept along with the food items in the dry storage area. This was a very common practice. The cleaning material, the acids, the Nirma powder, even the soaps, the pesticides, they were kept along with the food material. So this may cause poisoning, because sometimes what happens, these products, they can camouflage with the food products, and they may be used wrongly, or they can cause poisoning of the food material also. So there should be a separate cupboard, separate away from the dry storage area, for storing these food items, these cleaning items. And they should not have these storage area, they should not have damp walls. As I told you, it should be covered with the ceramic tiles. This was the condition of the cold storage at many places. So what happens, no one cares about these cold storage areas. We leave it to the contractor leave it to the cooks, and our supervisors, managers, they don't go and look into the depth of the refrigerators. So what we suggested, that for proper functional refrigerators, it is important to keep them clean, and we should have proper racks, storage racks inside the deep freezers. Like for example, if you are not keeping these plastic containers in the refrigerator, deep freezer, and if you are keeping the milk packets directly on the floor of the refrigerator, when you take out this packet, it will get stuck to the bottom and वहाँ पर spill हो जाता है सब. And when it gets spilled, it is difficult to clean that bottom of that refrigerator, and it will, there the bacteria will proliferate. And even the food items, they should not be kept like with an open lid. They should be covered, because it will help in maintaining the freshness of the food. So and there won't be any cross contamination. And the veg and non-veg items, they should be stacked separately in the refrigerator. At many places, what we found is their knobs were not working, their controls were not working. So if their temperature thermoregulators, they are not working, then proper temperature can't be maintained. So in that case, what is the use of keeping such a refrigerator just for the name's sake, without a proper temperature control? So we suggested that they should have a proper thermoregulator. It should be functional, and the marks were deducted if these thermostats were not working. Then cardboard boxes. Sometimes we see that we bring ice cream packets, we keep them directly inside the refrigerator. Even these packets of oil or ghee, they keep directly inside the refrigerator. What happens, this cardboard, it absorbs moisture, and when it absorbs moisture, it will lead to proliferation of bacteria. And this cardboard box, it will also it will just tear off when you take it out from the refrigerator. So we suggested that they should not use these plastic, this paper things inside and cardboard things inside the refrigerator. And for perishable food items, we suggested wherever there are big canteens, they should have these sort of walk-in freezers. So this is the way you should store and organize your refrigerator, maybe in the canteens or the workplaces, and this can be also religiously performed at our home also. Now comes the food preparation. We should have separate this spice box for all the spices. There should not be mixing of the spices. If there is mixing of the spices, then it will lead to different type of taste will be different. Sometimes the spices are more, or sometimes the salt is less, or so proper taste of the food will not be maintained if the spices are not maintained. Then comes the wooden logs and iron knives. They were used for chopping. So we suggested that you should not use wooden logs. You should use colored coded chopping boards, and all these rusted knives, they should be removed. They should be replaced by the stainless steel knives. So this will prevent contamination, and this will also prevent the infection. Then reusage of oil it was not promoted, because repeated use of this heating of this oil, it produces acrolein fumes which can cause cancer. And these fumes, if the exhaust is not proper, if the chimney is not working properly, it will go inside the respiratory passage and it may irritate the lungs, and it is carcinogenic. Excess use of spices and condiments was also discouraged, and turmeric, they should be used because it has got anti-inflammatory property. So all these guidance were given by the dietitians. Now, wet, unclean dish clothes, these are routine practices. So they should not be they should not be there. They should be properly cleaned, and they should be replaced as early as possible, because it is an ideal environment for the bacterial growth. And sometimes because of the lack of awareness, they apply butter with their own hands rather than with a spatula. So we advise them to use the spatulas for all these efforts. Then use of newspaper is very common to fold chapatis in the tiffin box. So because these newspapers, they have got this printing ink which is carcinogenic. So a long exposure, chronic exposure of this from this chemical, it can cause cancer. Then comes the equipment handling. All the equipment which are there, like the chimney or the burners, they all should be properly cleaned and properly maintained, and they should have a periodic cleaning schedule before the meal preparation and after the meal preparation. So this need to be maintained. Then improper storage of the utensils. That is also important, because after washing, if you are not stacking these utensils properly, then when they are required, then you will see, just to find out a spoon, you have to turn the whole bucket of the basket which is filled with utensils. You won't find the spoon. So spoon should be stacked at a proper place, and all the utensils, they should be stacked at a proper place, so that the flow of retrieval, it is very good, and ease of work will be there. Then what was observed, that kitchen areas, they were also being the dumping grounds. So there were slabs on the kitchens on which unused material, unused utensils, they were just being stacked, and rats and cockroaches, they were the breeding grounds for these areas. So what we suggested, they should remove all these extra things, and it should be cleaned regularly. Then all the exhaust fans, chimneys, they should be cleaned properly and with a frequency, because it will maintain a proper flow of air and better circulation of air inside the kitchen area. Then what was very important was these rusted pipes. No one was taking care of these rusted pipes, and these rusted pipes, we told them they should be removed and they should be proper colored, coded, and we all see this during the inspections. And even these cracked LPG pipes, they are the source of accident. So if these pipes are not periodically checked and periodically removed, they can cause accidents inside the kitchens. Then improper LPG gas cylinder storage areas. So these storage areas, they were also assessed, and if we are not maintaining these LPG gas cylinders properly, then they can be a source of accident or blast inside the kitchen or near the kitchen area. Then comes the washing area. These washing areas, all the clogged these drains, they need to be cleaned, and the frequency need to be maintained, and we should have this 3-sink method for washing, rinsing, and sanitizing these used dishes. Then geyser must be installed, and it should be in working condition. At many places we find that geysers were there, but they were not in working condition. And even these poor people who are just working and cleaning the utensils, they were not wearing shoes, they were not wearing gum boots. So we recommended they should wear gum boots while working in the washing area. Otherwise, we found foot sores which were a source of infection, and these people, they just don't care about their legs and hands. So we should provide them with gum boots when they are working in the washing areas. Then these are certain racks and storage areas which we suggested. Even the dustbins, improper garbage disposal, that was a cause of concern. So we told them to use proper covered step-up dustbins. So now you can go and see our canteens. They are all these sort of step-up dustbins are there. Then even for garbage disposal, in our refineries, we have 9 refineries, so in all 9 refineries, we had this organic waste, converter. So this is being used. This was initially installed at Guwahati refinery, and now others are also doing it. So clogging of drains should not be there. Drains should be periodically cleaned. Drains should be covered with covered to avoid accidents, because inside the kitchen also there were drains, and when you are just moving inside the kitchen, they should be covered. The drains should be covered. The washing area should be clean, and we should have some health related informative posters which should be placed inside the dining areas. And pest control was very important, because this proper documentation is required for when we go for pest control. Because what happens, we all line up some agencies, and these agencies, they come and do the pest control. We never bother which chemical they are using and at what frequency they are using. They just fill the register and do their obligation. But we suggested that they should better go for herbal pesticides, and after 3-4 visits they should change the chemical also, because these rodents and these pests, they become resistant to if we are routinely using the same chemical.
2 minutes left.
Yeah, sure. So these pest control, then comes the training. Training was very important. Awareness should be there amongst these pantry boys, and this is how our things changed after this hard effort. So now this is the ambience, this is the dry storage, this is the cold storage, this is the food preparation and services, well organized now. Utensil and equipment, they are clean. Then washing area is clean, and pest control is proper, garbage disposal is proper, and proper uniform to the kitchen staff. Then their periodic medical examination and 6 monthly deworming is being performed. Then these parameters which are observed: uniform, headgear, nails, gloves, hair length, jewelry if they are wearing, so it should be discarded. Then kitchen poster samples, they were provided, and this is the hygiene index which I told you. Out of those 80 marks, how much marks they got, divided by 100, the hygiene index will come. So this hygiene index need to be displayed at all the locations where the dining area is there, so that whosoever is sitting and eating over there, they should know what is the hygiene index of this canteen. And I will tell you that this hygiene index, now it is within the system of the Indian Oil Corporation. All the divisional HRs, they have a MOU with the respective units that they have to send quarterly report of the hygiene index, and this is now monitored by the corporate office. So you see, such a simple thing, no one will see, someone will laugh your occupational doctors, they are looking after the canteens and the kitchens, and how meticulously we have done, how we have brought it within the system of the Indian Oil Corporation. Maybe after a few years I won't be there, but system will remain there. So such sort of efforts you have to do. And since we can't go and do canteen audits now and then, we conducted food safety workshops for all the HR people, employee relation people, those who are taking care of the canteens, and even for the canteen committee people. Posters were designed and given, and even guidelines were prepared, and they were circulated to all the employees. And we introduced a canteen award, a healthy canteen hygiene index award. And this best canteen award is being given to the best location which has got the best hygiene index. So we should always prefer to go for safe food. Food safety is very important, and it is very good. Yes, our companies, they are taking care of our medical expenditure, but we should also prefer good food, safe food, rather than taking the medicines. So thank you all very much. If you have any questions.
Thank you very much, Dr. Sandeep Sharma. It was an enlightening session, and I observed a lot of people were very curious, taking a lot of snaps. And it is a different world gain food safety. Thank you very much.
And I'm ready to share this hygiene index with you all. I'll share it with Dr. Kamath and the team. So you can take it from them. You can use it in your organization, and this will definitely help you all. Thank you.
Can I request Chair to hand a memento to our speaker?
Thank you, delegates, for being here in large numbers. There is one very important announcement to be made. Looking at the hall full of total capacity, there is a live streaming going on, first floor, Emerald. So those who are not comfortable sitting in a crowd, they can go and watch the live streaming there. Thank you.
So moving ahead with the last speaker in this session, I may request Dr. Tejas B. Prajapati to come to the dais. Dr. Tejas Prajapati is MBBS, MD, Diploma in Clinical Toxicology from Australia. I think he has given 7 pages of CV. I can't read, but I'll read. But by his presentation, you can come to the depth of his presentation. He is presently the consultant clinical toxicologist in India, on-board medical toxicologist with many industries, and he is a resource person for Gujarat State Disaster Management, Gujarat Maritime Board, Gujarat Police Academy, Forensic Science Lab, Gandhinagar, Indian Red Cross, Public Health Institutes, National Disaster Management. So with this short brief, I would like to request Dr. Prajapati to give his presentation.
Well, I'll add on some of the more things. He was an invited speaker in GUJCON-17, GUJCON-19, and we have also called him in IIH Vadodara in one of the CMEs. He was invited speaker in various national and international conferences. He is a resource person of the Gujarat Disaster Management, and in forensic medicines he has updated 2 of the chapters and he has contributed a lot. He is working on the Alang shipyard, where he has designed various safety and the other monitoring arrangements about the first aid, hazard identification. 2 chapters of the textbook of medicines were amended by him. Dr. Prajapati, please.
Thank you so much, sir, for kind introductions of me, and thank you so much, organizations, for giving me this opportunity to speak here with the wonderful delegates. And so, first of all, that my topic is on industrial chemicals and their antidotes, because many times what will happen, the first call in any industries, whenever you are a doctor and go as a factory medical officers, the task is been given to you that identify the antidotes for the chemicals. Am I right? So, most of the time, you know, we are stuck up with the antidotes, at what kind of antidotes for the different kinds of chemicals we have, and after that we have to just look after the things in a different way. So the industrial chemicals are very, you know, diverse point of view. That covers a broad range of chemicals used in the inks, plastics, adhesives, paints, glues, solvents, cosmetics, soaps, many other products that may contain industrial chemicals. But many times we have to understand which are the toxic ones and which are the non-toxic or the non-hazardous ones. So the toxic, anything can produce an adverse biological effects. We have to understand. Many times what will happen that, you know, in the industry, whenever I used to have this audit on different kinds of chemical industries, and we just come to know that, doctor, this is not a toxic chemical. Then how will you identify whether this is going to be a toxic or not toxic? That we have to understand the LD50, the lethal dose 50, and the lethal concentrations of the 50 of that particular chemicals. Then and then only we can comment on something, whether it is of chemical, physical, or the biological toxic agents. Because many a times the toxic substance is somewhat different than the chemicals. Many times what will happen that whenever we are having a different kinds of chemicals combined together and the new product is going to be generated. Many industries are utilizing the intermediates. So what about the intermediates? Whether we have got a clear information on utilizations or whether we can have a proper information on the intermediates. Because whenever this kind of intermediate exposed and at the time of emergencies we don't have got much time to act. Many times we have got a very diversified chemicals which may be a byproducts. Recently I have got 2 patients in UP and they have gotten exposed to H2S. Okay, then after that H2S was not actually generated, but that may be some of the decomposition gas may be there, and the people were exposed and the one person died on the spot. One person was taken to the hospital, and after that the doctors were not knowing that what to do in this kind of H2S exposures. What kind of antidotes that should be utilized in this kind of hydrogen sulfide or any other chemicals exposures. So chemicals may be an acute or chronic one. Depending on that also we have to understand. Because in many pesticides industries where I am on board with the many problems may arise, because like in cholinesterase level what we are doing. The cholinesterase activity may be lower down in a chronic exposures. So whether in that kind of patients should we use that antidotes, palm or atropine or not. There are many questions, we'll just try to come upon the different things, but the important thing is in chemicals and industrial chemicals is the dose-response relationship. A way back this Paracelsus has told that the fundamental of the principle of toxicology, that all the substances are poisonous. There is none which is not a poison, but the right dose will differentiate. We all know the most important examples is alcohol. And I'll just touch upon the few of the important chemical events with their antidotes. It's not a new one. 19th century, the arsenic that has been used. Then there are many things been used in the World War also. Recently, the Syria that has been also attacked with the liquid sarin. That is what the highly, you can say, the hazardous OP compound. So maybe a blistering, pulmonary, cellular, nerve or incapacitance. So in that kind of situations, what should be the possibilities? Should we use this kind of blistering agents? There are many literature they suggested using of BAL, that BAL. That is again a question marks. So we'll just come to that. The various accidents due to these consequences are well known, but it gives a prominent actions or the cautions to prepare, practice the toxic disaster management plan. And in that we have to amend the antidotes chapter. Organizations worldwide have learned this importance of applying these principles of preventions and protections in a chemical disasters in a hard way. And we all know why I am telling in a hard way. Because we are just waiting, to happen some of the chemical disasters, and after that we just have to identify a few of the medications or the antidotes or any other things. So some of the worst disaster that may happen, and we have to understand that also. We know this Bhopal gas tragedy. And when they happen, we all know that was an intermediate being used, the worst disaster, many people died, and that time also, no one have got idea any kind of antidotes that was there with this kind of industry or not. We all know that how it happened, I'll not go into detail, but important thing is none of the safety system work, and importantly, complete absence of community awareness regarding this kind of chemical exposures. This was the situations. And that's why there are many lessons from this kind of disaster situations, that we have to reduce the inventory of this kind of material and proper antidote storage. Another very important example, if you can see the Flixenberg QK. In 1974, the company Nipro, and here the cyclohexane, if you can see this red one, that is one Craig reactor that was used, and after that, the plant operated about 2 months. Again, they collapsed and many people died. So the major chemical disasters that shape the public policies till now, there are many. If you can see the Triangle Factory fire, Minamata mercury, sivoxydioxine, Bhopal gas, Sriramolian, and there are also chemical terrorist events that may happen. Major toxic release. I am just sharing all these things because we have to understand the different antidotes after that. The phosgene, chlorine, dioxin, ammonia, sulfur dioxide, hydrogen sulfide, methyl isocyanide, methane, dimethyl ethyl, kerosene, propylene. These are on records till now the different kinds of toxic chemical leak that happen throughout the world. So now you have to ask ourselves, whether are we prepared for this kind of antidotes or not? Whether we are having a proper antidote banking at our industry? Because many times we know that we are having a different kinds of chemicals, and we are knowing that suppose methemoglobinemia forming agents, and we are requiring a methylene blue. So that methylene blue, how much methylene blue that should be there into the industry? What will be the stocking? Whether one person need a 1 ampule of methylene blue, and most of the time the OHC doctor, they require a 1 ampule of methylene blue. What about the stocking? If that will happen in a mass disaster, I still remember I managed one incident 100 kilometers away from Pune, where the 150 workers exposed to acetic anhydride. And we have only one hospital where the 2 ventilators available at that time. The 3 years back where the Maharashtra election was there. There's so many pressures from the politicians and so many other things we'll have to manage. But the important for the doctors to have how to manage this kind of mass casualties. So we have to ask ourselves, the OHC and the EHS people who are there here in the HR point of view also, that whether we are prepared for this kind of emergency situations with the proper antidote banking or the stocking. So there are many review of literatures been there. I'll not go into detail of where, but that is infrastructure, safety and environment, then review of alarm setting for the toxic gas. In total, if you can see, these are the most important 4 aspects of any chemical accidents: industrial, transportations, households and others. We have to understand the categories. We all know, we'll not go into detail of that, but major chemical exposures, if you're going to see, these 4 are the major ones, because I cannot finish in 20-25 minutes of all the chemicals, but these are the most important: the asphyxiants, cholinesterase inhibitors, respiratory tract irritants, corrosives and vesicants. We have to prepare for the on-site and off-site emergencies for this kind of the first responder requirements. Because many times we don't have got much idea whom to ask. Many times we are asking some of the other people that they don't have got much idea about this kind of antidotes or what will happen next. So we have to understand the first responders requirement, who can understand the signs, symptoms and trends and give you the guidelines that this antidote is going to be very important. Just one example, I can give you another example. I got a few patients at Hyderabad, and they've been exposed to acetonitrile. They exposed to acetonitrile early morning around 6 o'clock, and after that they've been admitted to the hospital. 4 people were there, and after that the doctors in the emergency medicine department, they have Google it, the acetonitrile exposures management, because they are not used to having this kind of exposures management in routine day-to-day practice. So from the Google they find it out the anti-cyanide kit should be used in acetonitrile exposures. But in Hyderabad, that pharma company which was an API, they were not able to find the anti-cyanide kit in entire Hyderabad. So almost after 24 hours they are not able to identify where to get this kind of kit, and the doctors have written the full protocols that how to use this anti-cyanide kit. The patients were into the hospital in the ICU, the patients were stable. Within a 24 hours, they are not able to identify, and almost in the night time, the president of that company called me and asked me, Tejas, I want this anti-cyanide kit, where to get it? Then I asked the history and the clinical situations. Next day early morning, I took a flight and went there to see the patients. The patients were all well. So that means we don't want to utilize this anti-cyanide kit to that patients. So we have to also understand that when to use this kind of important antidotes. If you are going to use because of this kind of antidotes unnecessarily, then also that will create a problem. I still remember I've seen one patient at Baroda way back, many years back, and he was a police constable and exposed to some of the cyanosis compound. And almost after 1 week I was called to see the patient in one of the multi-speciality hospital. When I see the patient was on ventilator, and the urine bag was containing so much of blood. The hematuria was there. So I was surprised at how that person have got this much of hematuria and this still on ventilator. The doctors diagnosed him very well that methemoglobinemia, but they have given 55 ampules of methylene blue. So that means that doctors have treated him with the methylene blue toxicity. Now I have to manage the methylene blue toxicity. So like that, we have to understand many things. I'll just touch upon the few of the aspects like asphyxiants, simple or the chemical asphyxiants. As I told you, that may be tissue hypoxia and the symptoms are not, that may be headache, dyspnea or altered mental status. Most important, the carbon monoxides and cyanides. These are the very important aspect to understand. Even nowadays, you know, during that winter seasons of time, we are getting many patients from the gas geyser poisoning that may contain this kind of carbon monoxide which is there inside the washroom or the bathroom, and the person was continuously exposed. Many industries where this kind of carbon monoxide is generated without unknowing facts, and that may be exposed to this kind of asphyxias. So important thing in hydrogen cyanide and cyanide salt, there are many review of literature been published, cyanide and hydrogen sulfides. So they have got very, very good in that cyanide intoxication as a part of smoke inhalations. I was there in International Fire Conference, and that is going to be very important aspect to understand from any of the fire exposures that may also have this cyanide intoxications. So we have to be very, very careful and very prepared from this kind of inhalation, smoke, toxic smoke inhalations point of view, which may contain the cyanides, and patients may have got a problem with this. So important, the antidotal, you can say the treatment for the cyanide poisoning, if you can see, I'll just touch upon the important. This is what this cyanide antidote kit. I think all of you may have seen or not, I don't know. But this is a cyanide antidote kit, which is very useful in a case of H2S, cyanide or toxic smoke inhalations where the cyanide is suspected. And this is going to be very, very important kit for as an antidote point of view, that, and importantly that this is the one or two of pharma company which is manufacturing on demand. So it is not available in a routine day-to-day medical stores. So you have to procure it for your, if you are suspected that your industry is prone to have this kind of cyanide exposures. So importantly that we are having this, if you can see here, we are having this amyl nitrate pearls, sodium nitrates and sodium thiosulfates. Important for this kit is that this amyl nitrate pearls can be utilized in a pre-hospital also. Before you admit the patient to the hospital, you have to break down this amyl nitrate pearls, put it in this cotton clothes or any plain handkerchief or anything, and put it in front of the nose of the patients. So he start inhaling this amyl nitrate till that reach to the hospital. Maybe the cyanide toxicity is little bit lower down. But many times we have to be very sure regarding the utilization, as I told you some of the examples of the cyanide antidote kit, when to use and when not to use. Recently we have got one incident happen in one pesticide industry where they have used this acetonitrile. Many people been exposed to acetonitrile, almost 10 people, and after that they have been taken to the OHC. Now see, they have this kind of anti-cyanide kit for a long period of time. Almost like since last 5 years they are having this anti-cyanide kit, but never used because never been exposed for this kind of activities. So the nursing staff was there and he was about to open this amyl nitrate pearls. So what he did, he opened up the cotton, removed the ampule. This is, if you can see the first one, open up the cotton, remove the ampule inside this plastic ampules, and he broken the ampules. During that broken of the ampules, some of the chemicals, amyl nitrate been poured, and that has been poured on his body also, and some of the things that he had started inhaling also. So he become the victim of amyl nitrate because that contain nitrates, so he may be the victim of methemoglobinemia. So we have to be very careful because that has to not be broken like that. That's why the cotton was poured on both the sides. You have to broken on in between. So proper training on the utilizations of the antidote is also very important, because at the time of emergencies, if you are not sure, then that will be a problematic. There are many respiratory tract irritants in the industries with the solubilities depends. That is like ammonia, formaldehyde, hydrogen chloride, sulfur dioxide, which is highly soluble, which will be only affecting our upper respiratory tract. So most commonly for this kind of chlorine or phosgene or nitrogen dioxide, which is more notorious, which may go into the lungs. So at that time we have to manage this kind of patients very symptomatically. There is no specific antidote for this kind of cases like chlorine toxicity or many other things. I'm not going to, but many a times we are also utilizing the steroids. So for making this kind of exposures, that depends on case to case based, but most commonly the steroids have got a very good results when the upper respiratory or the lower respiratory, the cases like phosgene that has been exposed. So there are many papers published in the ammonia and the anhydrous ammonia burns also. Accidental phosgene exposure, that is going to be very, very critical. And that time also, as I told you, the antibiotics, diuretics were questionable, but importantly the steroids, which can be very helpful. Corrosives, again acid base. I'll just touch upon the very important corrosives material, so will not waste the time. The hydrofluoric acid, HF. So many industries have been utilized this very important toxic chemical which is known as HF, or the hydrofluoric acids. So many times what will happen that many have been seen many patients with HF exposures, even a small quantity that has been poured on the body, that may damage your skin and they go into the systemic circulations, they damage your bones also. So what is the importance of this hydrofluoric acid? That fluoride ions have got an affinity for the calcium and magnesium in our body. So the calcium and magnesium will suck it out and the patients may have got hypocalcemia or hypomagnesemia. I have got one patient few months back, he had got a burns, the hydrofluoric acid exposures, and he was not knowing that he has been exposed. He went back and he has taken very lightly a few drops of the few ml of that drop on the hands of the person. He went back to the home and after that in the evening he was having severe neuropathic pain into the fingers. He went back to the OHC, asked the doctor that, doctor, I got a severe pain into my fingers, I don't know what happened wrong. The OHC doctor prescribed some of the analgesics. He went back to the home again. In the meantime, in the midnight, he had got some uneasiness. He again went back to the OHC. He was saying that I have got an uneasiness and what to do next. The doctors started taking the blood pressure and the ECG and all. They starting showing little bit arrhythmic changes at that time. So the calcium and magnesium, this both are low, and after that the doctor told me and called me. And nowadays as a toxicologist we have got a very tubular visions, because if you're going to call me and ask me, Tejas, I have got a fever, which are the toxins which can cause hyperpyrexia. So we have got, because there are many things must have to be ruled out. So like that in hydrofluoric acids there are many chemicals, like what we are having in one of the industries where I've been on board, we are having pyridine. So pyridine is such a hepatotoxic compound. So when we have gotten routine cases of pyridine exposures, that is, we have seen and managed the patients with the 8,000 of SGPT and SGOT. Can you believe that patient is about to go into the hepatic encephalopathy? And now after that we have defined that mucomix, the N-acetylcysteine, which is very hepatoprotective agents, can be utilized as an antidote. So we make it defined that N-acetylcysteine, but what dose that should be given, that we again a question mark. So we have started utilizing, like in paracetamol overdose, what we are giving an N-acetylcysteine, the same dose with any hepatotoxic chemicals that is utilized in the industry, we can use it, which is going to be very, very safe and very important. So like in hydrofluoric acid also, we have to be very important. Extensively many industries have been used. Important is severe neuropathic pain, muscle twitching, tetany, myocardial irritability, prolonged QT interval, and the potential for the torsades points. So what is the important thing for this? The calcium is the most important antidote for this kind of the hydrofluoric acid exposures. Many of the industry, they don't have this calcium gluconate gel. So if you can have this calcium gluconate gel, that will be very useful. You can use topically by making into the gel of 2.5% or undiluted the 10% inside the surgical gloves also. They may use the administered subcutaneously also. For the systemic fluoride, then we have the calcium gluconate to control the cardiac dysarrhythmias, hypocalcemia and hypomagnesemia. So that kind of calcium we must have to be there into this in our OHC point of view. Hydrocarbons and halogenated hydrocarbons again constrains a large number of chemicals. Aromatics, that may be a very important thing because highly flammable, gaseous, maybe as simple as frictions. Sensitize myocardium sometimes to the catecholamines also, so they cause CNS depressions, can lead to the coma, halogenated, mostly the hepatotoxic. Again, that's why I'm again telling you, whenever you are having this hepatotoxic, you can use N-acetylcysteine, which is going to be a very useful antidote for this kind of exposures also. So I'm not going to detail of this, all the hydrocarbons, but again, symptomatic, importantly that ensure the adequate ventilations and beta blocker for the ventricular irritability. Another very important aspect in industries and the chemicals point of view is methemoglobinemia. There are many chemicals which can cause cyanosis. And as I told you, many a times we are not able to understand that what to do in this kind of situations. So, and many a times the doctors have been treated this kind of patients and understanding doctor, you know, that we are having a low oxygen, but the patient is not having any complaint. We are having chronic low oxygen saturations, but we are not sure what to do in this kind of situations. We are not having a methylene blue. Many a times the doctors, I still remember, the doctors have utilized the amphion blue also, which has been used in the ophthalmic preparations. So many a times the doctors have utilized pathology that has been, you know, pathological methylene blue, which is used in the radiological dyes preparations. So the medical preparations methylene blue is available, so we must have to understand how to give. There are so many chemicals which can cause acute methemoglobinemia. We have to understand the nitrates, basically the anilines. Many a times that, you know, the drugs induce also methemoglobinemia. I got one patient recently who was diagnosed with the malaria, and he was taken this chloroquine and he went into this methemoglobinemia. So he was very much worried, and you know, he was admitted to the hospital and complaining of कि डॉक्टर मेरे वाइफ ने बोला है मेरा लिप्स ब्लू हो चुका है, and after that I was having little bit of breathlessness and admitted with this only, and the doctor were, you know, no hint about this kind of preparation. So he diagnosed maybe having congenital heart problem or something which may lead to this kind of problems, and after that was admitted in the ICU and investigated for many investigations, and he was not well to do family. So he told me, I don't want to go for, and after that I've been called to see this patient. We have given only 25 rupees of methylene blue and he was all right. He was having G6PD, and he was not G6PD deficient, but he was also having methemoglobin reductase enzyme deficiency. So again, that is a 5 lakhs to 1 patients may be having this kind of, and before giving this methylene blue, just kindly look after the G6PD status of the patients. If it is deficient, then we have to be very cautious while giving this methylene blue because it may lead to the hemolysis. So if it is acute methemoglobinemia, the methemoglobin level is there, then we can have methemoglobin level, and accordingly that you can treat the patients. Only 1 or 2 ampules maximum, not more than that. If you have still cyanosis and the patient is not recovering by giving 2 or maximum 3 ampules, and what I has advised, you can give direct intravenous push. Don't dilute into the 100 or 500 ml NS or something like that. You can push it very slowly, 10-15 minutes. The patients will be all right, maximum within a 6 hours of time. But
1 minute.
yeah. So only the thing that we have to consider. If it is cyanosis not recover, then you have to change your diagnosis. So that's why we have to understand that during the emergencies point of view, inform the employees about these toxic chemicals, training, MSDS, we all know. Pre-hospital use of antidotes, we can use some of the antidotes. The charcoal, if it is someone had ingested something, that is again a very good medical preparation charcoal. Nowadays that is available if someone had ingested, because in 108 we have put this activated charcoal in each and every 108. When I recommended, they were not ready to put this activated charcoal into the ambulance because that was, you know, designed by the US. So, and oximes, OP compounds, oximes and atropine, again a very good, we have to keep it. Ethylene glycol and methanol, that cyanide antidote kit as I told you. So that's it for the, you know, we have to prepare. Aware, alert and alive. Don't buy or store the chemicals that you don't need. Store the chemicals in the original containers, because many times the mix up and that will lead to the problems. Appropriate safety gear. Dispose the chemicals safely. And this is what the recommendations: atropine for OP, calcium gluconate for hydrofluoric, cyanide, methylene blue, and all the oxygens and all. So that's what Thank you so much. Of any questions that I can take it right now? And this is also the talk screen what I started. If you have any kind of toxicological monitoring point of view from the biological, and this is going to be very important for the services what we are going to offering to the many industries now, the blood and urine metabolites or the specialized test like urine phenol, methemoglobin, cholinesterase, and many other testing. Yeah, thank you.
Thank you very much, Dr. Prajapati. It was a very splendid presentation, and a lot of audience also noted out. Thank you very much.
I thank Dr. Tejas Prajapati for delivering lecture at IOH. He is came right from Ahmedabad to deliver the lecture. Now I request Chair to hand a memento to Dr. Tejas. I would request Dr. Sujata, Scientific Chairperson, to hand memento to our chairpersons. Thank you, sir. We will have a bio break for 5 minutes.
Please come back within 5 minutes because we have a very distinguished speaker, Dr. R. Rajesh, coming in within a short while. Thank you.
Welcome back all. Now we are going to start the next session. So I would call upon Dr. Shirish Kumar Gandhi sir and Dr. Rakshit Akrowala to chair and co-chair the next session. Dr. Shirish Kumar Gandhi has more than 30 years of rich experience in clinical as well as occupational medicine, and currently he is Chief Medical Officer at Reliance Vadodara. Dr. Rakshit has 20 plus years of experience in various aspects of medicine, and he is occupational health physician working in Vadodara as well as Panchmahal district. Now I hand over the session to our chairs. Thank you.
Good morning, everyone. I am immensely pleased to have an opportunity to introduce a distinguished speaker, the legendary and the laureate of occupational health, who has received so many awards and accolades, who is working as the Group Chief Medical Officer and the Group Medical Advisor at Reliance Industries Limited, and is associated with Reliance since 1996. Having 30 plus years experience in the public health and the occupational health. He himself is a qualified public health specialist, MD in PSM. And if I try to narrate and describe his personal achievements, I think I will take more time than his own speech. But to mention a few, Dr. Rajesh, he is Dr. R. Rajesh, and he has been invited as a speaker at many international and national conferences. And the Reliance Industries Limited has won several recognitions and awards at international and national level under his guidance and leadership. He has been invited for very prestigious orations at national conferences like ADM oration, CKR oration, and many more. He has got Reliance Industries Limited many prestigious awards like Healthy Workplace Award and Healthy and Arogya Award. Then he is also associated with International SOS, and he has represented India as the India Secretary with International Commission of Occupational Health, ICO, and has many more achievements and accomplishments he has bagged in his career. Cutting short the time, I present before you Dr. R. Rajesh to start his oration. Sir, you have 25 minutes to go, and your time starts now. Thank you.
Okay. Good morning. After break of tea and bio break, good morning. Yeah, that's great. That's the younger generation loud. Thanks to chairpersons for their kind words and kind introduction, but thanks to Baroda branch and for especially giving me this oration of Baroda Ghosh oration. As such, as Jamnagar branch, where Jamnagar I worked and I started the branch, and Mumbai I stays there, so it is my Mumbaikar now. But Vadodara is my affection, and my brother family stays here. And Vadodara I am having a very good friends, Saxena ji, Jain Saab, Kamath, and everyone there. They are my good friends. And they are the occupational health, what yesterday minister also told, they are the greats of occupational health. So that's the thing. But coming to, before going to my whole presentation, I don't want to take too much of time, but where the world is going on. See, in younger generation, I'll in whole occupational health, there are few things most important. And world is changing towards the wellness. You must have seen many industries are now, they are taking, not CMOs, they are taking now chief health officer, chief wellness officer. CMO is word now not like that good, chief wealth officer. So world is going for toward wellness, and we have to think next few years for whole globally wellness is the one of the key. Nothing else will work. And second and most important thing, you may be a very, very good occupational health expert, but you should be a good clinician first. You are all industry doctors. I'll tell you one thing. You may be doing many wellness works. You may be doing many occupational health projects. But when one employee comes and you misdiagnose a case of anything, cancer or anything, the whole family suffers. To keep in the mind, whatever the organization, the first thing starts with the curative health. And that is the most important. You should be a good clinical physician, then you can become a good occupational health expert. So with these lines, my presentation will be very, very brief. But before starting, I have 3 questions to ask you, and I will ask any 3. 2 years gone, COVID is still somewhere there. And who says totally COVID has gone? No boss. I still tell you last week my one case. Mostly we have treated more than 90,000 cases. And last week case, fully vaccinated with the booster dose and everything. Fully vaccinated. All protection. Got the virus. Every doctor thinks like, cough, cold, and home isolation. Do the things. On the 5th day, he got a high-grade fever. We got an HRCT test done immediately. His total lung was ignored. So still the clinician, keep in mind, when you are treating a COVID patient or any patient, still swine flu is coming up. In Bombay, it's already started. And we have a few critical swine flu patients also. So keep in mind, when you are treating any case, you have to be very, very careful. COVID has not gone. COVID is still there, and you have to take all precautions, and especially those who are having comorbid conditions. Still, you have to be safe rather than anything getting the danger, the things. Now, coming to the post-COVID, what is important? Post-COVID is wellness, work-life balance, mental health. That is the important thing. The first question was, during COVID, we was having a fear. What happens to me if I got affected? Is that fear has gone or still it is there? That COVID fear still has gone or some fear is there? Anyone can say yes or no? Yes, sir? Yes, still fear is there. The next question, what we are finding globally is that 2 years, everyone was working from more or less from home. Now coming back to offices. Still they feel better to work from home, not to come to office. What do you feel? Still that challenge is there or not? Challenge is still there to bring back to office. And third and most important thing, your own health in whose hands? Your own health in whose hands? So, own my health. I am responsible for my own health. Nobody else is responsible. No organization is responsible. It's as fact as. Organization will support you. Organization will give everything. But each one of you have responsibility of your own health. Yes or no? Yes. That's the thing. So now younger generation, 2 challenges which you are going to face in next few years. We are already having now bald and everything. and we are only mentors. And we are already torturers. Okay, you take the advice, but follow your own instinct, what you feel best. You are having a great intelligence. Use your own intelligence, do your best what you can do. You can have some advices, but follow what you think it is a global best, not the Reliance best, not the any other organization best. Follow what is the global best. This is a competitive market. With these few words, very few presentations. During COVID, you all know what happened. Lockdown, quarantine, loneliness, inactivity, social distancing, all these things took place. Yeah. What happened? 53% of working women and 29% of men have experienced increase in anxiety since February 2020. What is the stress? Most important, I will tell you, is the financial. It's a real stress. Second, job related. Third, relationship stress has come out. That is the most important. And fourth is health and others. What McKinsey company says? Today's consumer views wellness across 6 dimensions. 1, better health. Better health means now various devices are available where you can track, monitor your health. Fitness, you should be fit. Fitness is the criteria. I was joking little comment. The obesity is gradually increasing up and conference chair sizes are reducing. So we are finding it difficult to either chair size has to increase or we have to reduce our weight. Nutrition, diet is one of the important things. Better appearance, yes. Everyone looks better. That's the most important. Better sleep, yes. We all know 7 to 8 hours sleep is the one of the most important thing. And better mindfulness. Yoga, meditation, better mind, silent and everything. These things are more important in the thing. And I'm seeing the conference chairman, secretary is keeping a silence since yesterday, having a crowd of 350. But still they are managing silently very well everything. That's the thing. Now, before COVID, this was the, we were meeting and we are doing everything. These were the thing. Now, I am going to present few things which were important during COVID and post-COVID, how we responded, what is the whole wellness programs and what is employee engagement and diversity. So, again, we are meeting again and I am happy to see the good crowd here, 350 crowds, that's a fantastic. And physically meeting and meeting all of you is a great challenge. We are working on the 5 dimensions, physical, mental, social and financial and spiritual well-being. Now, physical, we are going to like physical health, which is most important, physical fitness, which is the second thing, and other measures, vaccination and other things. Mental health, all the mental related things which are having a strategic program on the mental health. Then financial, yes, this is with the HR, any financial thing, financial learning and everything. And for your all point advice, during COVID, what I did, you know, I spent something on the financial markets to learn and take a certificate of financial learnings. At least as a doctor, I was not knowing what is happening in the financial world, but now I come to know something is happening in the financial things also. So financial things generally we don't know. And recent, I will tell you my knowledge always. Demat accounts. We keep a accounts nominee in the bank account. We don't keep a demat account nominee because we trust a bank will do it. But no, you have to nominate for the demat accounts also. Otherwise, it will be a problem. Now, coming to the spiritual, yoga and meditation. Now coming to the COVID. Yes, March 2020, I came back from the Bangalore before that. Then suddenly the whole things were started and we thought what to be done. So we thought, what is the most important is risk reduction. First important, reduce the risk. So we decided one thing, manufacturing location will operate 24/7, but office location will close down and will come. But in manufacturing location, those who are having morbid condition like diabetes, blood pressure, age above 60, multiple risk factors, they will work from home until unless it's really needed. So let them work from, or let's reduce the risk as far as possible for exposure risk. Second, okay, we have reduced the risk, but most important, the mass communication. How to make the employees aware that something is happening in the world and we have to be aware of that. And most important was the infrastructure. We were knowing something is going to come and terribly going to be happen. How whole, because we have a population of 15 lakhs across India. Not 1 lakh, 2 lakh, 15 lakhs. Where they will go? Where they will, at manufacturing location we were comfortable. Because doctors is there, team is there, at rest of India location also we have doctors, but we don't have hospitals. We have created our own infrastructure rather than relying on external centers. We created a 1600 beds, 1600 beds across our own centers of COVID care where we can manage mild to moderate case. Then we recruited 600 doctors. We recruited paramedics, everything. Infrastructure creation, that was one of the important things, and that has helped us, and it is going to help us in the future also. Then communication, then medical assurance. Whole employees and family members wanted assurance that was there to tell the employees and family members, you don't worry, we are there to take care of you, and even if you need an airlifting from anywhere to Bombay or anywhere, we are there to take care of you. That assurance was there. Then finally, consultation for digital and vaccination for employees and family members. Now this was the first thing which we do. Second thing, like symptom checker, which was recognized at the global level. Our systems made wherever an employee and family members get some system, daily symptom monitoring. All employees were responsible to maintain a symptom checker into daily. If somebody develops some symptoms, it should be already flagged by, okay, this employee or family members having a symptoms, let them manage. One, that is the one thing. And testing, we have not depended upon external testing. Our Reliance Life Sciences created a labs to create the testing centers at Bombay and bring the samples to Bombay to get it tested. And we collaborated with some laboratory like SRL and other thing, but most of the Reliance Life Sciences has done it. Now, new normal is, like yesterday the Dr. Vijay was telling, Vijay President, when he went to our plant, weekly testing protocol still exists. I came to Baroda, but before landing, I got tested there. And before entering my guest house, they tested me again. That exists. So weekly testing protocol exists, green pass exists. If you are not fully vaccinated, you are fully vaccinated, you have RT-PCR negative, you don't have symptom, only your pass will be valid to go in, otherwise, that's the thing. So these are the mechanism which we do need, these are the beds and other things which I already talked, yes. At Bombay, then responsibility as a social responsibility, 7 Hills Hospital, we make all the things for 600 beds COVID care centers. And at Jamnagar, at Nagathane, we have created separate beds for the COVID patients. SMS marking and travel advisor, this all industries have done. Assurance. COVID vaccination, yes. We created a vaccination, and I'm thankful to the government. Why I will say one thing. Government was so proactive. When I reached them, sir, my OHC, please give vaccination permission. Within a 1 day, they gave, okay, your vaccination COVID portal will come. Don't worry. That's the way government has responded. That's the fantastic, huh? And roughly around all employees are fully vaccinated with the booster dose wherever the need is there. Now, this was a thing, geo-health and other application. There was always digital technology is the most important to keep a dashboard and monitoring. Now, what is the wellness? Wellness, what I told you, on the 5 pillars, physical, mental, social, financial, and spiritual. This preventive, curative, and promotive aspect, not only the physical, but emotional, mental, and spiritual. Coming to physical well-being, awareness, having a specialized programs. Now we, apart from all other programs which you learned in many years, now across organization, we are focusing on one program, that is diabetes, which is going to be a challenge in next 3-4 years. Total diabetes management through digital tracking, digital total systems, and with all the things. That's we are coming out totally. So that's way the focus programs for the well-being important. Yes, mental well-being. This is the one of the most important aspects. And why my mental health? I will tell you how it takes in yesterday. I am very happy when I entered. There was a smiling face on the organizing committee. Somebody came to me, met me, and they took me here. Ah, my God, so much good and so much good planning. So they have taken care of all the mental health. It's like comfort zone which they have created. But mental health most important is counseling, and that is the training of all employees who are the managers. Who are the managers of employee? They should be trained properly to counsel to their employees who are working with him, because he is the first person to come to know if any employee is developing any mental science symptoms. Then he needs a further psychological counseling and other things. So, empathy, positive relationship, sense of purpose, rewards and recognition. If somebody is really doing, so we have a total guidelines for that. Education, everyone should aware what are the mental health sign symptoms, what is the capability of manager has to be developed, and mental health first aiders. Already we are developing across organization. At each location, the mental health first aider, they will respond immediately if somebody is having some problem. Yes, we have an external agency also, Silver Oak, which we have collaborated for 24/7, helping for the mental health. Now, some new names have come, Reaching Dil Se. Some programs we have given Reaching Dil Se to more motivate the employees to come to our program. And female employees, women's, they are the most important aspect in the organization. So that's the most important, where we take care of proper things on campus, self-defense workshop, and infrastructure and other things. This is the one thing. During COVID, we were knowing that they are working from the home. How can they coordinate? We had an employee check-in surveys, online check-in surveys employee, to tell them what are the issues, my voice, what they can give it something, how the feedback of services and everything. This is the my voice which we did it. Finally, what happens after 2.5 years? Our feedback was all employees and family members are so good, happy that what we have done is the one of the best. Nobody can do it in that way up to that. So lowest rate in the COVID, infection rate was very less, holistic well-being, and more than 2 million employees and family members are vaccinated, business continuity and performance, and program management, executive effective employment engagement. So that's the most important. Now, what is the new normal, which everyone should aware? One, healthcare is changing. Dr. Munish, I know him very, very well, but he has to also change, because telehealth is becoming now one thing. So, new normal is widespread use of virtual care. Suppose he has treated a burns patient who came from the Assam, and he has managed it here, but follow-up, he wants to do a follow-up, he need not to call that patient to here, he has to use the telehealth, where he can work. Telehealth is one of the things, and most important thing, at least, all the business community, government has learned one thing, we have to invest in healthcare. Otherwise, OHC was like, is the last center. कुछ पैसा खर्चा करने का है तो, और पहले तो सोचेगा उसमें से मिलता है क्या, मेरे को कुछ मिलता नहीं है उसमें से. So now the government and everything understands, invest in infrastructure healthcare. Now when government and industry is thinking, invest in infrastructure healthcare, doctors, you are young, you have to go to the management. Sir, we have to create this thing. Sir, we have to do this thing. They will not come to you, doctor, what you want? You have to go to them. Sir, I want this thing. This is the needed here. That's the thing which you can do now, because the market is open, one, competitive, and second, at least post-COVID, one thing is helpful, they are going to listen now. Yes, this is one of the important things. That has come. And more recognition of healthcare participation, modern. Yes, healthcare personnel should be more recognized across. That is the most important. The new normal lifestyle and safety. Now, I hope I'm having some 5 minutes. Yes, thanks. I'm having a video also, so I will cover that also. First is, I still say, follow appropriate COVID behavior as per need. I have seen hospitals, I am telling you, patients operated day 1, next day, the consultant has come positive. And fourth day patient has come positive. So I have seen the things, and I am telling you, take appropriate COVID behavior still. Mask, yes, a mask is for your own safety. Now you think that way. And I am the person, I really tell you, I was surprised. In 2 years' time, my team knows I always had a mask outgoing, and I traveled a lot. But one day, I just coming inside my car at Chembur, so was so strict, Dakar knows. I would just bring my mask down, they stopped my vehicle. Police fellow, sir. I said, what? I said, mask to hai. Bole, no sir. They charged me 200 rupees. That day I realized, boss, ki after giving 200, I realized mask you have to put it properly and proper way and proper use to use that way. And do early reporting of symptoms. Any early symptoms of fever, cough, cold, or anything, don't neglect it. Just have a keep monitoring and that thing. And do regular physical activity, that is the most important. And yoga, meditation, yes. Eat healthy and good food. In Gujarat, I always say, enjoy one mango. Don't enjoy excess mangoes. Enjoy one gulab jamun. Don't enjoy excess your gulab jamuns. So enjoy one samosa. Don't enjoy too many small samosa which are there. So enjoy in the balanced way. Don't do anything excess which is not good for you. And stay hydrated throughout the day. That is the most important. And at least sleep 8 hours a day.
So
everyone tells
we have
sleep.
1 minute to go.
Yeah. And be in touch with family and friends. Now, one most important thing is, we are young guys, move out of your comfort zone. You can only grow if you are willing to feel awkward and uncomfortable when you try something new. This is my last week, morning walk. I was enjoying my morning walk. And I am thankful to all doctors, all my team members, all HR guys and all safety guys for doing excellent job in COVID. Salute to them. They have done a wonderful job. Give them a big hand. I'm having with permission 2 minutes video only. A small
Yes, sir, please.
कर दे लगा लूं उनको मैं मां। तुझ पे आँच न आए तू हरदम मुस्काए, कर दूंगा मैं कुर्बान खुद को ऐ मां। तेरे आंसू मैं चुरा लूं, पलकों पे मैं सजा लूं, झुकने न देंगे सर कभी तेरा। जीता रहे मेरा इंडिया, जीता रहे मेरा इंडिया, जीता रहे मेरा इंडिया, जीता रहे मेरा इंडिया। जिस मिट्टी पे जन्मा उस मिट्टी पे मरना, हमने तो है सीखा ऐ मेरी माँ। तेरी सारी दरारें हाथों से भर देंगे, कुछ भी होने न देंगे तुझको ऐ माँ। तेरे गम हम संभाले, तुझे सीने से लगा ले, झुकने न देंगे सर कभी तेरा। जीता रहे मेरा इंडिया, जीता रहे मेरा इंडिया, जीता रहे मेरा इंडिया, जीता रहे मेरा इंडिया।
Excellent support to the nation in the tough time by Reliance. Dr. Rajesh, you have blessed us with wonderful insights towards the mental well-being. Even during the tough time, I'm sure many of us will have those insights where they can improve or they can initiate, they can experiment with themselves. Thank you very much, sir.
Thank you. Thank you.
You are the corporate doctor. In present scenario, the cases are increasing. Little bit case increasing, someday it increase, someday it fall down. So, what is your opinion for industrial physicians? What to do at present scenario?
Okay.
We know okay, all three vaccines had been given by the corporate office, by the doctors and anywhere. So what is your suggestion in this era of present situation? Yes. What we can do?
Thanks. Actually my HR is also behind me. I'm very frank. Rajesh, when you are stopping weekly protocols. Yeah, this is on. First thing, see, whatever you do, one thing, see that vaccination totally complete, employees and family members. That is the most important where you have to push it. Otherwise, it is practically impossible. Vaccination, you have to push it. What I am seeing in last 6 months, I am telling you very frankly, even my own family members, I know, employees. Boss, अभी कुछ नहीं है, अभी जो कोविड हो रहा है ना, वो साइन सिम्टम्स भी ज्यादा नहीं है, एडमिशन की जरूरत नहीं पड़ती, तो वैक्सीनेशन छोड़ सकते हैं. Don't. That is one thing. And second thing, you don't know swine flu how it's going to spread across India. I'm very frank. One thing, so what I want to say, if old age and those who are suspected, those who are comorbid, give the swine flu vaccine also. That is two. Third, now COVID protocols. Weekly testing protocol, as we have a stringent insight, that's why only thing, otherwise there is no need of testing weekly. Only testing to be done when we are having a symptoms. If somebody is having a cough, cold, fever, you cannot say, you have to isolate them. You have a separate fever OPD. You run the separate fever OPD. If somebody is having a fever or some sign symptoms, get a testing done. That is the fourth. And if it's tested positive, isolate and treat as a protocol. If negative, okay, you are okay with that. But with him, those who have close contact with him in last 3-4 days, you have to separate them. Because at present, more or less isolation is 7 days. Everybody is recovering in 5 to 7 days. And at site level, at manufacturing level, what you can do? A proper spacing, one, and mask. If suppose you are meeting many guys, many persons in the meeting, then you wear the mask. But if you are sitting inside the office, there is no need to mask. That is one. If somebody is having a diabetes, somebody is having a blood pressure, somebody is having operated, they should take their own safety first. That is the minimum guidelines which I can say.
Thank you very much, sir.
Yeah. Sure. May I request you please tell your name and industry? So at least we can be good friends.
અત્યારે મારી બાજુમાં જે કામ કરે છે એ ફૂલી વેક્સિનેટેડ છે છતાં પણ એ કોરોના થઈ ગયો છે તો એવું કઈ રીતે સંભવ છે?
જો no word is taking if you are 100% vaccinated, 3 doses vaccinated, you are totally 100% safe. Nobody is telling that. Keep in mind. But if you are vaccinated, you are 70 to 80% safe. Means તમે 70 થી 80% safe છો. તો अगर वैक्सीन नहीं लेसो तो कदाचित 10 થી 20% सेफ રહેશો. वैक्सीन लेसो तो 70 થી 80%, तो भी 10 થી 20% છે જેના થઈ શકે.
ઓકે, થેન્ક યુ.
Now I would invite our chairs to present a memento to Dr. Rajesh sir. And I also call upon Dr. Milan Thakkar, our secretary, organizing secretary, for further.
Let us all thank him for his time.
Oh, no.
Thank you.
Thank you.
So now is the time to present the prestigious IOH Vadodara Vosh oration to Dr. R. Rajesh sir, Group Medical Advisor, Reliance Industries Limited. IOH Vadodara is pleased to have you on stage, sir, today. You came all the way from Mumbai, giving your precious time, and I will like to invite our key persons, Dr. P.C. Jain sir, Chairman GUJCON-2022, Dr. Saxena sir, President IOH Vadodara, and Dr. Kishore Parikh sir, National Joint Secretary IOH Headquarters, to please present the Vosh Oration Award to Dr. R. Rajesh sir. And I will request a standing ovation from all of you and a lot of claps to our Oration Award speaker, Dr. R. Rajesh sir.
Oh, thank you, sir. Thank you. Yeah. Yeah, don't worry. Thank you. Thank you, sir. Thank you. Thank you. Nice of you.
Thank you all delegates and our team.
Thank you.
Thank you, Dr. R. Rajesh sir, for your kind attendance and taking the award from IOH Vadodara. We are so kind to you, sir.
I have done justice.
So the next session we are going to have for the intensive trauma unit. Trauma is one of the leading cause of life loss as well as disabilities and limb loss. In the time where minutes meet the muscle is a concept, we need to have a
very good. You can take
state of art kind of an intensive trauma units and an excellent team which works in course manner to prevent life loss as well as the limb loss disabilities. So from Team Bhailal Amin, we have Dr. Girish Hirode, Dr. Nimesh Patel and Dr. Sagar together as a team to present us how to take up intensive trauma unit, a case of trauma to prevent life loss or the disability. Dr. Girish Hirode, sir.
Yes, thank you.
Thank you, organizers. Firstly, it's my privilege to address such an august gathering and my misfortune to follow a speaker like Dr. Rajesh. So first I'll give you 5 seconds to cool down a little bit, okay? You have gone up there, now you're going to listen. He is a man who's controlling 15 lakh people. I am a mere surgeon in a 300-bedded hospital or a 200-bedded hospital. So please bring your expectations a little down. I'm not saying, but please bring your expectations a little down. Thank you very much. Yes. So I was asked to speak on management of injuries. What I'm going to do is present a case and take you through a person who came in the morning to work as a normal person and then his life went topsy-turvy literally, and how we at Bhailal Amin managed to take him through the journey and hopefully bring him back to fruitful life. So that is my purpose here. I've been given 8 minutes, so I've omitted all the videos because that takes a little time. You'll forgive me for that. Thank you. So firstly, there was a 42-year-old man who fell from a height of 30 feet. It was a scaffolding. They were actually building a new unit, so strictly it's not an industrial accident. But he fell down, and since there were no medical officers, they just put him in a rickshaw and brought him to Bhailal Amin General Hospital Emergency Department. Now, just to help you through, I was hoping to go through this in more detail, but 8 minutes doesn't give me too much time. So first of all, we do primary evaluation. So airway. What is airway? Airway is the physical path of the breath. So that has to be clear. So from the mouth, the throat, the trachea and the bronchi. So all the way to the lungs, the airway, the physical path has to be clear. Breathing, which means the act of breathing, which could be from the central part or it could be compromised because there's a pneumothorax, fractured ribs, hemothorax, any such thing. So his breathing was labored and air entry was decreased on the left side. There was some hypotension, not very alarming, but as soon as we gave him fast IV fluids, he responded. So these are the first. Obviously, if you're at the factory, then you add 2 more, decubitus and evacuation. Decubitus means in which position are you going to evacuate him, and evacuation is how you're going to evacuate him. So that, of course, will be a separate lecture at a different time. So what did we do? We kept the airway clear with a nasopharyngeal tube. When in an emergency and you find that the breathing is labored, it's okay to put an ICD even without having clear proof whether there is pneumo or hemothorax. So you put an ICD, which obviously evacuated about 350 ml of blood, and we started giving IV fluids fast in order to maintain his blood pressure. Secondary evaluation is once he's become hemodynamically stable, you again look at him that, okay, I've managed his airway, I've managed his breathing, I've managed his circulation. Now what is the second thing? Now does he have any injuries which require attention, immediate attention in terms of an emergency? Patient was unconscious, so obviously he had a bad head injury. He had multiple fractures on the left wrist side.
Air entry had slightly improved, not so much that I expected, and there was guarding on the left upper abdomen. All the routine investigations were set. So we have a protocol where we send CBC, electrolytes, creatinine, RBS, HbA1c, serum TSH, all these things to find out any disease that he might harbor, because in these cases sometimes we don't get the medical history as to what his past history is and everything. So it's a good thing to get everything tested. And now, earlier we used to go take the X-ray chest, take the X-ray pelvis, take this, take that. But now we have a trauma protocol CT scan, which unfortunately is a video, so I can't run it here. But basically what it does is take a plain CT scan from the vertex down to the pelvis. Now it's a screening test. So it almost immediately tells you what's happening in the head, in the cervical spine, in the chest, in the abdomen, and in the pelvis. So it's a very good screening test that we follow. And what did we find? Yes, in the abdomen. Now, since I'm a surgeon, I'm going to limit myself to my brief. That is, I'm going to talk about his problems in the chest and the abdomen. By no means am I saying that those are the only injuries he had. He had a bad head injury, which was treated by a very efficient neurosurgeon. He had bad fractures, which was treated by an orthopedic team. So, but since they will be covering their part, right now I'm only covering what I did in this, because I have 8 minutes. I'll keep referring to that 8 minutes a little bit. But anyway, so what was the first thing? On CT abdomen, we form a splenic rupture. Why have I focused on the abdomen when there was already a chest injury? Because I think the chest injury was not life-threatening at that point of time. It was the splenic injury which was life-threatening. One thing about splenic injuries, don't read Western textbooks and apply it to Indian patients. Spleen is almost marginally enlarged or friable in most Indian patients because we have chronic malaria here, we have so many infections here. So in America, in England, when I went as an observer, they would treat grade 1 and grade 2 splenic injuries conservatively. कि चलो कुछ नहीं होगा, छोड़ दो उनको, 2-3 दिन रखो, घर भेज दो. In India, you come back, you think, oh, I'm now foreign returned, I have to apply these sciences. Grade 1, grade 2, रखो 2 दिन, बहुत अच्छा है, stable है, घर भेज दो. 7-day patient comes back in shock. I was wondering why this was happening, mainly because our spleens are very friable. They can't hold themselves together. Sooner or later, they're going to rupture, they're going to start bleeding, and he'll be in shock where he can't be treated properly. So, splenic rupture is one thing which you should go ahead and remove most of the times. Very rarely, if it's just capsular tear, we treat it conservatively. So, and this was the state of the chest. Left-sided, you can see there's still a lot of hemothorax, but we put a tube, and he was maintaining his oxygenation, so we weren't too worried about that. So what do we do now? Nowadays, if the patient is stable, we don't open the abdomen as far as possible. We go ahead and do a laparoscopy. Why is laparoscopy more important? Number one, obviously, it obviates a big incision. When there's no big incision, then the patient is in less pain. His respiratory problems are less because he'll take deep breaths, as and when he becomes conscious. Whereas if you have a huge incision, the pain of the incision limits his breathing capacity and usually leads to chest complications. So you do it only if the patient is stable, but if he's stable, then we can, the main advantage is you go in through small holes, and if there is no other injury, then we can actually retransfuse the blood that the spleen has spilled back to the patient. Of course, there's a technique which is slightly this thing. So we make these holes, go in. Now this photo is like this here, there's a disclaimer. This is for this thing only. This is not the actual photo of that patient, because that patient's photo looked more like this. Okay.
So you have 1 more minute to go.
Okay,
Please.
sure.
Thank you.
So it was full of blood. And then initially in the chest injury part, the ICD worked well with time, but then collections kept appearing and you can't keep fitting tubes one after the other. So it was like this on the 14th day. You can see the tube down there. So what we do now is we do a thoracoscopy, which has 4 advantages. It drains the fluids, converts the entire pleural cavity into one compartment. So if there are compartments, loculated collections, we can convert it into one. Active bleeding can actually be visualized and we can stop it, controlled. And tubes can be placed wherever we want to, under vision. So all these four things, so this is how a thoracoscopy is done. There are 3 or 4 holes through which we go. And this is how we aspirate blood from there. And this is how we looked at the time of discharge. You can see there is a small pleural at the corner, but that's okay, we accept that. So patient eventually stayed for a month and a half, out of which 1 month was in the ICU, but he eventually went home. But his point was well taken. He never came back for follow-up. He was one of the tribals who the contractor was paying, so he went back to his village, and much as we tried, we could not contact him, and we don't know what. So we presume he is good. No news is good news. So I think it's very point well taken that even after all this internet, we still lose patients to follow. Thank you. I hope that was short and sweet.
Excellent, sir. Excellent state of artwork which has been displayed with uttermost knowledge sharing. Thank you very much, sir. And I would like Dr. Nimesh Patel further to take the session ahead with the
Good afternoon, everybody. Thank you, Chairperson and IOH Vadodara for giving us this opportunity. Now, I was in the impression of 15 minutes, but eventually I came to know that I have to present for 8 minutes. So this presentation was made in such a way. So in between, I'll be skipping the slides. Initially, our topic was basically a primary management at the industrial health and industrial injury. I believe the role of neurosurgeon comes quite later. So, my role predominantly starts after the patient come to our place. As Dr. Hirode mentioned, we have a very well-equipped trauma center and very good infrastructure to manage any trauma or industrial health injury patient. Rather than going too much in, I'm sorry. So I hope I'll get 2 extra minutes. Slide changing is this only. Anaditization. Okay. Now we all know head injury and spine injury is one of the major disastrous issue after probably the cancer and myocardial infarction. And it's a big challenge even in the present scenario. Whatever advances we do in medical sciences, we lose a lot of life and a lot of morbidity, especially in the young generation because of that. I'm not going in detail of too much of the guidelines. You all have the guidelines in the industrial side also. We have guidelines on the management side also. I will just try to give a little brief what is a link between the injury site and patient reach, between the injury site and a neurosurgeon, where you can play a significant role, because as the previous speaker, Dr. Rajesh mentioned, missing a single thing can lead to disaster, and it will be a disaster to family also. So whenever you have injury at on-site, always evaluate patient thoroughly, even if patient is conscious. Try to examine him from head to toe, because a slightest of issue can raise the alarming point and you will be able to manage in a better way. So, most of the trauma, ABC, mechanism of history is important. Now, as a neurosurgeon, I always insist all our medical officer also into the hospital, and I always insist at the industrial site also, whosoever is managing, try to learn the GC skill, because that is one of the major important point to communicate with the next specialist. And that will give the gravity of injury, and that is how at the trauma center people can be prepared. Pattern of injury is very, very important. Primary injuries when somebody has fallen down on the industry, either a CLW or a direct fracture. But generally, the issue happens with a secondary injury. Patient might be conscious at your side, but by the time he's been transferred to us, he might be unconscious, and that is where you have a lot of things which comes in pictures, which we consider as a secondary injury. So there are so many things which you also would have come across at the industry level: direct fracture trauma, blood loss, whiplash injuries, spine injuries. Now, why we are very, very cautious when we are attending the patient of trauma and head injury? As you all know, there is a specific component of brain, blood and CSF in the skull. It's a closed cavity. So whenever any extra thing happens into the brain, it will lead to increase in the intracranial pressure, and that is the biggest problem, and that can lead to all kind of herniations. I'm not going into much of mechanism of herniations, but that is a grievous sign when you have a herniation of brain. So you have to act fast, clock is ticking kind of situation. So I always insist, and I urge all of you who are managing the industrial trauma, at least to have a little understanding and a knowledge of the Glasgow-Coma scale, because that is very, very important in communicating, and it will give us the idea how bad is the injury. I'm not going into too much detail of the theory part of the same. See, the second most thing, I always ask our doctors also, whoever is managing a trauma, to check for the pupil. So whenever you are seeing or attending any industrial health patient on site, first thing you always look is for the Glasgow-Coma scale. That is basically for the level of consciousness. Second is pupillary examination. Any change in the pupil or any difference in the size of two pupil will indicate that there is a significant intracranial injury. Sometimes you might have extradural hematoma. Patient might be conscious, but there might be difference in the pupillary size. So you cannot take it lightly when you have such ominous signs on the examination. So always check for the external signs. Whenever you see this kind of signs, always imagine that there might be an internal injury. So don't delay further transfer and management of the patient or investigating the patients. As I mentioned, pupillary changes, decrease in the consciousness level. So whenever you see a patient, always manage as if they have any kind of spine injury. So always support the neck, all the spine, never ever try to kind of, shift patient without any proper support of the spine. Once they come to us, it's our job basically to evaluate with the scans and x-rays, and if require, MRI. So this is all a pure medical management. I'm not going into much of detail of that. So whenever we do any kind of emergency surgery in head injury, it's more of a damage control and a life-saving procedure. We cannot guarantee what is going to happen next. Most of the patients ask us, ki saru to thai jase nahi, and that's the most difficult question to answer at that point of time. I'm just going to present few interesting cases. 42-year-old male came to us. It's an industrial trauma, basically, pure head injury. GCS was E1, M3, V1 with pupillary changes. Now, one of the relative in a family was a doctor. So if you see this scan, these are not routine subdural hematoma, extradural hematoma, which you will easily can say ki ha, isme surgery ki zarurat hai. No. This is more of a significant cerebral edema and a little bit of contusions. But closely, if you see, there is a uncal herniation actually. I mean, on a neuro side, we can appreciate it more. Hence, he was going down. So he required emergency decompressive craniectomy. The time is the most important thing in all this trauma. We preserve the bone flap at a particular minus degree. At bilalamine, we have that facility. The other scan is the immediate post-op, and that is 2-month post-op. Patient survived very well, no deficits, and we put the same bone flap back after 2.5 months. Another case, a head injury, 29-year-old, low GCS with pupillary asymmetry, signs of herniation. The biggest issue was platelet, 51,000. Now it's a big issue if you have to do emergency surgery as a life-saving procedure, and at the same time platelet is low. Fortunately, we have in-house blood bank. We could manage SDPs, and he was immediately taken up for surgery. This is the first scan and the immediate post-op. And that's the 2-month post-op. You can see a little gliotic area in that. Now, it's not only about a single specialty when we are managing trauma. As you can see, it's an extensive facial trauma. You need a team of doctors, not only orthopedic, general surgeon, but a facial-maxillary surgeon also. So this is one young patient with fall from height, with extensive facial and frontal bone fractures with contusion, and this is the post-op images. So it's not a single...
You have 2 more minutes to go, please.
Yeah. So you need all equipments. We do a lot of ICP monitoring. When we are monitoring in ICU, all patients which come to us, we don't straight away go for surgery. So we monitor with the intensive care unit. We have all ICP calibrations. And you really need experienced staff, intensive care monitoring, and rapid access for everything. I'm not going into too much of detail of spine injury because it's a separate topic, but I'll just touch a few things. Whenever you see an on-site patient with a fall from height, always suspect that he will have a spine injury. Always check whether he is moving limbs or not. And when you feel that there is some discrepancy, always support those patients before you shift them, because sometime at that point of injury, he might have incomplete injury, and if it is not been shifted properly, it may turn into the complete injury. After they reach to us, there are many management which we go ahead. I'm not going into much of detail of everything. These are some few cases. Industrial injury with fall from height, cervical spine trauma. It was an incomplete injury. We did anti-cervical approach, decompression, and corpectomy and fixation. Some intra-op pictures. Now this is one interesting case. It was a bad complete. We don't get always a flowery thing. And this is one of a sad part of the spine injury. This was a complete spine trauma. Some 9 years back we operated. The fixation and screws wall out you are seeing is more just for the stability. What I'm injecting here is actually we took a special permission and approval for the stem cell injections in this patient because it was connected. It was easy to get the permission. When I was doing my training of neurosurgery in Kerala, we used to do stem cell research in Chitra actually. So we thought, why not to try, because he was anyway young and it was a complete spinal injury. We knew that he might not recover, but unfortunately there was no positive result. So any spine injury, when you are shifting, always check whether it is complete or incomplete. So take home message from my side, always check for ABC, thorough head-to-toe examination for the evidence of any trauma, even if the patient is conscious, immobilization of the cervical spine, provide oxygen and maintain oxygen because hypoxia will further lead to secondary damage. Provide adequate fluid, keep the blood pressure in proper lining, continue reassessment and GCS examination, urgent CT and cervical spine imaging if required, and surgical intervention at correct time. Thank you. I hope a day will come in India, which is actually going on right now, where we will have this kind of facility to transfer the patient. Fortunately, in the last 5 years, things are changing.
Thank you, sir. It has been wonderful knowledge sharing, and I would request, sir, please take a chair and just wait for some time for the next for the team appreciation. Now I'll request Dr. Sagar to share the stage and share his knowledge about the trauma management. Thank you.
Thank you, sir. Both my seniors, my colleague doctor has made my life easy. So they already narrated so many things, but still I want to imply some orthopedic injuries. I will divide my talk in two ways. I want to show some splinting that is very important.
Sir, you will also have the same time, 8 minutes to go. Thank you.
So, I will narrate my talk in two ways. One is splinting, that is very important part in any orthopedic injuries that happens in industries. And second thing I want to imply, I just want to show a single case that includes everything from head to toe injury, right? Operated recently. So let's go for the objectives. We should know the early identification of injury is the key of any industrial injury. Protocol should be there to manage primarily at the site of injury before the patient is shifted to any tertiary care hospital. Splinting and immobilization is also a very important part of treatment. Early and proper transfer of the injured to the hospital. And the important two things which most of the time we are missing is communication with hospital, with doctors, as well intercommunication to safety team, HR team and all. Management of mass casualty is a different topic, but to complete the list, I have put in various type of injuries we see in industries. The patient may fall from the height, some heavy object may fall on the patients. Sharp injuries or cut, acute back injuries is also very common, and some blast, mechanical and chemical blast is the key. So already narrated by Dr. Girish and Dr. Nimes, the primary evaluation and identification of injury we can finish within a minute or two maximum. We should always check for airway breathing and circulation. Head to toe palpation is very important thing. Chest compression test, pelvic compression, abdominal palpation, everybody should know. As Dr. Rajesh said, we should be a good clinician. So everyone should know whether there is any injury or not, right? Evaluation of neurology, pupillary reflex, already Dr. Nimes said the Glasgow Coma Scale that we should have in our knowledge. So what primary aid treatment we can give to any injured patient? Compression, bandage of bleeding part. There is very important thing that should be sterile dressing and saline wash, betadine wash if it is possible. Splinting of the fractured limb. If any suspected spine injury, we should splint the cervical spine. We should splint the lumbar spine. Specific spine boards are available. We can procure in our industry. We can have in our armamentarium. I will show you some pictures later on. Management of wound is also very important, because most of the time when we got patients from any industry, they have on their open wounds. So thorough wash of the wound at the industry level will always reduces the chances of infection and easier our life. Evaluation of distal neurovascular status. Antibiotic injection earliest is the key. IV, especially any injury, we should give IV fluid, whether it is small injury or the bigger injury. So this is one of the collar, cervical collar. If any suspected injury, we should have in our safety department. Always apply that cervical collar and then transfer the patient. Never ever transfer patient without this collar. Spine board, this is the specific spine board we have in our trauma. We always shift all our polytrauma patients, any RTA, any industrial injury on this spine board. This is how we put patients on a spine board. This is the sling. These all splints are ready-made splints. So we can have in our industrial center, industrial sling for elbow and shoulder fracture. You can always apply. Most of the time, we get patients with that putthavadi sling and બધું આવીને આવે અને પછી અમારે બધું આપવું પડે. So this is we can procure, right? Splinting of the wrist fracture. This is the how we splint immediately before we apply plaster. This is how we can splint. This is Thomas splint for femur fractures or tibia fractures. This is the splint for knee fractures. These all things, splints are ready-made available. Most of the time we get patients from the industry, patients will be kept unsplinted. If splints is applied, patient will be more comfortable and it can prevent further injury. So patient shifting is also important. This is very important thing that we can, you people as an industrial physician, you imply in your practice. This is the PET slide we have, we used to shift all the patients with PET slides only, right? This is how we put PET slide under the patient, under the bed sheet. We pull the bed sheet and we shift the patient directly on the other bed. This will not give single pain to any patients, right? This is a very comfortable transfer to patient's own law. Communication in case of polytrauma, in case of the multiple injury, in case of mass casualty, in case of suspected critical injury is very important because the timing is the key. So let's see one of the industrial case I have operated 2.5 months back. Recently patient is also in my very good follow-up. Male 26 year, fall from the height, presented to us with hypovolemic shock. These are the injuries. Only right hand was spared. All other limbs, including head, chest, abdomen, pelvis, everything were broken. So he was having right tibia fibula fracture, fracture of the right calcaneum, open fracture of left calcaneum and talus with bone loss, fracture of the lumbar spine with paraplegia, D12, L1, L2, sacrum fracture, distal and radius fracture left side, having bilateral multiple rib fractures with the fracture of sternum, hemopneumothorax, abdominal injury that includes the liver laceration and the head injury, contusion and subarachnoid hemorrhage. So all the systems were involved, right? So fall from height. Fall from height. This is a fall from at 20-30 feet height. So this was the X-ray of tibia fibula fracture, lateral view. You can see the badly shattered calcaneum and talus. It was open fracture on opposite side. This is the fracture of wrist. This is the scan I have done emergency at the middle of night, 2 o'clock I got this patient. So in emergency I have to inform all my team. So this was the injury to spine, fracture of the L1, L2, D12 with the cord injury. You can see the bed injury, down is the sacrum. Sacrum is very rare fracture. This is one of the very rare fracture. 1% of all pelvic fracture we got this kind of injuries. This is a fracture of sacrum, fracture of spine, and this is the CT images. In emergency, we got the patient with blood pressure of 50 to 60 systolic blood pressure. We took central line immediately. We started nasal oxygen. We pushed the saline. We pushed the blood. We have blood bank in house. Immediately, within half hour, we pushed 4 unit of blood. So all the X-ray and scanning was done. Admitted in ICU. On next day evening, we took the patients for surgery, especially for spine, because it was the critical surgery. We want the patient's function back. So after the stabilization, we did all the surgery in manners. First, we took for spine. Then after, these are the post-op pictures, how we fixed the tibia, same side calcaneum. This is the fracture fixation for spine, decompression fixation. Spinopelvic fixation is one of the very rare fixation we have done in this case. This is the fixation for sacrum. Rare injury, rare fracture. This is the fixation, open injury. This was the open injury we fixed with K-wire, external fixator, screws, because we could not put implant inside because it was a very bad wound. These are the plate fixation for distal and radius, AP and lateral view. So to summarize, the primary management of injury at incident site is very important thing. Early proper transfer of the patient at competent center and communication within industry and to the relevant hospital is the important thing. Thank you.
Thank you all the speakers. I would like to acknowledge that this session was sponsored by Baila Lamin General Hospital. Now I will invite all our speakers from Baila Lamin to come up on the stage, and I will invite our chairs to present a token of appreciation to our speakers of Baila Lamin Hospital. Dr. Girish sir, Dr. Nimesh sir and Dr. Sagar. The next session is sponsored by Sterling Hospital, and our chairs will invite our speakers on the stage.
So, I take this opportunity to invite Dr. Munish Shah on the stage to take along with the first session in this segment. Dr. Munish Shah is a consultant plastic burns and cosmetic surgeon with more than 30 years of experience. Besides being passionate about the treatment and management of extensive burns, he has keen interest in facial-maxillary and hand injuries, diabetic foot management, cosmetic and reconstructive surgeries. He has been successful in saving lives in patients with more than 85% of the body surface area and deep burns, besides most of the burns up to 70% of the body surface area. He is an extensive user of grafts from cadavers in the treatment of major burns, being amongst the very few in India. So I request Dr. Munish Shah to start his presentation. Sir, you have 12.5 minutes to go. Thank you. And your time starts now. Thank you.
Thank you, Chairpersons. Thank you, IOH. Thank you, Dr. Jain, Dr. Saxena, Dr. Everybody. It's a privilege for me to be here presenting my work, and also occasion to meet so many friends after such a long time. Thank you very much. This lecture on industrial burns is divided into two parts. I'll be covering the non-ICU part. The ICU part will be covered by my colleague, Dr. Revati, who's a very eminent intensivist in the city. And basically, how many of you know which is the biggest organ of the body? Anybody doubting skin? Skin is the biggest organ in the body. And so the importance of burns. Okay. All the vehicular accidents, we talk of the golden hour. We get 1 hour to get the best of the result in that situation. When it comes to heart attack, Suhas will agree it's about 3 minutes. But when it's burns, it is 1 minute. The skin burns in 1 minute's time. And that's the reason prevention is better than cure. And I have seen that change over the last 30 years of my practice. Lot of industries have made lot of changes to prevent burns, and at the same time introduce something which would help in the first aid. So the mission here is to save as many burns patients as possible, and I can very proudly say that I feel, and our team feels confident of saving burns up to 80-85% in most of the cases. We are striving to touch even 90-95%. The second and the most important thing is to reduce pain and maintain good health of the patients if they survive, because we do not want a cripple again added to the society and to the family. And so the most important thing in that is early wound healing, and that makes all the difference. As I said, we have to discharge the patient with full functional capability. We do not want any functional disability, otherwise there's a big problem afterwards. And more important is they have to be, whether it is he or she, has to be going back to the same occupation that they were there before the accident. And at the same time try and reduce the lost man days. As you all know, burns basically happens from 3 sources. One is an electrical current, live current. It may be 11 kVA or more, or many a times it is the low intensity, but then it does cause a lot of problems. The second is the chemical, whether it is acid, alkali or whatever. And the third and the most common is definitely the heat. So direct fire. Sometimes there is just a flash fire, whether from the electrical short circuit or from the gas flame. And the third is the contact burns, hot, whether it's a hot metal, hot liquid, or many times in the domestic one we see the motorcycle silencer burns. So what is the first response? Definitely the presence of mind. But, sorry. We cannot rely on that, and that's why what Dr. Rajesh said, we need to think about this prior, and that's why I said prevention is better than cure. So you need to lay down strategies, but that would only come after you understand the whole incidence and the pathophysiology and what is needed. So you need to have a strategy in place, you need to have trainings, you need to have mock drills, you need to analyze what is the result of those mock drills, and then you have to have repetitions, because just saying it even once in a year or twice in a year is not enough, because people keep changing, they keep forgetting. So you need to have repeated mock drills and repetitions of those things to prevent burns in the industry. And then you need to monitor that how well you are doing the whole exercise. For most of the burns, I mean, I'm not talking of the electrical, but definitely all flame burns and many of the chemical burns. Shower, water is the best first remedy. And so it is common to see showers in a lot of industrial areas because they reduce the depth of burns, they relieve the pain. And there is a study which says irrigation within 10 minutes has 5-fold decrease in the full thickness of burns and 2-fold decrease in the length of the hospital stay. But the problem is how much practical it is. Because as I said, skin burns in 1 minute. So if you do the same thing after 5 minutes or 10 minutes, I really don't think so it works. On site, what needs to be done? So if it is a flame burns, definitely you need to have running water or a gel, silicone gel sheet, gel blanket, which will help cut down the flame and which will give a soothing effect to the patients. As in the chemical burns, again, running water is important in most of them, but in specific conditions you need antidotes, and for which we've already heard the lecture of Dr. Tejas Patel. It was a fantastic lecture. I also got to learn something more. Please do not neutralize an acid with an alkali or an alkali with an acid. Never. It is only in chemistry it is positive and negative, but practically it is the most harmful thing, so please don't ever do it. Phenol burns has a little special thing, because first you rinse it with water and then one can use polyethylene glycol solution. It helps to reduce the depth of the burns for sure. Electric burns, definitely you have to switch off the power supply because that is the cause of the burn. So you need to remove the cause first. That's the most important thing. Duration for as far as the shower is concerned, till how long do you keep the patient in shower? So basically till the flame is out, and if the patient's general condition is not bad, you can ask the patient to keep the burnt part under running water because it helps to reduce the pain to a great extent. The other ointments and the treatment can start later on, there is no hurry. But if the patient's condition is critical or there are major burns, then you definitely do not let the patient stand in the shower for a long time. These are just the list of the antidotes, but they are very well covered by Dr. Tejas, so I don't need to go into them. Otherwise, I had a whole list. And hydrofluoric acid and the ACN are the commonest that I have seen in my practice. So this is the second list. Coming to what next? So definitely it is the patient's assessment and planning. I mean, these are very routine things. I really don't need to go into the details because of paucity of time. But we need to cover the whole body in general, and it has been repeated so many times by the other speakers. The only thing that now comes for burns is to estimate the body surface area, the extent of the burns, how many percentage the burns is, which I'll be coming in the later slide. The another important thing is to know about the depth of the burns, whether it is first degree burns, second degree burns, or third degree burns. And in some cases like the electrical burns, one needs to look into if it is a circumferential injury, it will cause a compartment syndrome. So that is what needs to be looked into, and because that needs a early treatment. This is a very simple rule of 9 to know about the percentage of burns. It's very, very simple. There are other formulas. There is always a debate which is good, but more simpler, the more practical it is, and so I follow it in my practice all the time. It is very simple. Only the trunk, the chest and the abdomen is 9 each, so it becomes 18. Same with the back, the thorax and the back, lower back is 9 each. Otherwise everything is 9, 9, 9. And so is the lower limb. The thigh is 9 and the knee below is again 9. So it's a very simple rule of 9. The second important thing is the extent of the burns. I do not count, and we do not count first degree burns in any calculation for burns treatment. People do have first degree burns, and we hope all of them get away with first degree burns, but that practically does not need much treatment, and so it is not spoken about in the treatment part. So what I am starting is the second degree burns. What you see here are different zones. Even in the second degree burns, you have a superficial, intermediate and a deep burns, but it is too technical. I will not go much into that, but that is what is important, because if this second degree burns is not treated well for whatever reason, late treatment, wrong treatment, application of, people apply Colgate, people apply different things, the same superficial burns can get converted into a third degree burns. So that's the reason one needs to take care of the second degree burns in the initial phase, and that's the lifesaver. A third degree burns would either be whitish like this, or a black or a brown patch like this. And that definitely needs surgery, because third degree burns don't heal without surgical intervention. Otherwise it will take a very, very long time with lot of deformities. Admission criteria for burns, very important. So any major burns, more than 25 to 30% body surface area needs admission. A compromised ABC like what you saw in all other traumas is applicable here, including associated injuries. A very elderly patient, a pregnant patient, or a pediatric small child would definitely need more monitoring. Same way, burns of the hand, because function is very important. You may heal the burns, hand burns, but if the patient goes home with a deformity, it is very problematic for the patient, the society and the family. Same way, face burns, very important, because just not for the cosmetic reason, because we have the nose, we have the eyes, we have the pinna, so we need to take care of all those very important vital structures. The private parts definitely, because I have had burns, patients with just burns of the penis, and we had to admit the patient, otherwise it's very difficult for the patient to manage his or her, his daily routine, plus causes a lot of strictures, so that's why it is needed. And if there are any associated comorbidities and illness in that patient. The ICU management, as I said, would be taken care by Dr. Revati, so I will not indulge much into it, but then all these routine things what you've heard from the other speakers so far applies in burns also. Electrolyte balance is something which I would like to specifically say in burns. Fluid and electrolyte is the first and the foremost thing to be taken care of. So there are different formulas for the replacement, which again is little technical. I will not go into it, but by and large I follow a formula of 3% into percentage of burns and the patient's weight. Some people go 2%, some people go 4%. I like to remain in between 3% and then keep my monitoring and adjust the fluid replacements accordingly. Very important to monitor the general condition of and all the systems of the patient.
Sir, request you to finish in 2 minutes time. Thank you.
The mental makeup of the patient in the ICU is very important. The nutrition is very, very important. Believe me friends, I give about 20-25 eggs per day to a major burns, extensive burns, 70-80% burns. including a 5-year-old girl. And they have taken it. Right now I have a patient, I'll show you, she's a Jain, a Brahmin, doesn't eat eggs. But having convinced her, she is eating 10-15 eggs every day. Very important, because howsoever amount of albumin infusions you give, it does not match the protein that one gets from the eggs. The social interaction is very important, so I definitely don't advocate very strict ICU protocols on that way, but asepsis, antisepsis is very important. Aim is early excision and grafting in burns. You have to avoid infection, because that is the game changer. And use of antibiotics as needed. And the local applications could be any ointments, or there are a lot of newer materials that are available. Paucity of time, I can't go into it. Antibiotics, I've said, I use them minimum. I don't start with the higher antibiotic, I go with the basic. Do repeated cultures, and then follow the patient's local condition and the general condition and the blood reports to decide what antibiotics I need to go. And then I scale them up and down as the situation goes. Dressing, very, very important. We need to ensure the patient is comfortable. So this is what a Bakhtar, I take the pride in having designed it for my patients over my 30-35 years of practice. I find this to be very, very helpful for my patients. And upper limb, lower limb band dressings are all right. But when it comes to the chest, abdomen, this is what really helps me a lot. And I use a lot of collagen for superficial burns. Tangential excision is grafting is the important game changer, because it helps early heal, gets early healing, reduces pain, reduces morbidity, it minimizes deformity. I'm repeating things because this is very important. Mobility is preserved, and definitely it improves the survival of the burns patients. So this is a patient whom I have treated recently. You see varying amount of burns in the hand. This is like a second degree superficial, this is second degree intermediate, and this is a second degree deep burns. This is not third degree burns, friends.
Sir, half a minute more, sir.
Yeah, so basically after excision, this is what we get, and this is what we get after grafting. And you see this patient, the burns, this is on the 8th day. You see full function of the hand. That's what is important. And you cannot say that this will come after a month. It has to be done right at that same time. And this is what makes all the difference. And this is, the lady had burns on both the right and the left upper limb, both of them with full functional recovery. Same thing on the face. Fortunately, her face healed quite well. On the 14th day of the post burns, whatever raw areas were deep, I had to take them for grafting, which included the upper eyelid, the pinna, and on the 7th day post-op, the wound is all healed, and she is ready to go home on the 15th day of the surgery. Not of the burns, but 15th day of the surgery. And that way it makes all the difference. So, where do you get the skin when it is an extensive burns? Definitely it is the patient's own skin ultimately that counts, but if it is not available then, and definitely what I use is a thin, it is a very thin slice of the skin. Sometimes I use a medium thickness burns, but if we don't get the patient's skin, we used to use relatives or other skin, but then a cadaveric skin, just 1 minute I finish. Cadaveric skin has changed again. We get skin from the skin banks which are not in Baroda, unfortunately. I get it from Bombay, Delhi, Indore. There are artificial skins like the Integra, but again too very costly, more for the foreign markets, not for India. Aftercare is very, very important to ensure there is a full range of movement. The functional joint position splinting is very important. Pressure garments are very, very, very important. Physiotherapy, early mobilization of the patients. This is one example of a full body pressure garment that is given for having a very smooth scar management. Rehabilitation in terms of occupation, transportation, counseling, and the patient's compensation has to be taken care of. Summary, these are the very important points, but the most, at the end, I would definitely end my talk with necessity to have a motivated and a dedicated team, and it is because of them that all the patients are being able to go home and have the results that are desired. So I thank them all and thank you all for the patient hearing.
Thank you, Dr. Monisbhai, for your elaborate talk on the topic. The next part of the session will be taken ahead by Dr. Revati Iyer, who is MD and DNB in medicine, is also qualified with IFCCM, EDIC, and she is the Director of Medical and Surgical ICU at Sterling Hospitals. She is the past president of ISCCM Baroda branch. She is also an American Heart Association certified SCLS instructor and IDCCM and CTCCM teacher and examiner. She is the national faculty at Ventilator Workshop, Best of Brussels 2017. She is also a national faculty to Critical Care Conference at Kochi 2017. At Mumbai in 2019, Hyderabad in 2020, Ahmedabad in 2022, and Eurasia Conference Delhi 2022. She is an author of a chapter titled Advanced Medical Directives in India, the Ethical, Legal and Practical Aspects in Critical Care Update to 2021, and also a chapter titled How to Mitigate Ill Effects of High Staff Attrition Rates in ICU in Critical Care Update 2022. And she has participated in INDICAPS, DISACT and Hermes study. I request Dr. Revati to take along. Dr. Revati, you also have 12 minutes to go. Yeah, thank you.
Thanks. Thanks. Hope I'm audible. Thanks for that kind introduction. Thanks IOH for this opportunity and my hospital, Sterling Hospital, for giving me this opportunity. I'll try to do justice in this short period of time. To make it interesting, I have a recently treated case, a 22-year-old male who came with accidental chemical burns following blast in the chemical plant. There were about 6 to 7 patients were there, which came in the papers. Of course, none of them survived, but all of them died within 24 to 48 hours. But we could manage to keep him alive for 20 days. He later succumbed because of sepsis. But just a brief, he came with these vitals. He required some oxygen, he was conscious, oriented, GCS was 15/15, there was no neurodeficit, but he had a slightly hoarse voice. Assessment was he was about 89%, 2 to 3 degree deep tissue burns. His reports, as usual, hemoglobin was 20.9, so what does this show is he's extremely dehydrated. Total count was high, his INR was slightly altered, his albumin was very low, liver functions were slightly altered, electrolytes were also altered. Creatinine was okay, chest X-ray was normal, pH, ABG was done, pH was 7.29 and BICAP was 18, RBS was 120. So before going further into this case, I would like to discuss what is the general ICU management and then we'll go ahead to see what happened in this patient. So what do we do? Like already the previous speakers have told you, every burns patient should be treated as a polytrauma patient. So it's not much different and patient should be managed in a dedicated burns unit. So we have our ICU in which we have isolation units with HEPA filters, we have positive pressures and negative pressure rooms. So we keep those patients there. Every patient is treated in a single room with a separate AHU AC units so that the infection doesn't spread from one patient to another. We have to have barrier nursing, single 1:1 nurse ratio. So all that is important. Then airway, like my previous speaker talked about trauma, airway has to be assessed in such patients first by asking questions to the patient, listening to hoarseness, because that would be a big guide. If he has hoarseness, it may specify upper airway burns. 100% is administered to each patient and SpO2 monitored should be confirmed by ABG analysis. Wheezing, tachypnea, stridor, hoarseness indicate impending airway obstruction, so that could be a good clinical guide. Immediate treatment should be instituted. If patient is not breathing or has labored respiration or signs of obstruction, immediate suction followed by intubation should be done. Special care should be taken when there is a risk of airway obstruction in inhalation burns, deep burns with more than 35 to 40% total body surface area, burns involving face, neck and upper torso. Intubate early if progressive airway edema is suspected or the patient requires prolonged transport. Breathing, airway breathing. Breathing may be due to smoke inhalation injury, deep circumferential chest burn or an associated chest injury. In smoke inhalation injury, usually present with, like I said, hoarseness, wheezing, carbonicium sputum, facial burn, and nasal vibrising. Diagnosis could be established by using bronchoscopy, which reveals early inflammatory changes such as erythema, edema, ulceration, sloughing of mucosa, prominent vasculature in addition to infraglottic soot. Frequent bronchoscopy may sometimes be needed to clear secretions. One thing I wanted to say, in case of inhalation injury, even in the industry, one should strongly suspect carbon monoxide poisoning and cyanide poisoning. You should look into it, you should diagnose and treat it. So what are the symptoms? Carbon monoxide poisoning could have mild symptoms like headache, nausea, fatigue, irritability, seizures, vertigo, flu-like symptoms, confusion. Severe could be delirium, ataxia, chest pain, dyspnea, seizures, coma, even a myocardial infarction, stroke or a death. So it is easily diagnosed by carboxyhemoglobin levels. Less than 10% is normal, more than 40% is severe. What is the treatment? Very simple. Remove from the source, give 100% oxygen. Hyperbaric oxygen is a treatment adjunct. So it's as easy to treat, but you have to suspect it to treat. If you don't suspect, then it can be fatal. Second, very important thing is cyanide toxicity. In fires, hydrogen cyanide gas is produced by combustion of products containing carbon and hydrogen. So cyanide toxicity should be considered and low threshold should be kept for initiating treatment. Diagnosed by depressed level of consciousness, which may also happen in carbon monoxide, traumatic shock or head injury. So symptoms would be as mild as headache, nausea, vertigo, anxiety, altered mental status, tachypnea or hypertension, and severe like dyspnea, bradycardia, hypotension, arrhythmias, unconsciousness, convulsions, cardiovascular collapse, shock, pulmonary edema and death. So it could be fatal. So diagnosis is mainly clinical. There is no quick bedside or lab test as in case of carbon monoxide. Fire victims with soot in their mouth, altered mental status and severe metabolic acidosis with extremely high lactate levels such as cyanide poisoning. So lactic acidosis in a blood lactate level more than 8 millimoles in non-smoke inhalation victims and more than 10 millimoles in smoke inhalation victims and a compensatory drop in EtCO2 indicates cyanide toxicity. Antidote treatment, as you are all aware, sodium thiosulfate and hydroxycobalamin is best. It is preferred, especially when a combined cyanide and carbon monoxide poisoning is suspected. If hydroxycobalamin is not available, then you can use cyanide antidote kit, amyl nitrate and sodium nitrite to induce methylhydrochloride and sodium thiosulfate to act as a sulfur donor. The only problem is this can cause hypotension, and if there is associated carbon monoxide poisoning, then this is not a preferred treatment. Then comes to circulation. As in all trauma patients, you have to obtain an IV access and start giving fluids. Unburned areas are preferred because if you put an IV access in a burned area, then there is an increased incidence of infection and sepsis. Burned areas may be acceptable if you don't get anything else. Central line would be preferred if the expertise is available, or cut down as an esterera. Perform resuscitation in a burn shock in first 24 hours. Massive capillary leak occurs in such patients. And fluid shifts from intravascular to interstitial space. So fluid requirement increases with great severity of burns, that is larger the percentage of total body surface area, increased depth, inhalation injury or associated injuries, the fluid requirement would increase. So fluid resuscitation is the cornerstone of treatment in the initial 48 hours. It is done to anticipate and prevent burn shock rather than treat it. So pulse rate of less than 110 indicates adequate volume, more than 120 means patient indicates hypovolemia. A narrowed pulse pressure is more important than a hypotension. So a narrow pulse pressure should be noted, that is an indication of shock. Delay in fluid resuscitation for more than 2 hours of injury complicates the resuscitation and increases the mortality. Excessive resuscitation again can lead to fluid overload and it can cause pulmonary edema, myocardial edema, abdominal compartment syndrome, etc. So you have to weigh and give fluids accordingly. So different formulas, as the commonest formula which is very popular is Parkland formula, which says 4 mg per kg body weight. But as Dr. Munish says, it becomes a little higher and many times patients land up in higher fluid load. So the ATLS formula is 2 ml per kg body weight for adults. And there are other formulas which may be used. Resuscitation goals are, of course, sensorium should be comfortable, arousable, and a urine output of 0.5 ml per kg per hour for adults and 1 ml per kg per hour for children. If it's not achieved, then fluids have to be increased accordingly. Preferred fluid, of course, is ringer lactate. It is isotonic, it is cheap, it is easily stored. Resuscitation formula can just act as a guide, but you have to manage clinically. Albumin IV can be added because there is profound hypoproteinemia and it favors recruitment of interstitial fluids. Other colloids are not advisable, like volulite and dextran and other things are not advisable because they can increase the incidence of AKI and coagulation abnormalities. Blood transfusion may be indicated if hemoglobin is less than 8 in non-cardiac patients and less than 10 in cardiac patients. Second thing would be a detailed history. Like ADS in ATLS, it is mnemonic is ample, allergy, medication, pregnancy, past illness, last meal taken, and environment-associated injuries. Start supportive treatment like put in a rice tube for gastric decompression and initiating early enteral nutrition, IV analgesics, antacids, and tetanus prophylaxis. Assessing severity, I think Dr. Manisha has already talked about percentage of TBSA, depth of burn injury, age, and associated injuries. So I would not go into the detail. The classification wound, superficial, partial, and full thickness. So once that is done, burn wound care as the plastic surgeon takes care and control of infection. Prophylactic antibiotics, especially a broad spectrum, have no role because they may increase the infection by multi-drug resistant organisms. Inappropriate antibiotics and signs and symptoms of infection occur, guided by culture reports, and maybe even antifungal after 7 days may be required. Some life-threatening complications I would like to talk about: infections, rhabdomyolysis, and AKI. The common infections could be streptococcus, MRSA, gram-negative, fungi, viruses. 70% of the mortality in burns are due to infection. Then rhabdomyolysis, which happens very commonly after burns and crush injuries due to breakdown of muscle tissue that leads to release of muscle fiber contents into the blood. When muscle is damaged, a protein called myoglobin is released into the bloodstream, which is then filtered out of the body in the kidneys. So this breaks down and can cause AKI. What is the common symptom? Dark red cola-colored urine, decreased urine output, and muscle weakness. Test to diagnose: mainly CKMM is raised and calcium is reduced and creatinine is increased. Treatment would be as simple as adequate hydration to give fluids containing bicarbonate, forced diuresis to have enough urine output, treat hyperkalemia, low calcium levels, and if conservative management does not help, then early renal replacement therapy in the form of dialysis. So acute kidney injury is another very important complication of burns. Incidence is up to 30% and mortality is up to 80%. It could be classified into early and late. Early, 0 to 3, hypovolemia, denatured proteins, inflammatory mediators, rhabdomyolysis, and cardiac dysfunction. And later, it's because of sepsis, multi-organ failure, fluid overload, and nephrotoxic drugs. So advent of renal replacement therapy has changed and improved the mortality of burns. Unfortunately, no other pharmacological agents are available. In our case, like we managed, we put all the lines, we resuscitated, we took to the OT, did all dressings, patient improved, we managed the electrolytes, bronchoscopy was done, the airway injury was not bad, but patient developed fever. All lines changed, antibiotics changed, antifungal added. He did get better, but we lost him on the 20th day because of severe sepsis. So that was unfortunate, but at least this patient survived. Other patients had died within 48 hours in other hospitals. Most important, last but not least, metabolism, as Dr. Munish had already said. Nutrition is the most important in burns. Ideally, enteral nutrition should be started along with fluid resuscitation, except in patients with major burns or complications. Early enteral nutrition can abate hypermetabolic response to burns. Rice tube feeding should be started even within the first 6 hours. A patient cannot take orally. The caloric requirement needed to gain weight and achieve nitrogen balance is about 25 kilocalories per kg plus 40% kilocalories total body surface area burn for 24 hours. Protein needs are approximately 2.5 per gram per kg. TPN is associated with immunosuppression, increase in infection, so we do not prefer giving TPN. Strict glucose monitoring should be done. Hyperglycemia should be avoided, as it can lead to increase in infection. My last slide. I would again like to conclude, resuscitation is the primarily important. Airway breathing circulation, airway patency and protection as needed. Breathing support by ventilation, and if needed to intubate, use ARDS protocol, low tidal volume, high PEEP for ventilation. In patients with smoke inhalation, airway injuries to be assessed by bronchoscopy. Carbon monoxide and cyanide toxicity should be looked for specifically and treated. Circulation, good IV access, optimal resuscitation using clinical goals to achieve adequate urine output to avoid overhydration and resultant complications. Optimal burn wound care, prevention treatment of infections recommended because they contribute to 70% mortality. Rhabdomyolysis and AKI should be recognized, treated early to save lives. Last but not the least, adequate enteral nutrition with optimal calories and protein intake is mandatory. Thank you. Like Dr. Munish said, up to 80-85% burns we have been able to save, and we try to do that in future also. I I hope I completed in time.
Thank you very much. It was an extensive know-how about the industrial burns management, especially in ICU and critical care. Thank you very much. Team Sterling.
We have a question for Dr. Munish Shah, sir.
My name is Dr. Hiren, and I work in a chemical industry. So we get many of the chemical burns, but as you know that diphoterin is one of the liquid that we use as to wash the chemical burns. Now it is a common practice among the plant workers that when we get a patient, we ask the history, and while asking the history, तो बोलेंगे सर पहले diphoterin लगाया बाद में water लगाया. So what is your opinion? What should be applied first? Whether we should give wash with water or whether we should give diphoterin first?
See, very frankly, I am not an authority on it, toxicology. I would take the advice of somebody like Dr. Tejas Prajapati, to be very frank. But as a thumb rule, always rinse it. Because by the time you get the antidote, water is more easily available, right? So I think so.
Munish bhai, can I add something that the diphoterin is basically manufactured by a German company or a French company, which is just a hypotonic solution, and they never mention the content of that solution. Though we keep it, it is advised and it is advisable that if it is used within first 10 or 20 seconds of the incident, which is practically impossible. So never miss on the safety part of the injury or the chemical splash incident to take the person or the victim under the safety shower. Because decontamination is the foremost part, but the role of diphoterin is still mysterious. It could be incidental, but anyway, because the role is not very well established.
Basically, if you have the antidote on hand, then that would be preferred. But practically speaking, to get even water, and it is 1 minute's time. So you need to understand from that point of view. Yes, Kishore.
Yes. Now I would request our chairs to present a token of appreciation to our speakers from Sterling Hospital. So, please stay here.
ડેલિગેટ્સ ને એક રિક્વેસ્ટ છે કે 15 થી 20 મિનિટ ખાલી ભૂખ જાળવી રાખજો પ્લીઝ. આપણું છેલ્લું સેશન 15-20 મિનિટનું ડૉક્ટર સુહાસ લેલે સાહેબ લેવાના છે હાર્ટ એટેક ઉપર, અને પછી આપણે બધા પ્રસ્થાન કરશું લંચ માટે. થેન્ક યુ, પ્લીઝ.
Hello. So, Dr. Suhas Lele, he's an interventional cardiologist presently working with Zydus Hospital, Vadodara, and he's a consultant interventional cardiologist. He has a rich experience of 25 years in the field and over 15 publications on the same subject line, along with around 10 years experience with 2 Blue Ribbon and US patients and 1 European patient. So we will have some wonderful insight about the cardiac arrest and its management on site, especially by Dr. Suhas Lele. Thank you.
I guess I represent the new kid on the block. And I'm sure you know a little bit about Zydus.
Just to add, sir, 15 minutes. Okay?
Absolutely.
Thank you.
I mean,
It's just a time before the lunch. Thank you.
Time pressure is something that I don't think I have, because I had a colleague who was going to speak with me, and she got H1N1, and so she couldn't come. And I was wondering how we are going to divide a talk on death into 2, but I was saved that problem. So I think I have a lot of time, and I can in peace discuss what I need to tell you about sudden cardiac death. So if you just begin, what is sudden cardiac death is simply an unexpected circulatory arrest due to a cardiac arrhythmia that happens within an hour of the onset of symptoms is sudden cardiac death. It is very simple to identify. And what is happening in the patient is from a normal sinus rhythm, very abruptly he is going into either a ventricular tachycardia, which is a heart rate of close to 200, 250 beats per minute, or a ventricular fibrillation, which is a rhythm with about 600 beats a minute, and that cannot sustain circulation, so he goes into circulatory collapse. And that is what sudden cardiac death is all about. So the commonest thing that happens is ventricular tachycardia. Sometimes it is pure ventricular fibrillation, or it can be torsades, which is a type of a tachycardia. In a small set of patients, it is predominantly a bradycardia event. But by and large, sudden cardiac death is a tachycardia event where there is a high heart rate leading to a circulatory collapse. By far and away, it is the most common cause of death all over the world. It is second only to all cancers. And if you put it in context, look at all other diseases that cause death. Sudden cardiac death is the largest single way that you will experience a mortality or death. It kills over 1,000 patients every day, or a patient every 10 seconds. The unfortunate part of it is that 95% of these patients who experience sudden cardiac death do not survive. They usually have a very, very high mortality. And the incidence of sudden cardiac death simply increases with age. Irrespective of your sex or your race, the older you are, the higher is the risk of sudden cardiac death. And of course, in the younger patients who die, sudden cardiac death occupies an even larger proportion of all the causes of sudden death. And again, in over 70% of patients, that is the first manifestation of disease. And usually they don't have any pre-existing disease, and death presents as the first major event that happens in this set of patients. So since we can do precious little when sudden cardiac death happens, so the whole aim is to see if you can identify patients who are at a higher risk of sudden cardiac death and do something to prevent sudden cardiac death. So if you look at what are the causes of sudden cardiac death, there are four important. Cardiology is very simple. There are 4 chambers, 4 diseases, 4 drugs. So it's not very complicated as the other specialties are. So these are the 4 common conditions that can trigger sudden cardiac death: coronary disease, structural heart disease, cardiomyopathy, and conduction system disease. If you just look at the age of the patient and the sex, you will know what predominates where. So in males, it is actually coronary artery disease, which is the commonest cause. In women, it is a combination of coronary artery disease and dilated cardiomyopathy. If you see a younger patient, then hypertrophic cardiomyopathy or coronary anomalies or structural heart disease predominates. So if you just look at the sex, the age of the patient, you know what is the most common underlying cause that has triggered this sudden cardiac death. Look at coronary disease, which is the most important underlying cause for sudden death. Just the existence of coronary disease increases your risk of having a sudden cardiac death by almost 5 or 6-fold. Add to that if you have left ventricular dysfunction or if a patient is in heart failure, they are very potent predictors of sudden cardiac death. And any patient with coronary disease, you find an ejection fraction less than 30% is the single most important predictor of sudden cardiac death. When you see a patient with an infarct, in the first 6 to 12 months, there is a higher risk of sudden cardiac death, after which the risk of sudden cardiac death progressively reduces until about 8-10 years later, when the left ventricular dysfunction sets in, then again you have a higher risk of sudden cardiac death. So as I said, just look at the ejection fraction and you will know that there is a 7-fold increase in risk of sudden cardiac death if your ejection fraction is less than 30%. If your ejection fraction is normal or more than 50%, your risk of sudden cardiac death is very, very small. Again, heart failure, there is a significant higher risk of sudden cardiac death. It is about 9 times more than the general population. In patients who are well controlled in NYHA class 2, the predominant cause of mortality is sudden cardiac death. In patients with NYHA class 3 or 4 or more severe heart failure, you have heart failure as a cause, but still sudden cardiac death remains an important cause of mortality in this set of patients. Then of course, if you look at structural heart disease, you have heard of this condition called hypertrophic cardiomyopathy, where there is an unusual, I don't know if there is a pointer here I can use. But anyway, where there is an unusual thickness of the heart muscle, especially the septum, and these patients, so these patients usually will give you a family history of sudden death. A young patient who has hypertrophic cardiomyopathy and tells you that in his family there are other people who have died suddenly, that is a very high risk subset of patients who you need to treat very aggressively. Then when you don't find anything in the young, you don't have hypertrophic cardiomyopathy, you dig a little deeper and there are certain very rare conditions that can produce sudden cardiac death. One of them is what is called arrhythmogenic right ventricular dysplasia. It's a mouthful of a syndrome, but all it means is there is RV dysfunction, not LV dysfunction. And there is RV dilatation and RV dysfunction which predisposes these patients to arrhythmias. These are patients who will commonly go from one person to the other because they will have recurrent ventricular tachycardias which are easily treatable and they are usually not life-threatening. So if you have a sudden cardiac death-like experience and have a person who has recurrent ventricular tachyarrhythmias, this is the condition that you generally suspect. Then you have some rare forms of cardiomyopathy where the basal septum is normal, but the apex is hypokinetic, and they also present with certain cardiac death. Then of course you have heard of dilated cardiomyopathy, which have normal coronaries, extremely dilated left ventricle, they go into heart failure. So as I told you earlier, LV dysfunction and heart failure both predispose the patient to a very high risk of sudden cardiac death. Then you have an even rarer conditions like conduction system abnormalities called Brugada syndromes. Of course, I promise I have not diagnosed the Brugada syndrome yet, so you don't need to worry about it. But these are certain electrical abnormalities that can produce sudden cardiac death. Then you can have long QT syndromes where inherently an ectopic beat on the T wave can trigger an ventricular arrhythmia and can kill the patient. And of course there is this what is called as polymorphic ventricular tachycardia that is triggered by catecholamine surges. That is what explains when you have a very unusual emotional experience or a tragedy and there is a catecholamine surge that can trigger polymorphic ventricular tachycardia and can actually kill the patient. Then you can have even rarer coronary anomalies where the right coronary comes from the left sinus or the left coronary comes from the right sinus. The problem is these coronaries then take an abnormal route and get compressed between the aorta and the pulmonary artery. And when that happens, it triggers ischemia and can lead to sudden cardiac death. Mitral valve prolapse I have mentioned here because we do a lot of echocardiographies and a lot of times we report mitral valve prolapse. And generally if you just have mitral valve prolapse, it doesn't increase the risk of sudden cardiac death. But if you have a degenerated valve, like you see on the right side, and it is myxomatous degeneration, severe mitral regurgitation with mitral valve prolapse, that is what increases the risk of this patient going to sudden cardiac death. So what do? The object of screening, because you're all occupational health specialists, so the question is, how do you screen a patient for the risk of sudden cardiac death? There are three things you do. You do an ECG, because you want to see if there are anomalies in the ECG. You do structural heart screening by doing an echocardiography, because you will pick up hypertrophic cardiomyopathy and mitral valve prolapse when you do echocardiography. And then because coronary artery disease is a very important underlying factor triggering sudden cardiac death, in patients who are workers or employees who are more than 40 years of age, some form of screening for coronary disease, which can include a simple stress test or a stress thallium imaging, which is a more sensitive way of picking coronary disease, is what you need to look for in order to identify patients who are at a higher risk for sudden cardiac death. What do you do if you witness a sudden cardiac death? And you probably don't want to be next to that patient, because you know the statistics that 95% of these patients will not survive. So if you are there, you are not going to do anything positive. But what can be done is, if you are right there, you need to initiate basic cardiac life support. And I don't think my brief included a lesson on basic cardiac life support. But the important thing in this is to not continuously thump on the chest, because that is not going to help. The underlying cause of the cardiac arrest is a rhythm problem. It is either a ventricular tachycardia or a ventricular fibrillation. So what you need is one of these gizmos pretty close to highly populated centers in factories and in workplaces. These are external defibrillators. And everywhere where there is a congregation of people, you need, not only do you need these gizmos, but you need trained people who know how to handle these gizmos. And when you talk of an external defibrillator, you should know there are two types of external defibrillator. One that comes with pedals, and the other that comes with disposable pedals. If you have a defibrillator with disposable pedals, you have to attach them, one at the apex and other just underneath the clavicle. Or you can attach one at the front and one at the back. In pediatric patients, it is always one at the front and one at the back. And when you turn the machine on, if you have the automatic, the disposable cables, the machine senses the rhythm and it will defibrillate automatically if it detects a ventricular tachycardia or a fibrillation. But if you don't have that kind of an external defibrillator, if you have a pedal-based external defibrillator, then the positioning is the same. But if your patient has collapsed, you don't need to identify the rhythm. You can just deliver a shock with the hope that you revert the rhythm back to sinus, and then continue your basic cardiac life support, which is an attempt to maintain the airway plus maintain cerebral circulation. But the important thing is to revert the rhythm. Unless you revert the rhythm back to normal, no amount of thumping on the chest is going to work. So the important thing is to have a defibrillator preferably close to where large employees are based, and have somebody in that set who knows how to use an external defibrillator. Once you train this, you will make a lot of progress in trying to prevent sudden death in patients who present with acute collapse. What about prevention? How do you prevent sudden cardiac death? And there are two ways. Either you give drugs to prevent ventricular tachycardia, or you can use a device to prevent ventricular tachycardia. When it comes to drugs, our experience with drugs is horrible. All the drugs that we use will prevent arrhythmias, but they don't lower mortality. In fact, most drugs will increase mortality. The more effective it is in treating arrhythmias, the more toxic it is in terms of causing a higher mortality. The only drug that is neutral on mortality is amiodarone. So amiodarone will reduce the risk of arrhythmias and is neutral on mortality. So the only real drug that you can use is amiodarone, which will lower mortality. The only therapy that is known to reduce mortality in patients with ventricular arrhythmias is this. I mean, it's what is called as an implantable cardioverter defibrillator, or ICD.
Sir, last 1 minute, sir.
Put like a
minute, sir.
1 minute. Oh boy. Okay. So it is put underneath the clavicle, and the leads are put in the ventricle where it senses the rhythm. It will detect a ventricular tachyarrhythmia and it will defibrillate. And as you can see, in a large number of studies in patients who have documented ventricular tachycardia, or even in those who have no ventricular tachycardia but have left ventricular dysfunction and have heart failure, because these are patients who are at a very high risk of sudden cardiac death, that in these patients, use of an implantable cardioverter defibrillator certainly saves lives. And it is aggressively pushed in major Western countries. Of course, in India, everything boils down to cost. And the value of life does not matter. But if you have a patient who has coronary disease, has less than 30% ejection fraction, is in heart failure, ideally he must have an implantable cardio defibrillator, because it certainly lowers mortality. So, in summary, sudden cardiac death is easily the most common cause of mortality. Unfortunately, in a witnessed event, the mortality is very high. External defibrillation, if you can handle in the first 2 minutes, it will work. AEDs in public places and trained people is what is going to help. Screening for coronary disease, structural heart disease is important. And of course, patients at high risk who have left ventricular dysfunction and have heart failure need to get an ICD. We can endlessly discuss the cost of the ICD, but this is a device that saves life. And it is important because we will truly understand sudden cardiac death only after it has placed its hand on someone that we love. And that is when you will know what is the importance of preventing sudden cardiac death. That is something that we need to aggressively pursue. Thank you very much.
Thank you very much. So the team Sterling, Bhailal and Zydus, the entire team has, supported us and ensured that how to manage the emergencies at site, may it be burns, may it be cardiac arrest, may it be any polytrauma. Thank you very much, sir. Thank you.
I would like to acknowledge that.
Hello. Fantastic, sir. In last 6 months, the sudden cardiac death also, personally, we have seen three, not less than 3. One, post-COVID, totally cured, but after 4 or 5 months, suddenly died. Second one was also something related to some morbidity. But yesterday my case, I will tell you, I wanted to check. 25 years, a young guy, no comorbid condition, no COVID, nothing. At home, he got the chest pain, died. Now, his all parameters, whether lipid profile and all were normal. Nothing. Only sudden cardiac death, but there was only one history. Before 3 days, he was having mild uneasiness, mild. He went to a hospital, got ECG, 2D code done, everything was normal. He put on the medical management. But after 3 days, suddenly at home, he passed away. So, okay, we know the sudden cardiac death can happen. Have anything you want to say, okay, in this case, we could have done before 2 days something. I would be more happy because I know, I will tell you, deep things we are putting across wherever our employees are there, everything, and training and everything. But this case was yesterday first way, just jolt to me, okay, some things which is happening.
Well, yes, I mean, just like you face sudden cardiac death a little less frequently than a cardiologist, because we get this chest pain patients who have completely normal ECGs and echoes all the time, and it's always worried. I hope nothing happens in the next few days if these are unstable symptoms, and there is no good answer. And like somebody said, that good judgment always comes with experience, and that experience almost always comes from bad judgment. You do something, you neglect something, you face the consequences of it, and then you decide that if I get any patient who has chest pain, I will do a protocol which will evaluate for good whether he has ischemic coronary disease. Now I agree that at 25 years of age, it is very, very unlikely. I showed you the slide that the most common causes are hypertrophic cardiomyopathy, anomalous coronaries, all these kind of things. So you will do an echo, you will do an ECG, but you will not take the argument further. But maybe the time has come where if you think the pain is typical for angina, some form of a stress protocol, either a stress test or a stress thallium, will identify whether he is ischemic, the chest pain is ischemic in origin. If it is, but as I said, you will get 100 patients with 25 years of age who will complain of pain here, pain there, pain in the back, pain while walking, pain, and none of them is coronary disease. So how extensive to go in terms of investigating is a matter of judgment, and that judgment usually comes with your intuition, or you have done something wrong. Like now, if you get a 30-year-old, I'm sure you will not say go home. I don't know, get a stress thallium. So at least I am sure that there is no ischemic component to your problem. That is the best thing I can tell.
Thank you very much, sir. I would invite our chairs to present a token of appreciation to Dr. Lale, sir. Thank you. And this session was sponsored by Zydus Hospital. Thank you.
At the outset, now I would like to thank all our hospital and other partners for the conference. I will like to invite our chairpersons for book token of appreciation, please. On stage, chairpersons Dr. Shirish Kumar Gandhi, sir, and Dr. Rakshit Akrowala. Dr. Sujata, please, if you can deliver a memento with Dr. Khyati. At the outset now, I would like to thank all of our sponsor partners, platinum sponsors, Bilal Amin General Hospital, OptiSurgicare, Reliance Industries Limited, Sterling Hospitals, Tricolor Hospitals, Unity Hospitals, Zydus Hospitals, Gold sponsors, BAPS Hospital, HCG Hospital, L&T India, Rhythm Heart Institute, Sunshine Global Hospitals, Shriji Hospital Chani, UPL Limited, silver sponsor Aditya Birla Group, and digital sponsor Cipla, because out of help of all of this, we are able to achieve such a successful conference in 2 days, and we really thank from heart team of IOH Vadodara to sponsor and help us in this event, making it a huge grand success. Thank you all of you. I will now request the delegates to proceed for lunch, and I will request our guest speakers and government dignitaries to come to first floor Emerald Hall and join us for a lunch. Please, sir. Thank you all for being patient and kind.
Dr. Rajesh sir mentioned. Good afternoon. Okay, so you all are awake. That is one basic validation question as a part of a faculty or speaker. So the subject is based on the theme occupational health challenges and strategies. So as a Reliance, one of the biggest corporate in India and have a global presence, it is very difficult for me to explain the strategies in 10 minutes time. But definitely I will explain you the difference between the other organization or world-based organization, how we are different and we are successful due to that. So before that, as usual, tactical. No issue, you all are aware about the occupational health as an occupational health physician. So no need to go into the definition of OH. You all are aware. नहीं चल रहा है. Okay. So this is the OH definition. Major challenges we all are aware. In any country, the major challenge is lack of legislation. Only majority of 93% are unorganized sector or informal sector when there is no legislation applicable. So only limited 6 or 7% of the organized company or developed company or corporates, they are following up the OSH legislation and all. So that is one of the major challenge as a country we had. Apart from that, the non-communicable disease burden and in due to COVID since last more than 27 months, the mental health challenge is also addition to the NCDs. Like pressure, diabetes, heart disease and all. So it's one of the major challenges as a country. Indian scenario, even for a legislation purpose also, the framework is different. Industry of labor ministry is different, family welfare, health is under the family welfare. So there is a different strata of the legal framework. So that is also one of the major challenges as interlinking. But this is about the country. Now going to our organization company. So Reliance, I don't want to give the introduction. You all are aware from the morning awakening to the night sleep time, majority of have a Reliance product. So Reliance's presence is all the field, hydrocarbon, geo, retail, consumer and also it's a Reliance company. This is the most important slide as a top management commitment. So our chairman firmly believe Reliance should be the most healthiest company in the world. So the first statement itself, the commitment of the top management, and it is not a statement, but I will differentiate how we are different from other. Like these slides, the framework of our strategy is based on the WHO model, that is one part. Apart from that, we have a health checkup data analysis over the years, that is another part. Apart from that, regular challenge like COVID pandemic era. So various factors into consideration before making the strategies. But the main I want to highlight, I am not going to detail into this R Swasthya wheel, but the difference between the other organization and our is, first is top management commitment, the already mentioned in the first slide. Second, how the top management committed, we have in steady state, that is 240 plus online, full-time doctors with us. They all are our Reliance family members. Full-time doctors with us, 240. Apart from that, during COVID, we have recruited 600. Dr. Rajesh mentioned 600 doctors during that COVID time. So that is the commitment of the management. So if doctor is full-time as a part of the family, then and then he has an ownership mindset. So because our company believe in 6 values and behaviors. One is ownership mindset. Second is customer value. Though it's an internal customer, external customer, we always believe to serve the customer, employee, family member, CSR, whatever. So it's a 2 value. Other is integrated approach. That is the one team approach, like integration with the HR, integration with the safety, integration with the environment. So it's an integrated approach as an organization from top to bottom. That is the success mantra of our company. So 3 I already mentioned, customer value, ownership mindset, one team. Apart from that, our chairman and we all believe excellence is our mantra. Whatever we do, we excel. We don't do any suboptimal work or anything. So excellence is also another, and apart from that, most important is respect for each other. So these are the 6 values and behaviors that is the differentiating factor and our sustainable growth mantra. So that I want to highlight. Otherwise, I will take you through all the slides, only list of the programs as a part of strategy. So as a centrally, apart from the framework, top management commitment and various analysis and use the world reference like WHO, CDC, we have defined the strategy. So our medical service model, we have divided into preventive, promotive and curative. It is very clear, before you go for the preventive aspect, first you have a basic health services to tackle the emergency. So first is backbone of the any medical services is the emergency services, that is the curative services. So we have a full-fledged occupational health center across our manufacturing locations, supported by ACLS, BLS ambulance, availability 24/7, 24/7 doctors, paramedics. So it's a basic unit as a curative services. So over the years, over the decades, we move from curative to preventive and promotive. So as a occupational health physician, we always learn prevention, prevention and prevention. So that is the preventive and promotive strategy. In preventive aspects, we have a strategy to tackle the occupational health risk related issues like occupational disease, occupational health hazards. We have various programs. Apart from that, we have an industrial hygienist. So I'm happy to share we have a 5 full-time industrial hygienists working with us, and they are the real ground-related thing to mitigate, to measure the risk as a recognition of the hazards, evaluation of the hazards, and control strategy for the IH occupational health hazard at the plant level. Apart from that, the more focus to tackle the NCD, we have a mental health champion, we have a Swasthya champion to tackle the work-life balance program as well as the lifestyle program. So based on all this paramedical or our medical services model, we have a various program. I can just go through that. These are the various strategy at our company to implement and to get the best result. One is CASE, you all are aware because it get recognized at the national, international level, change agent for safety, health and environment. It is the one of the most sustainable program since last 20 years in our company. The success of our program is people's participation, top management commitment, and integration of the occupational health physician, industrial hygienist, and the all manpower. So this is the success of program. You can clearly see we have started this program as a project in 2003, but after 3-4 years, this whole project become the enterprise-wide movement, and that is converted into program. Start with the basic 4 objective: zero incident, zero accident, no occupational disease, 100% PPE. But right now, since last 5 to 7 years, we have also used this framework to tackle the work-life related issues, mental health issue, diabetes control program and all. So that is the success of this program, and you can see the outcome in terms of savings, in terms of the reduction of health hazard. Second is critical task-based health risk assessment that we have developed and implemented 5 or 6 years back based on the AIHA model. Those who are industrial hygienists, American Industrial Hygiene Association exposure model, we have defined this program to integrate the job related risk, like any operator working in the plant, so exposed to chemical risk, ergonomic risk, noise related risk, indoor air quality, any other risk. So integrated program to manage or measure the risk, and what we can measure that we can monitor. And also we have integrated this with our health checkup. So whenever employee comes for the health checkup, we can easily see the profile of particular employee exposed to chemical, noise and that. So accordingly we have a focus approach to prevent the occupational disease. These are the structured monthly health program. We have a defined calendar based on the WHO days as per as our health checkup analysis and all. So this is the defined January to December. The objective and purpose of this program is tackle the NCD. But apart from that, the strategy is uniformity across locations. So at any given point of program, like in July, we have a blood donation and occupational health week celebration. So you can visit any our site, same program is going on. So that is the uniformity of the program apart from tackling the burden of the NCD. Diabetes control mission. 4-5 years back, my colleague Dr. Bhavin will explain you how at plant level or at site level we have implemented. Because at central level we just define the corporate strategy. So in this program the basic goal is conversion of pre-diabetic to normal. That is the one basic, because from over the years this pre-diabetic then goes to diabetic. So it is always to tackle them early. That is the one. Second is control of the uncontrolled diabetics, those who are above 7 HbA1c. So we have to control that diabetic. So based on these two goals, we have defined charter for this program, framework that should include physician, dietitian, psychologist, physical trainer, yoga trainer, monthly review, quarterly review, and at the end of the year, we have integrated this program with the annual operating plan. So there is no issue, we have to compulsory report all these things regarding the outcome. BMI, that is the 90 days weight loss challenge, that is also we have strategized across locations based on the defined format, defined criteria, how to go ahead, how to measure and monitor and tracking at central level, and same way at site wise they will implement and accordingly measures. Medical surveillance is the basic of the any occupational health services, like all type of pre-employment, periodic, pre-placement, pre-retirement. So these are the various services offered in-house. Based on that data, what I mentioned about the health checkup analysis. So this is the health index. Based on the analysis, number of percentage of employee above 90, those who are between 71 to 90, and those below 70. So based on this, we have a target group approach for the below 70 because they are the comorbid condition. So we can, like in same way in COVID, we put them in work from home. So, and during that also it's a focus approach by the chief medical officer of the particular site. So this is also one of the helpful for our various program. This is the most important and take away message for all of you. So since many years, it is not only occupational health, they were depending upon to manage the occupational health hazards. Gradually over the years, that convert into manage the lifestyle diseases. Few years back, it converted to holistic well-being, and now the concept is OH to OMH. It's on my health. So as a occupational health professionals, we have to also develop the culture and sensitize people. The health of the individual is individual responsibility. Apart from that, we can just provide the support through various very good strategies, very good outcome, or through various outcome measures. So this is all about the strategic part. Now Dr. Bhavin will explain about the plant level, how we implement each program.
गुड आफ्टरनून। फिर से एक बार बता रहा हूँ क्योंकि फिर से आवाज कम हो गया। हर सेशन के पहले एक वैलिडेशन चाहिए ना। गुड आफ्टरनून। सो गुड आफ्टरनून ऑल डिग्निटरीज ऑन द डायस, ऑफ द डायस, एंड So Nikunj bhai already mentioned some of the strategies at the corporate level at Reliance. And in fact, implementation of that strategy at the field office is one of the challenges for us, because as already mentioned, that all strategies at a corporate level defined is at the highest level of health level strategies. So we want to maintain all the strategy, all employees' health at the highest level, and this is one of the biggest challenge. So now, already we all know that occupational health is physical, mental, social well-being. Already you have seen that our chairman sir a statement that he wants each and every employee's health at the highest level. So at the site level, we are not different, and I am sharing the data of our site, that is Vadodara Manufacturing Division, and our site vision is also the same, that is to operate Reliance VMD with highest regard to health, safety, reliability and compliance through total enrollment of employees and stakeholders for continued improvement. Just I want to give you this is an update actually. Previously, before 2 years, health part was missing in this vision statement, but since 2 years also, health part is also in the site vision. 3 main areas, focus areas of health services. These are the main routine services. These include the pre-employment medical examination, periodic medical examination, 6-monthly medical examination, or comprehensive health checkup for spouse or biological monitoring, or special medical examination. That comes under the OHIS services. Second is consultation and routine emergency services. And third is health promotional and public health activities, which include the NCD programs, mental health programs and health awareness sessions. Now, what are the new challenges and strategies at the site level? Rajesh sir has already mentioned that COVID is one of the biggest challenges that come since last 27 months, and rise in non-communicable disease and mental health issues. They are main other challenges at the site level. So what we did at Vadodara Manufacturing Division, number one, we have in-house RAT, RT-PCR testing at our township medical unit, and every day around 700 RT-PCR are being tested at our this township medical unit for employee and family members. We have rapid antigen test facility available. 35 bedded COVID care center. Yesterday Dr. Vijay Shah sir was also mentioning about the same, that we have built our own COVID care center at our facility, forecasting that the COVID will have much more requirement of number of the beds than expected, and we may need a facility in which we will be able to take care of employees and family members. Also at the second wave, you must be knowing that the most deadly wave was perhaps the second wave, and in the second wave there were some cases in which getting bed for ICU facility was difficult, but we forecasted that we have established 10 bedded ICU. In case we do not get any bed in any tertiary care center, we have the facilities at our own center also. Also we have 2 oxygen plants. At some point of time, there were the times where in the newspaper every day there was a headline, oxygen is less, only 1 day oxygen is left. So we have our oxygen plant also. So as a result of that, all our needy employees get the bed, and I am very proud to say that for not a single case it happened that employee doesn't get any bed or any family members. Now regarding COVID-19 vaccination. COVID-19 vaccination, I very well I am able to recollect when the DHO come to our site, he saw our vaccination facility, and his statement was, this is the best facility and perhaps the most ideal facility for any vaccination center, and perhaps we are the first center to get approval from the government side, and we started operational at the very beginning. You can see pre-vaccination, vaccination, post-vaccination, various areas. Rise in non-communicable disease. I have analyzed the PME data of last 3 years and I found that, and you must all have if you will analyze at your side, definitely there is rise in the pre-diabetic prevalence, uncontrolled diabetes prevalence, uncontrolled cholesterol levels, high BMI levels, all prevalence are rising. So, we have our diabetes control mission since 2018. But what we did in this year, on 28th April 2022, our site president has kicked off intensification of the diabetes control mission. So we have now more intensified efforts to combat all diabetic cases. Especially we are targeting all employees with HbA1c more than 7 to get their HbA1c level in control range. For pre-diabetic also, we are targeting the employees with 5.7 to 6.4 HbA1c level. We are doing HbA1c as a part of our PME for all employees. Now, this is the basic strategy. In one line, if I want to, to narrate this strategy is, we go for case-based strategy for uncontrolled diabetes and group strategy for the pre-diabetics. So in case-based strategy, employees with more than 7 HbA1c we take at baseline, and we do one-to-one consultation with physician, dietitian, counselor and fitness trainers. And we evaluate FBS, PBS and HbA1c after the 3 months gap. And second is, for the pre-diabetic, we are going to the plant level. All our doctors go to the respected plants. They are already assigned 4 to 5 plants. We are 4 OSC doctors. We have 15 plants, so each doctor is having 3 to 4 plants. And at plant level, we are going for the sessions. And the questions and everything, they address it there. We have developed a modular PPT, and we are using the same PPT across. And quarterly HbA1c assessment we are doing. Same for mission Fat to Fit, that is 90 days weight loss challenge Nikunj bhai has already mentioned, and in which we are again going by case-based or group strategies. What we have additionally done at our site at Vadodara, that at prominent locations, 6 prominent locations, we have put weighing scales. So employee can monitor the weight whenever they go to their prominent, either of these 6 locations. So these are some of the photographs. You can see we have our NCD clinic, non-communicable disease clinic, at our OS itself, and in which we have comprehensive package. Doctor, we have dietitian Monday to Saturday, then we have fitness, activity consultations, we have consultant visits at our TME facility. So if anyone is having uncontrolled diabetes in our NCD clinic, they are getting checked for diabetic retinopathy screening also, and psychological counseling we are doing with the help of Silver Oak, and we ourselves are also doing. And this is evaluated every quarterly. These are the pre-diabetes and high BMI strategy photographs, which include session of diabetologist, fitness trainer session. As you can see, we are using the digital platform in this slide. Dietitian session, yoga session, session for high BMI. Also to involve the spouse, we have done healthy recipe competitions, and we also give them proper guidance by the dietitian that how you will make some healthy recipes, because it was observed that whenever we advise something to the employees, they usually do not say anything to their home. So if the spouse are involved who are actually making the food, then it will be more beneficial and we are getting the result.
2 minutes left.
Yes. Plant level sessions, FAQ booklets, etc. we have also done. Already various health awareness activities. Nikunj has already told that we have structured monthly program. For each month, one activity is defined. So at the site level, you can see blood donation camp. Our site president is inaugurating that at both locations. We have cardiology sessions, Zumba sessions, psychiatric sessions, cardiac camp, BMD scan camp, video competition, poster slogan competition, etc. Actually, there are more activities, but I am putting some of the activities only. Also, theme-based sessions we did for hearing conservation, heat stress, yoga, IAQ. For mental health, we have our in-house mental scoring, so all employees during their PME, they have to fill up one scoring form, and for that scoring, based on the scoring form, we decide whether he should be counseled or not. And we have Silver Oak support, as Rajesh sir has already mentioned, and for mental health awareness, we are doing various sessions also. Also, we are doing that theme-based. Every month there is one different theme based on our Swasthya platform. As you can see, there is psychiatric session, Dr. Yogesh Patel sir, Silver Oak session, meditation session, and de-addiction session. This model is pandemic proof. That is the digital model. We have our own house HMS, that is health management system software, since a decade, more than a decade. But now GeoMed, Teams, and GeoHealth, these are the three platforms in which without physical interactions we are able to achieve many things. SMS, social distancing, is actually, for our side, it is not actually social distancing, it is physical distancing, but we are socially interacting as well as communicating each other more frequently with the use of this application. So what was the outcome? Till date, 100% employee got the bed during COVID-19 peak. 100% employee and agency staff at VMD are fully vaccinated. Nobody without 2 doses is coming inside the plant. 27% employee converted their high HbA1c to normal, more than 7 HbA1c baseline, and at the first follow-up, 27% were normal. 21.6% pre-diabetic were converted to normal, and 11.2% employees converted from high BMI to low. It is well said, Pehlu Sukte Jate Nera, and we are trying to do everything that is possible for the wellness at our side. Thank you.
Yes, thank you, Dr. Bhavin. So in short, if we sum up the session of Dr. Nikunj, what he clearly mentioned that there are the major challenges are there for everyone, for every OH physician, whether it may be OHS policy, OHS infrastructure, and the most important, since the COVID started, the burden of the NCD. So we all need to work together at our individual entity level as well as in team, whether it may be organization, culture, and the strategy and the vision of the management toward health should be included. We need to incorporate different programs so far as the OHIH, public health, EMS, that is the emergency management system, and the wellness programs they are concerned. Like Dr. Nikunj has rightly mentioned, at our organization, structure monthly program, CASHE, health index, this diabetes control mission, and weight challenge program. So these are the few at a one organization, but similarly we need to all can take up at our organization for reducing this all kind of the burden. And so far as the Dr. Bhavin session is concerned.
Not working? Dr. Bhavin has highlighted the big challenge which we know. In the morning Dr. Rajesh has already said how we had to face the bad time of COVID, during COVID and after the COVID, and so nicely handled that we developed our in-house facilities right from the A to Z. Diagnostic, curative, separate OPD facilities and so on. And especially the new facilities like especially high diabetes and index and the online sessions, and especially in the morning Dr. Rajesh mentioned regarding the COVID first aid counselors. The point to note, and especially we appreciate and we thank you for your knowledgeable and good session. Thank you very much.
Thank you so much. This session was sponsored by Reliance Industries Limited. Now I invite upon our chairs to facilitate our speakers with memento, please.
Bye.
अभी क्या संतोष दाता का पहले किसका है? Hello. Friends, it's my pleasure to introduce you to the eminent faculty, our friend Dr. Santosh Datar, who has travelled all the way from Mumbai to address us, all of us, and this August gathering. To his credit, Dr. Datar is a very senior occupational health physician with experience of 34 years. He has diploma in anesthesiology, diploma DM in industrial medicine, AFIH, and DHA, diploma in hospital administration, PG DM LS, PG diploma in medical legal system, which is expertise, and I have got an opportunity to hear him on this topic many times, Mumbai and different places, national and local conferences, and he has expertise. He is lead auditor for training courses for the ISO 9001-2000 quality management system, BS OSHA's 18001-2007 OH and OHS management system at NAB accredited courses. He also worked in L&T, Mumbai. He also worked with the Oil and Gas Natural Commission, Hindustan Insecticides, and he has a rich knowledge which he has gained out of vast experience in different industrial sector. So now I will not be in between you and Dr. Datar. I will directly hand over to Dr. Datar. Sir.
Thanks for the kind introduction, and thanks for the invitation also. So let's go into what is audit. The Oxford Dictionary says audit is a systematic review or assessment of something. So ISO, all this ISO 9000 and all that, they say it's a systematic, independent, documented process for obtaining audit evidence and evaluating it objectively. Everything is important. When we conduct any audit or assessment, we collect objective evidence. I am doing very good. Auditor has no value. Sir, I am doing it, but records are not kept. It has no value. Objective wants to see what he can be seen. That is objective evidence. And then evaluate it objectively to determine to which extent audit criteria are filled. I'll explain to that later. So, what audits a company doctor may face? There are various types of audits. One is your quality management system, EMS, environment management system, OHSMS, that is occupational safety and management system. Yeah. Then statutory audits, that is ISO 14489, every tiers you are supposed to do in industry. Some organizations, they have internal standard, they don't go for external audits. And again, NABS standard if there is a hospital. So there are various kinds of audits. Sometimes the factory inspector may come in and the medical inspector of factories may come in. So what are the types of audits? First is the first party audit. That means you are assessing yourself, and that covers our internal assessment. Second party audit. That means it is conducted by a party which is interested in you. Like suppose you are a client, before giving order, he wants to evaluate you. And third party is a very authentic audit. It is done by people who are totally disinterested, not connected with your work. So most of these external audits are third party audits. So there is always a confusion between audit and inspection. Many times when I go for audit, sir, आप inspection के लिए आए हो. It's not inspection. It is always against the standard. A good auditor will not go by his whims and fancies. I want this and I want it. He or she will stick to the standard. It's a fact-finding process, not a fire-finding process. And audit aims to determine the conformity of the standard. That means something is written here, what I am going to see in the audit, that are you doing it or not. We see the intent, we don't go by checklist, very critical. So audit results, many organizations give in a different forms. One is a good practice. We always start with positive put. Okay. Like one child comes to the father, shows the mark sheet. He has scored excellent marks in all subjects except mathematics. What the father will say, why you score less in mathematics? So it's a human tendency to find the faults first. So we always find the good first and then go to the faults. Non-conformities measure, that means something written in the standard, you are not doing it, and any failure for statutory compliance is a major critical non-conformity. Minor, that means you are doing something but not to the full extent. Areas of concern, that means if you don't address this, next audit it may turn into a non-conformity. And of course opportunities for improvement. We have done a lot of audits, so we come to know about some best practices which we advocate. Now how do you prepare for the audit? Be knowledgeable about the standard. Many times I find the doctors in the OHC are not aware of what is ISO, what is OSHA's. You won't believe this. What are the legal provisions in the Factory Act? They don't have a Factory Act state rules book with them. They are not aware of the biomedical waste rules. So be knowledgeable about the statutory requirements. Very, very important. The auditor expects you to know that. Become an internal auditor. The best thing is undergo internal auditor course. If your organization is certified for the external audit, undergo internal auditor course and you will you'll learn a lot of things. Participate in the manual preparation, HIRAC. Now what is HIRAC? Anybody? Yes. And can you believe in many audits I have found doctor is not involved in the HIRAC. It's not doctor's fault. It's organization fault. Safety prepare people prepare this HIRAC and only false trips and everything comes. The chronic effects do not find place in the HIRAC, and that is the biggest problem. Doctor doesn't have a HIRAC copy. Okay, so that is another problem. So this is a fundamental tool for control of occupational hazards for the doctors, for the safety professional, and for the environment also. So I can talk about risk assessment for 2 hours, but just to give a gist, assess the hazards and risk. Risk is hazard into probability. Just because hazard is there doesn't mean the risk is there. Plan and implement controls. So when you implement control, the hazard remains the same, the probability goes down. So reassess the risk after controls. It cannot never be zero, but it could be acceptable risk. So this is the basic plan of risk assessment, and every doctor, every occupational health physician should know it, especially for the chronic hazards. Then there are different methodologies, walkthrough survey, very best tool, documentation, yes, staff interview, talk to the staff. Whenever I go to the audit, people give, oh sir, we are certified for first aid. Don't show me the certificates. Call one of the first aiders. I'll give a say, if you patient start, what will you do? And there you come to know. Because first aid is a skill. If you don't practice, you are going to lose it. Okay? So what I have advocated is a first aid skill testing, SOP. Those who are interested, I can send it to them. That you give a case and ask them to assess it and how they are doing it correctly. Testing the SOP, of course mock drills and all those things. Use of tools, RULA and RUBA, that is mainly for ergonomics, rapid upper limb assessment and rapid entire body assessment. And of course use of apps. So please download these apps, they are available on the Google Play Store. Sound meter, Lux meter is available, and this is an excellent tool, ILO ergonomic checkpoints. Please download it in your mobile. It will be very useful to you, while conducting the audits. Now, why internal assessment? Even if your OSC is not certified for external audit, You must take the lead. As Dr. Rajesh said, you must take the lead, go to the organization, go to the manager, I want to do this. So you know your system best. We only will come outside, see something and go away. You know what you are doing. You come to know the deficiencies. You take corrective action in time. That is very, very important. A stitch in time saves 9. Keep checks on the staff. When they know the doctor will come anytime and check my records, check my fridge, check my whether the water in the humidifier has been changed or not. They will be also on their tests, and slowly they will also learn. And also medical legal importance. That if you have done this, it has great medical legal importance. So proactive and reactive. By nature we are reactive. We do something when something has happened. So in doing internal assessment yourself is a proactive step. It relieves stress, all of you know it. It helps you to work smart, not hard. And it improves quality. So internal assessment audit, prepare a plan, define audit criteria and scope, what are you going to do. You need not do all the departments. You can take certain section. Today I will see the documentation in the OSC. Next audit I will see the emergency preparedness. So you decide what is to be done. Audit checklist. I have given a sample in your souvenir. It's an indicative sample, so you can go through that. Audit observation, document, and corrective preventive action. That means you have to prepare a definite timeline. I found this deficiency. And when external audit comes, he finds it and you show, sir, we have already found it and we are working on it. This is our management action plan. It is called MAP. We are working towards it. So that auditor may not give you a major non-conformity. He knows that you are doing something. See, as a good auditor, I will see the intent. Okay. So frequency could be defined in your ISO document, quarterly, fourth monthly, it's up to you. Generally every quarter is advisable. And you may cover some work areas in the audit. So this is as far as the internal assessment goes. But what is external assessment? Audit is there. Doctor, NC nahi chahiye mujhe. Every management expects this. And no adverse remarks. So it's all well and good. It's very difficult to practice. So auditor expectations, awareness about standard practice. Nothing irks the auditor if you don't know for what that person has come. Nothing irks the auditor if their records are not found. If, sir, I want this phone. Arey sir, jaldi record bhejo. It irks the auditor. That means you don't know where your records are kept. No, you are just firefighting. Compliance with the statutory requirement. I need not explain this further. And what we see is a general conformity to the standard. Not very 100% nobody is compliant. Never. Nowhere in the world. Preparation for the audit. Start preparation well in advance. One day I had gone to the audit. Temperature refrigeration where the vaccines are kept. 2. What is this? I said, kal bhara na? Yes sir. Manipulation करना है तो थोड़ा दिमाग लगा. सब 2 क्यों लिख रहे हैं? Okay. So don't do last minute preparation. It gives you stress. Prepare your staff. Go through your records and complete them. Review every week. Final brush previous day. Take a round. Everything is ready, and it's a good idea. Now there were virtual audits because of the COVID. Now the site audits have started. So identify a room. Keep all the records there. So preparation is the key. Allocate a room in OSC, so keep all the records there so you don't have to run anywhere, and auditor will be impressed. He will be happy. Anticipate and keep all documents handy. So you anticipate what the doctor is going to, what the auditor is going to ask. So once you yourself internally assess, you know what documents will be required. Do a walkthrough survey in the morning. What documents? All licenses and registration certificate. Many times I get the answer, sir, I don't know. BMW certificate, environment has. But it's a good to have a copy. Many times the nurses qualification, it is not renewed. The nursing council registration is not renewed. Neither the doctor is aware of it, neither the HR is aware of it. And she gives a nurse, she gives an injection. The nurse gives an injection and something happens to the patient. Even if you have not done nothing wrong, just because of this, the nurse, you and your company can land in suit. Because the moment you don't have a valid registration, medical council registration or nursing council, please see that all the documents are in order, they are valid. Qualification and experience certificate. Iraq, I told you, all of you must have Iraq. Okay, go to the safety, go to management. I want to get involved in Iraq. What is this? And many times in the Iraq, I see vague things. Hearing loss. No, hearing loss not the correct term. What should be the correct term? NIHL. Okay, so it has to be very specific. What is Iraq? Today, a new engineer and doctor has come in the company. He opens the document. He sees and he comes to know what are your hazard. At least 90%. That has to be that Iraq has to be perfect. Legal register. What is legal register? I have prepared this. What I do is just write down, suppose you have got an X-ray machine. Okay, so just write down the clauses. And every quarter you just keep on ticking it. Yes, I have complied, I have complied, I have complied. So you are also update. So this is called legal register. Medical records, health register, that is your periodic checkups. Vaccination records, many times I do not find vaccination records. You don't know hepatitis, especially hepatitis B vaccine. AMC and calibration for imported equipment. I always ask the nurse what is the first aid for neurasthenic injury. 70 to 80% time they are not able to tell correctly. Okay, I always ask the Ayabai, how will you clean the spill? Somebody has vomited. How will you clean the spill? So those answers have to be perfect. So this BBP training, blood-borne pathogen training has to be perfect. SOPs and staff training records. If you have trained the staff, but training is just, it's not document. You have to assess the training. So I use a tool before and after. So before and after, and if they are improved, that means your training is effective. So it could be a text, checklist, flow chart. How much time I have? Excuse me? How much time I have? Yeah. Text, checklist, flow charts, pictures. So it need not be a document. You know, in one of the ICU hospitals ICU, I have seen how to turn the patient every 2 hours, bedridden patient. That itself is a SOP. There are no words, there are only pictures. How to interact with the auditors. Receive them with smile and courtesy. Okay, be gentle, polite, dignified. No, yes sir, yes sir, yes sir. Okay. They are not gods. Do not argue with the auditors, for heaven's sake. Don't argue. Sir, I have 30 years. I have done this, I have done that. The auditor is not interested in that. You show me what you have done. If you are, as an auditor, for me, if you can't show me the objective done, you are not doing it. It's as simple as that. Do not give excuses such as lack of support from company hospitals. Sir, I have asked to management, but they are not giving. Very bad. It creates a very bad impression about yourself. It creates a very bad impression about your organization also. Do not appear negative and stiff. Do not sit on the edge of the chair. Be relaxed, confident. And if you are well prepared, you will be relaxed and confident. Keep open mind. Disagree politely with sound logic and evidence. And sometimes non-medical auditors also. I was facing an audit and we had an audiometry room. So the auditor asked if the person collapses on side, is a claustrophobia, is a very small room. How will you bring him out? Because the door is opening inside. It will be blocked by that fallen body. Absolutely right. The next day I called a carpenter and got the door reversed. Okay, so even the non-medical auditors can give you valuable suggestion. Please value that. And if you can disagree, but with sound logic evidence. Do not beat around the bush. Be frank. If you are not doing anything, say I am not doing anything. It's fine. It's okay. Because the auditor knows when you are lying. Or auditor knows you are trying to deflect the subject. Okay. General cleanliness. It is said that the standard of the hospital is, or your clinic is known by the quality of the bed sheets. So this is very true. Everything should be clean. And not only when the auditor comes each day. Housekeeping, cylinders, a non-auditor always will check the oxygen cylinder, whether it's filled or not. In one of the audits, I found the spanner is missing. So why? How are you going to open the oxygen cylinder? Sir, no, udhar se leke gaya hai. Wapas rakha kyun nahi? So these things, in a walkthrough survey, you come to know. Medicine store. There should be no expiry medicines. If there are, keep it in a separate box and label them. Any non-working equipment should be labeled that it is non-working. Clean toilets. Waste disposal is very important because a non-medical auditor will go on this. Emergency case management, perfect. Health education material, you can have a lot of displays. First aid boxes, up to date. So friends, audit is an opportunity. So prove your competence, prove your manager and leadership skills, and affirm your contributory role in the organization. So it's not a problem, it's a biggest opportunity for you to show that you are not an expense department, you are a highly contributing to the company's productivity and quality. Do you have some more time?
Yeah, we have 2 minutes.
2 minutes. Okay, I'll just quickly take on calibration because I kept it at last. So, calibration is very important and there are many, sometimes misconceptions, so I'll just clear it. Anything that measures requires calibration. So, this is atomic clock accuracy, 10 minus 9 seconds per day. So, why calibration? Accurate reading, quality of service, safety, medical legal value. I'll just run through. You can just read it. So the auditor will ask you about calibration. So prepare a list and get it calibrated and set alarms. You can't remember everything. So set alarms for renewal of licenses, set alarms for AMC, set alarm for calibration. And sometimes these electronic items, they cannot be calibrated many times. Pulse oximeter, how will you calibrate? So it can be validated. That is compared with the another item. Follow manufacturer recommendation generally once a year. And you can do internal calibration also. So I'll skip this. So if there are any questions, I'll be happy to take.
Thank you very much, Dr. Datar sir.
Yeah.
Audit is in occupational health or in any industry, it is something which starts from the first day. We also learn audit slowly, and I know my first day when I was in industry some 20 years ago, there was no occupational health center. It was in the process of getting down. One of our friend, safety colleague, was handling the things. The auditor came from US. I was not there. I was not in the picture. He found some expiry date medicines in the refrigerator. Next day on my next visit to the factory, my safety officer called me and fired me. Why it is like that? I never knew why he is firing me. But today, Dr. Datar has elaborately cleared the concept of audits for all the doctors. He has said every answer, why, what and how. Not only like this, he has also emphasized the enhancement of documentation skills, right? And he has also highlighted the new concept in the audits. So I think very beautiful and complete presentation. We thank you him for this. Any question from the audience, please?
Oh, that will take 1 hour. That you are talking of 45,000. See what has happened. Earlier 18,000 was an independent document. Am I audible? Earlier it was an independent document. It was not part of OSHA. But when it became 45,000, it became a ISO document. And the beauty is they aligned with lot of clauses in the QMS and EMS. So it is very easy for you to prepare the manual, especially when you are going for the integrated management system. What is integrated management? That means you cover all the three in one document. That is, you only prepare one module. There will be one audit. So that is the beauty of it. So most of it is same, but it is aligned with the quality and environment. Thank you. Yeah. 45,000? What is that? No, I am not much, I don't have, I mean I have not read about it, so I don't want to comment. Is it something like that? 45,003? Yeah, possible. I heard it, but I have not read about it. Recently, yes. Thanks for the knowledge. I will read it now. Thanks. So when you don't know, say don't know. Simple. Auditor will be happy.
Kalra, you want to ask something? Yeah, Dr. Kalra want to ask something.
Yeah. No, you go by manufacturer recommendation. And usually it is once a year. See, like you do induction now, always do machine induction. Whenever any new machine comes to your OSC, open the manual and see what are the guidelines for maintenance, what are the guidelines for calibration. Like in AED, it is very clearly mentioned, it does not require any AMC, it does not require any calibration. So always go by manufacturer guideline, you are safe. You are able to show it to the auditor. The manufacturer is saying this. But if you suppose you want it a little critical, you can audit little more frequently. Okay. So see, law always prescribe what is minimum. You can always do more.
Okay. Thank you very much, sir. Now I invite our chairs to present a memento to Dr. Datar, sir. Our next session is sponsored by Unity Hospital, and I request our chairs to call upon guests.
So, our next speaker is Dr. Vaibhav Aterkar. He is practicing in joint replacement surgery and specialized in orthoscopic surgeon in Vadodara. To his credit, he completed MBBS and Masters Orthopedics from Medical College Vadodara, and he holds a gold medal in the executive. So, he also, to his credit, has specialized in robotic surgeries and revision, that is redo joint replacement surgeries, which is a new concept in. And he has variety of rich experience, gaining his knowledge from Bridge Candy, Hinduja, Mumbai, Hylam University, South Korea, and also to his credit has a fellow of International College of Surgeons, FICS, USA, and also having MRCS and so on. So now inviting Dr. Vaibhav Aterkar, and dice is to you, sir.
Thank you, chairpersons, for the introduction, and it's an honor to speak in front of an esteemed audience. Considering my core competency, I would be having a more practical approach towards latest technology in ergonomics rather than academics. Okay. So these are my disclosures. So, considering the future aspects, the futuristic point of view in ergonomics, it is worthy of mentioning what an industrial revolution is. 18th century, it was 1.0. It was just steam power. Every 100 years, the industrial revolution has evolved to an electricity point of view, electronics point of view. Since last 2 decades, it has gone to Industry 4.0, which is advanced robotics, 3D printing, Internet of Things, and much more. So, to start with, what is ergonomics? Ergonomics can be simply plainly defined as study of the people in their working environment. So, the designs or modifications in the work to fit the worker, and it is not the other way around. You fit the processes and the instruments to the worker, to the human way, not the other way. So, what is the goal? The goal is to eliminate discomfort, risk of injury to the work, to enhance performance of life and quality. So the Executive Council has defined it this way, as everybody might be knowing. So the most important line, what is fitting a job to a person? So human factors and ergonomics are concerned with the fit between the user, equipment and the environment. The entire process is an intersection of all these things. So it accounts for the user's capabilities and limitations to ensure that the task, functions, information and the environment suits to the user rather than the other way. So when we are evaluating ergonomic point of view, there are 3 ergonomic stressors which are given importance while evaluating the job. The first is what is the force required to complete the task, awkward or static working postures, and the repetitiveness of the task. Any of these factors in singularity or in combination may place a human at particularly a greater risk or discomfort. So what are the challenges in today's workplace? It is increased task complexity, awkward postures, confined and restricted workspaces where it is difficult to work for a human to accommodate themselves. And traditional ergonomic solutions are not applicable. You cannot apply all the general principles of ergonomic solutions to all these workspaces. So before going to the futuristic point of view and the latest advancements, we will know what are the traditional ergonomic practices and what are the limitations of those methods and practices. So it requires a skilled ergonomist and their team, which is actually, they might have a subjective error, which is human observation based. There are accuracy concerns sometimes, interruption of the worker, so there are man hours lost, and it's a time consuming analysis. So what are the objectives of today's lecture? We will be covering these aspects, which are exoskeletons, wearable sensors, computer vision and AI, virtual and augmented reality, robotics, gesture control technology, and embedded technology. So to start with, usually when we hear of robotics, we just think of automation, that the robot is doing everything. This was 20 years back, 30 years back, but now the concept has changed. The robot entirely doesn't do everything. There are certain workspaces in which robot cannot function in a fully automated way. The human element and the human interaction is required, which is known as a human-robot collaboration. So it's a concept of shared workspace. The human and the robot share a workspace in which they work in unison. So this is an example of how a local workspace and a remote workspace. The local workspace is being used by the human or the worker in the factory. The remote workspace is where the robotic automation is being taken place. But if you see, both the workspaces are connected with each other. So what are the objectives of human-robot collaboration? It is a comprehensive system, both from an ergonomic and a communicative point of view. It is to merge the robotic capabilities and human capabilities. Okay, the human has capabilities of cognition, thought process, analytics. So basically, considering both point of view, we require an HRC. So as I told you, robots have the capabilities of performing precise movements with repeatability. Humans have the faculty of cognition, recognition, creativity, and adding final value to the product. So what is coexistence and synergism? A robot can work alongside with humans without using barriers in a shared space. Humans can communicate with the robot by using the interface in a simple and intuitive way. Robots can lift heavy objects and for a long time, which are the limitations of humans. This is usually underestimated, but in the long term, it definitely makes a big difference as far as the ergonomics is concerned. So I have compiled a video, which is how a robot is taught in a small workspace. Once the robot is taught how to work in a small workspace, it can automatically generate its own program. So this is how a robot has been taught to do a particular thing. This is a very small example. It can be any tool at the end of the effector. So once this robot has been taught in a confined workspace, this is how the synergy occurs. The same movement occurs, what has been taught, and this can be customized according to a particular application. The biggest thing of robotics are confined workspaces when actually humans cannot reach. Okay, hazardous places where it is difficult for us to reach. In those spaces, these are continuum or flexible robotics, which can reach small places. They have fiber optic cameras as well as tools attached to their ends, in which they can go to a particular place. The best thing about these robots is they have a memory. They remember their path where they go. These robots have joysticks or other manual operative modes attached at the end user interface, in which we can direct the robot to go to a particular place do whatever execution tooling which has to be done, and they can come back to its original workplace. So ergonomically, things which are beyond the reach of human body can be reached by machines. So what are the advantages of human-robot interaction? First, remote teleoperation can be done, where physical integrity of the human workers may be compromised. Secondly, the synergistic effect, complex operation in tight spaces can be dealt with. It gives good precision and strength also to carry out that particular operation. Thirdly, cobots. The robots which I have shown are known as collaborative robots, or cobots in short. Cobots could operate as assistant in shared workspaces to reduce manual handling and improve ergonomics. So why not full automation? So high value and low volume are labor intensive tasks. So we cannot apply full automation process at these things. They take a lot of time and are labor intensive and expensive also. In those cases, we can do what is a human-robot collaboration. So considering all these factors, two major concepts that come here are the consciousness cloud and augmented workspaces. Whatever I showed you basically is a part of that everything. So in a modern manufacturing scene, the robots, the human worker, everybody are in a synchrony. So every process which is going on in the industry has a closed loop in which the human element is always there. After robotics, the second thing which comes is gesture control. Usually, gesture and verbal commands are best perceived in an industry, or for that matter in our practices also. While we operate in surgeries, during the surgeries, it is difficult for us to talk, or maybe the ground staff won't understand, but they definitely respond to gestures. So ergonomics, gesture machine interaction is a very important aspect. So basically, if you can see, there is a small device attached to the computer. It is known as a leap motion controller. You can have 10 gestures controlled over it, and you can control any machine interface with it. So basically, verbal and gesture communications are inseparable. So in the industrial settings, due to restriction of the working environments, like in crane operators, you have to do hand signals. So the gesture communication part holds best value in such unstructured and open workspaces. So contactless gesture user interface enables HMI using natural movements and is a preferable option for this kind of research. It is a bit new in its this thing, but still it's going to evolve with time. So these are the kind of gestures, those are being used. All the 10 fingers in combination or in singularity can be used to control any machine. So this is a type of gesture. I can program it with any finger or 10 fingers in combination for the robot to go at a particular place. So what are the application goals of such gesture control devices? So they can be considered as secondary input devices in which a person actually cannot read the site of this particular operation. So walking long distances, reaching hazardous places will reduce the risk of MSD also. Targeting applications in system recovery and error correction, it does not require any significant training because they are natural movements of the body. The next thing which comes in line are wearable sensors for ergonomic assessment. Many of you might have heard there are wearable sensors which can be attached to different parts of the body. So they are attached to the employee or the person while he is performing a particular work task. These sensors are both useful for in-office setups also, for those who have continuous desk jobs, or they can be applied for industrial workplace also. So there are different versions of sensor based. So they are accelerometer and gyroscope based devices. They can be used to determine force application, gather muscular activity and awkward posture measurements also. So these are the type of sensor technologies that are already there. So how does this sensor work? Basically you apply the sensor to a body, a part of the body that you have to record the movement of. You have to connect it where it will be connected via Bluetooth or Wi-Fi to a specific software module on your phone or on a PC, it will record gestures, something like this. So the sensors have been placed on this particular person's back. Whatever activity he is doing in his own industrial environment will be completely recorded. After the recording, all the graphs which have been shown in this particular video can be analyzed, and a particular abnormal posture or movement can be recorded and can be corrected. So the next thing which is artificial intelligence using computer vision. This is the same as sensor-based postural assessment, but actually it doesn't utilize sensors. It utilizes high-end cameras which can actually assess human body pose estimations. So computer vision technology uses artificial intelligence and deep learning softwares. So it is used for assessing an operation or task using videos from cameras. There are no sensor or devices which are required for the body to be placed on the body. So traditional ergonomic assessment, as I already discussed, there are inaccuracies and inconsistencies, as well as they might have some subjective errors also. So a camera sees what a human eye can't see in fractions of seconds, in milliseconds, and it can be recorded. So this is computer vision. It can use facial recognition, object detections, object trackings. So this is a type of computer vision. You are recording a video. It will entirely give you all the coordinates, something like this. These coordinates, the recorded video will go to a software which it will be analyzed. I'll just show you a video. So this video particularly shows you have to record a video of the person doing a particular task. Once the video is recorded for 4 to 5 minutes, it can be just uploaded into the software. The software will analyze based on the joint positions and the relation to the back and neck. The entire angles can be recognized and can be categorized into safe, cautious and hazardous practice. All the hazardous practice will be labeled in red, and those postural and behavioral assessments can be changed with time. So as you can see, rebar and Rula traditionally are partially automated systems, but this will give you a fully automated system and give you full analytics of how the human body is behaving and moving, and changes can be made accordingly. So the analysis gives you how much physical strain is borne by the human body at that time, and support preventive actions and automatic assessment of abnormal body posture and ergonomic risk. So what are the infos provided? The infos provided are you can continuously have a risk assessment of each worker with a continuous monitoring system, vision-based behavioral assessment, and short-term and long-term ergonomic risk. So what are the results of artificial intelligence and machine learning? You can give personalized recommendations to the worker, postural correction, and high strain condition you can prevent it by giving the worker some days off. Next comes exoskeletons and exosuits. Usually you might have seen Iron Man movies, okay, but it is far from future. So we have exoskeleton is a suit-like structures that is intended to change how the body exerts the force on other objects, or how a particular movement is experienced externally by that suit. So these are the kind of suits which are already available, and so exoskeleton can be viewed as it can be augmenting a person's strength, so it can make a human stronger, and reducing the strength exertions to lighten the load of a particular specific task. So basically there are two types of exoskeletons. One are battery powered exoskeletons, which actually help in synergizing a particular movement of that worker, and passive exoskeletons are to lighten the load of the body. We'll just have you can see a video in the next session. So this is an active exoskeleton. So it augments the grip strength of that such particular exoskeletons can be augmented in the entire body, and a particular worker can use strength of that particular exoskeleton in doing tasks which usually cannot be done. For an example, if a worker can lift a load of 10 kgs, with these exoskeletons, powered exoskeletons, he can lift a load of 30 to 40 kgs also. Secondly comes passive exoskeletons. So passive exoskeletons are like joints where you can continuously change your posture in your workspaces. If you want to sit at a particular desk, you can sit, do your job. You can just arise from the exoskeleton. You can go to a particular place and then continue your job. So when it comes to exoskeleton, the fit, functional and variability is of prime importance. So there are two types of fit. The exoskeleton which has been applied for a particular case, is the case correct or not? And is the person wearing the exoskeleton has a good fit or not? If both these criteria are not met, then it would be a day one failure. So matching an exoskeleton to a specific person and a specific task is critical to the success. So critical analysis, exoskeleton research still is going on, and its implication of musculoskeletal disease prevention, the final analysis would be coming in near future. So things to consider is task fixed better by engineering control, which might not require an exoskeleton, sizes, training and timing to don and off, adjustment, usage and acceptance, maintenance, storage, sharing and cleaning. So it is not a magic bullet yet. Try it before you buy. The next thing which comes is industrial virtual reality and augmented reality. Virtual reality and augmented reality are specialized glasses, goggles and smartphone apps. Earlier it was being used just as toys and for entertainment purposes, but now its application in industries has become quite widespread. So it is used for overlay of digital information into a plant worker's real life view. So it can help increase productivity, efficiency and safety on the manufacturing floor. It also does calculations on its own and statistics also. So that's the difference between VR and AR. In VR, the user gets fully immersed, so he has no connection with the real world. You cannot see the real world. In AR, digital information is being overlaid on the real world element, so he can see both. So what are the applications of augmented reality? Production, design and development, maintenance and repair, training programs, assemblies, quality controls and order picking. I have a video which we have been made for a MRI scanner gantry. It's a teaching video, which you can see. The technician can see this video, learn from this rather than reading it from books or from other persons guiding it. This has been made for a particular company. So the entire teaching module can be seen. This is very specific to the design of that particular MR scanner, but yes, this helps a lot. So this is virtual reality. Same can be done for augmented reality overlays also. So what are the benefits of AR and VR? Decrease development time of that particular product, decrease risk, manufacturing and servicing cost, and decrease cycle times. Embedded systems are small microcontrollers and IoT, Internet of Things. Usually these are small chips which can be attached to the body, which can measure these following non-invasive parameters: blood pressure, heart rate, SpO2 temperature, ECG and EMG. So for that matter, consider a worker going into an industrial place. So we have a central node which is a Wi-Fi server. The particular worker has a patch attached to his body. We are running a program which has all these parameters. So a combination of parameters or a singular parameter, if triggered beyond a certain point, for an example, heart rate going beyond 120 or changes in sinus rhythm, that particular central node of Wi-Fi server will directly communicate to the doctor or the emergency response team or to the central server. So the entire biology and the entire health of that particular worker is being monitored at a central level. So any changes in the heart level or any changes in the cardiorespiratory parameters would have a trigger in the red flag, and that would be triggered, and there would be alarm system which would be evident in the central server and the nearby OSC center. So to summarize everything, what are the future needs for the field? Wearables, automatic assessment, vision-based systems, augmented reality, data analytics, collaborative robots. So what is the future? The push for the smart technology and real-time data in every industry continues at a fast pace. We have to be futuristic. Earlier at a time we used to use those dabba phones, but now everybody has a smartphone. So predicting future outcomes, making decisions based on them is of utmost importance. To conclude, what the latest technology in ergonomics can give us, it improves the life of the working population in industries, reducing incident cost, staying compliant, improving productivity and quality. So this is a complete EHS ecosystem where people, process and the environment of the industry intersect. Thank you.
Thank you, Dr. Atreku. You very presented nice information on the innovative part so far as the ergonomics tools are concerned, and being a occupational health physician, these new updates also we need to take consideration because it is the era of the innovation. In upcoming time, these all devices, they are going to be placed, we need to use. Only thing is that at current era, the cost and the other things we need to consider, but so far as the ergonomics is concerned, all we know that it is the Greek word, that is the rules of work, and some basic rules we need to follow at the workplaces, particularly for the office worker, whether it may be straight back rule, straight eye rule, belly button rule, skin rule, and the most important, no brain machine rule. किसी भी machine का खुद का brain नहीं चलना चाहिए. There must be some limited value or limitation value should be kept for the every machines, and beyond that, the break rule, particularly for the office workers, we need to encourage for the all the workers to take break if they are persistently working over the tool. So yes, it was a very nice and informative session. Is there any question answers for this session? No, so yes, thank you.
I request our chairs to present a memento to Dr. Vaibhav. Thank you, Dr. Dinesh. Thank you, Dr. Atul sir, for chairing the session. I invite Dr. Sujata ma'am to facilitate our chairs with memento. Now we will be having very short break of 5 minutes for tea, and then we will meet again for the next stage. Thank you.
સાચવી નહીં આવે છે હમણાં.
We are starting the session. We request everyone to be seated here, please. Okay, so welcome back after the tea break. I call upon the chairpersons for the next session, Dr. Prateen Trivedi and Dr. Kalrav Thakkar. Dr. Prateen Trivedi is the head, Health and Medical Services, L&T Vadodara. He has a vast experience in IPCL and Reliance Industries for past 28 years with 5 scientific papers. And Dr. Kalrav Thakkar is the founder, ProMed Sentinel Healthcare. He is the joint treasurer of IAOH Vadodara branch, joint organizing secretary, GUJCON-2022. I welcome you both. I hand over the chair and the dais to the chairpersons to call upon the speaker. Our next session is sponsored by Opticura. Thank you.
Yes, here we would like to invite Mr. Bharat Chaturvedi, who is a co-owner of OptiSurgicare India Private Limited, and he has 19 years of rich experience in handling corporate customers in marketing, sales, strategic alliance, and account management. He has an active interest in newer technologies, and he is here to talk about the Titmus Vision machine for their latest offering in the industry segment. Welcome, sir. Over to you.
Okay. Warm welcome to all the delegates, special guests, invitees, and the esteemed organizing committee. I know it's a difficult time, typically Sunday afternoon, late afternoon, after a tea break. But in cricketing parlance, they say that post-tea session is always perceived to be one of those happening sessions. So I'll try and make this next 10 to 12 minutes absolutely watertight but happening. And you get to know about something which is absolutely a glorious story of Titmus, which has not necessarily always got covered. But a lot of you already know of the machine, but here is an opportunity for me to talk to you about something new that we have brought about with the Titmus machine. Okay, to begin with, as you all know, we are OptiSurgicare India Private Limited. We are a company that's based out of Ahmedabad, and we are absolutely working in the direction of being an end-to-end one-stop solution for occupational health. So if you see my slide, it says an introduction into the strategic alliance with the occupational world. Now, what do we mean by a strategic alliance with the occupational world? What we are basically trying to say here is that it is an opportunity we are absolutely embraced and indebted to working with this occupational health fraternity in the best way possible and providing you superior quality equipments and services that you typically need for your plants, for your sites, for your organization. Now, what is an OptiSurgicare edge? See, there are a lot of players who may be operating, who may be giving you a lot of services, a lot of equipments. But we are very, very careful about handpicking our products in terms of if it's a specific category, then what are the kind of products that typically work, how technologically superior they are, and how they are going to help you in the years ahead. That is the edge for OptiSurgicare. And that's where we work towards a customer orientation. That is very, very critical for us, and we don't believe in being called vendors. We like to be called partners, and partners is the mentality with which we go ahead. So there are a lot of places where we only want to work with you because we want to work with you over a period of time, not a transactional relationship. So that's not something that I believe in personally. Some of the core product offerings that our company brings to the table, my anchor product and the critical product that I'm going to be talking about, Titmus Vision Screener. Then we have spirometer, we have audiometer, we also make audiometer booths, AED machines are available from Philips, which we work and market with them, and ECG machines and oxygen concentrators. These are some of our core products. Just to give you a brief view, as you can see, Titmus vision screener, Spirolab spirometer, AEDs, portable ECG, audiometer, and this is something that we essentially deal in. Okay, now we come to this part, which is where I'm saying it's a glorious story of Titmus vision screener, and the way the name has been designed and how we have tried to create a communication line is Titmus, and you add another T and you add testing. So Titmus testing becomes the critical thing for the industry. We are saying that vision screening is something that you all understand, but there are reasons why we believe, and we truly passionately believe, that Titmus is the machine for any kind of vision screening activity that you intend to do at the level of your organization, at the occupational health centers, and for various community screening activities that we engage in. So, how we position this machine is, this is a machine which is primarily an all-in-one kind of AIO categorization. See, typically vision screening, we all know, is efficient and an effective process that's there to detect any refractive errors or any other eye issues that typically the workforce or the people at the workplace may have. So it is an effective way, efficient way, and you are able to know what is happening. What it also does is that a lot of employability criteria get affected. Somebody with a color deficiency or with a depth issue could be not suitable for a specific organization. So the idea of the machine is not to frighten people away, but to just give organization and people an idea, an in-depth idea, that where is it that they will be better suited in the employability criteria. Now, some professions like machine operators, you have forklift drivers, and you talk of clerical staff, they all don't necessarily need to go through the same kind of screening mechanism, screening parameters. So this is where Titmus works very well, because they have personalized specific job standards, which I'll come to you in the later slides. But that is something where we customize site screening, and it's not a generic screening which is fitting every target segment. So now when we talk of this vision screening bit, and we talk of these important aspects of vision screening, which is that one machine that will do this all, and that is where Titmus comes in. It will do it for you at the convenience, in the most effective way, and with 99.9% accuracy. So that is where we work, and when we say this with an aplomb, because we already have made about 400 plus installations across the country. So these are, of course, I'm sure you all know what vision screening is about, but typically the parameters that get covered are visual acuity, binocular vision, depth perception, color perception, muscle-eye balance, and peripheral vision, which is also called the field of vision. Okay, now we come to this whole story of the Titmus vision screener. Now we have more than 3 decades of experience, or heart and soul, in eye and specifically in vision screening. And this is a product, like I mentioned, with installations across the country, and a pan-India presence with large companies at the PSU level, at semi-government organizations, private organizations, a lot of NGOs, government bodies. They have all picked up vision screener from us and have used it for their requirement as they have found it suitable. Now, when we talk of the vision screener mention, so when we are talking about it here, so kindly just allow me, there's a small correction here. It's not the Indian Factories Act, but it's the Building and Construction Workers Act, which is where this mention of Titmus vision tester is clearly mentioned, where it is specified that this is a machine that is used, which is effectively and ideally used for any kind of vision testing activity. Now, what we have realized, and this again is stemming from the fact that, like I mentioned at the beginning, there's a heart and soul which is involved in creating this machine. So we did a research across the country, we did a research across geographies, and we realized that the same machine, the same standards will not work in all categories. That's where we recognized, and we got the thing called worldwide accepted job standards. That is something that we give with all our machines to the respective customers, wherein there is very clearly defined job standards for specific groups, whether it is the clerical staff, administrative staff, factory workers, skilled workers, semi-skilled workers. So so you can use the machine, you can use the job standard book and scientifically arrive at accurate results. Okay, like I said, again, another very important reason why this machine has found so much of acceptance in the industry is its ease of usage. Now, any machine which is easily used, you can use it easily, and you can train the paramedic staff, and they can use the machine and do the basic level of screening. I think it saves a lot of time of our esteemed doctors, who can then only be involved for activities where there are some complications, where there, you need further referrals and etc. So that's a very important part of it. This machine does not require any calibration, so that's something that I can upfront tell you. We as an organization give our customers the certificate saying calibration not required. So even from an audit standpoint, it works absolutely fine. This single machine allows you to do an entire test on both far-sighted parameters and near-sighted parameters in a matter of 5 to 6 minutes. At the beginning of it, you might take about 6 minutes, 6.5 minutes, but as you get used to it, that the whole thing can be done in about 5 minutes. All the tests that we are talking about, both for far and near criteria, can be easily managed in both day and night mode. Like I mentioned, very easily carryable, very, very handy device, very lightweight, is about 6 kgs in weight. You can easily carry it as a cabin luggage also, and you can see that in the pictures very clearly mentioned. Ergonomically, again, ergonomy is a very important part of any kind of screening activity or any kind of diagnostic activity. Now, the machine has been designed, and the flexibility of the machine is such that a patient can be managed in a sitting position as well as in a standing position. It can be adjusted up and down, and whoever wants to come and see the machine, you can see it. We have the machine at the demo counter also, so you can very clearly see it at our counter as well. So that ensures that by the time your patient is sitting and looking at the machine, he's in a comfortable position to answer to the questions that are going to be asked of them. It's absolutely on subjective criteria. So the machine comes with control panel. So control panel allows you to economize the space, and you can move between the slides using the control panel. Fluorescent light source. Now you can see the lights typically are again a very important thing, because what we are doing through this AIO, as I popularly is known as, is that we are taking into view your daylight conditions, we are taking into view the night light conditions. When you do a wall chart examination, sometimes your light may be slightly dim. So this particular machine ensures that the adjustment is done to keep in view what is permissible and what is it that you can use, which is the threshold levels for light. So that is a very important part. Now if you see the foam headrest, there is a headrest which is attached to the machine, wherein that's a comfortable position, because typically we would realize that a patient, whether he's a 15-year-old or 40-year-old or 60-year-old, may have some degree of discomfort if you are there for over more than 3-4 minutes. So you need a comfortable foam headrest. So that is something that we provide, and that is absolutely well managed. It doesn't get spoiled. People can come and just all you require is a little bit of wipe between the patients, and that's about it. You can use it. Head sensor. Now, when we talk of a promise being a product, a vision screener that gives you 99.9% accurate results, how is it that possible? Because there are those automatic electric sensors that ensures that only once your head position is in correct place will the slide start opening up. So chances of, of course, the slides will not show up till the time your head position is in correct place. So he needs to be in correct position, and only then the slides will start opening up, and then you can do the next bit of prompts. Now I'll quickly take you through some of the tests that are typically done. Before I get into the test part of it, something that I will also want you to know, here is a machine that has been designed to manage through Landolt rings. We have realized this over and over again across industries, across segments, across markets, that when examination happens at a factory site or at a plant level, you don't necessarily have everybody who's...
Sir, 2 more minutes.
How many?
2 more minutes.
Okay, okay. So, so whether it's a literate person or an illiterate person, if you put an alphabet in front of him, he will not be able to do. So the Landolt rings work for you, wherein there are cuttings in the ring, wherein you have to tell where the rings open, and that's where we do the examination, which even an illiterate person can very clearly do it. I'll quickly take you through some of the, the slides, what typically happens in a visual acuity. These are the slides you have fit for left eye, right eye, both eyes, far and near both. As I mentioned about the Landolt ring, so we do use it. So that's there, you can see the rings, there are openings at different places. Then there's something called binocular vision, which is the ability of the eyes to see both the things from both the eyes to see the same thing at the same time. So that is there as a binocular vision. These are the binocular vision tests that are done, wherein there is a fusion of what you see in both the eyes, and you should be able to see what it is, which is the right answer. Then you have depth perception, which is a very important parameter required especially for drivers and people in that particular segment. Our machine has it. Okay, color perception, the color deficiency bit that I am referring to, which is there, using the Ishara plates. Then you have the muscle eye balance, the vertical and lateral foria. These are separate tests that are typically there. Peripheral vision, which is a very important part of, incidence of checking glaucoma, which typically is a problem facing the industry at large. So even the smallest of this defect that a person might have will be detected using the machine. I will just just give me 2 minutes now. This is a very important part, and this is something which is what we want to refer to, which is the glorious story and the evolution story of the Titmus software. The Titmus software has been again designed in a way where it manages everything in the most effective way, and there is complete data encryption end to end. It's a licensed software which comes for a period of 10 years, and it is data encrypted easily. It integrates. Now, a very important part which we have realized when we have gone and met customers at the corporate sites, etc., is that you want to integrate with the medical management software present at the customer site. That is something that this particular software allows you to do. Now, I have created job standards basis the findings that we have in the machine, but a particular customer might have a specific job standard present at their location. This software allows you to integrate the software with whatever is prevailing at a customer site. So if your levels of threshold are different from what we have, we are absolutely open, we are not rigid, flexible enough to make it as per your requirement. Face recognition. Now face recognition is a very important part to ensure there are no proxy screenings happening. If I am being monitored, if I come for the screening for the first time, my face is captured, and even if I give my employee card to one of my other co-workers to come and do the examination on my behalf, it will not happen, because there is a face recognition which has already been captured. So that's a very important part of it. All tests are customized and for within different groups. So a skilled worker will have a different level of test, an unskilled worker will have a different set of tests, and likewise. And similarly, we can create the reports for our customers and requirement for factory medical officers and medical inspectors. Now, just last bit. This is the last bit I'm just showing you, which are various loyalty based, as I mentioned to you about installations. These are some of the very large prestigious organizations who've been using our machine for over the years, and all of these machines typically they've been using it and they've done repurchases as well of the latest versions. Private sector, you can see, I will now come to quickly also on some of the important installations in Gujarat. Adani Port, as you can see, Suzuki Motors, Bechraji, Reliance Industries have picked up from us at Dahej. Ambuja Cement has picked up, Baxter in Ahmedabad has picked up, Deepak Foundation, our own Vadodara bit has also picked up, Indian Oil again, Vadodara, if you can see, and so on and so forth. So as I mentioned, it's across the spectrum. Gujarat being where we are it's like Karam Bhumi for us. So we are here in Gujarat and we've been servicing a lot of customers and look forward to having more of you guys coming over. And this is where we stand. This is our promise to all of you, service and quality, where there will be absolutely no compromise whatever that's required. A customer's smallest little requirement, we will address it, and we will go to the extent of saying whatever that is required at a vision screening level, at a level where you feel good about your organization, we are there to support you. Thank you very much, sir. Thank you very much for your time.
As we all know, and Mr. Bharat has rightly said, that industry has an exquisite requirement of visual screening for all their workmen, and it is a part of our annual medical checkup or periodical medical checkup. So as he has to provide that, Apart from far and near vision, they have another parameters called peripheral vision test, color vision test, and many more. So we may use it to our best interest of our employees. And thank you very much.
Thank you, sir. I request the chairs to give a token of appreciation to Dr. Bharat. Thank you, sir. I request the chairpersons to call upon our next speaker. The next session is sponsored by Tricolor. Thank you.
Now for a very interesting topic on minimal invasive cardiac surgery, I invite Dr. Devendra Singh from Tricolor Hospital. Dr. Devendra Singh, he has a vast experience of almost more than 22 years and has performed around 10,000 plus cases in various corporate hospitals at Coimbatore and Escort Hospital at New Delhi. He has also overseas experience having surgical fellowship at Wakefield Hospital, Wellington, New England, and he is exposed to VATS and aortic aneurysm surgeries at Asian Medical Center, Seoul, South Korea. He is also trained in heart transplant and keyhole surgeries at Germany. He has a fellowship in aortic surgeries, and he is a visiting fellowship in University Hospital at Belgium, visiting fellowship at Royal Hospital in London. I invite Dr. Devendra Singh to talk on the minimal invasive cardiac surgery.
So good evening, chairpersons and dear colleagues. So I'm here to talk about a completely different topic from what you've been hearing for past few hours. So I'm going to give you an overview of what is happening in heart surgery and sorry. So basically, the common patients you would be also seeing when you refer patients for heart surgery is basically the majority of these patients have coronary artery disease or valve-related issues. So what is happening now in cardiac surgery? The recent developments or what is recent in CABGs is we are doing minimal invasive bypass operation, and besides that we do hybrid surgery, and we are also doing surgeries for complex coronary artery disease. So this is category of patients which are being refused surgeries earlier because they were considered to be inoperable. And we also do awake CABG in certain category of patient when the need arises. As far as valves are concerned, we have started doing mitral valve repairs for the purpose of preserving the patient's natural valve, because we consider those valves an ideal valve which is difficult to replicate. Besides this, it is also possible to do a minimal invasive valve replacement surgery, and we also have certain new valves which I am going to show you now. And you would have heard of transcatheter valves which are put through the femoral artery, and we replace the aortic valve. That's the commonest one. So besides that, surgery is also possible in patients with heart failure, and the commonest surgery that is being done is heart transplantation. And we also do mechanical circulatory support, where we replace the function of the main chamber of the heart, that is the left ventricle, with an artificial pump. And if the cause is the problem in the valves or the outflow obstruction or the ventricle, and it could also be corrected with surgery. So there are other options for heart failure. So I'll just go through and give you an overview of these things. So CABG gives an advantage that it bypasses the diseased vessel, and complete revascularization is possible, and the results of CABG are durable. A lot of patients you would have seen, it goes on for about 15 to 20 years without problem. But the problem lies in the incision. The incision is long, patient has pain, the stay in the hospital is about 7-8 days or 10 days. But the biggest advantage the CABG gives is the use of internal mammary artery, because it is part of the body and the artery arises from the subclavian artery. The patency rates are very high, and that gives the advantage for CABG. Patient is pain-free and free of symptoms for up to about 15-20 years. So that is the effect of the mammary artery, the single or bilateral mammary artery. So this has been shown through various trials. Now, so to get the advantage of CABG and to reduce the disadvantage of the incision and pain, so we have started minimal invasive bypass surgery. So basically this was started in Germany and other parts of the Europe, where they started doing the bypass operation through the left fourth intercostal space. And but this required special instruments and equipments, because it was not possible through the routine surgical instruments. So currently the minimal invasive surgery is being done in two ways. One is with the help of robotics. It could be completely robotic, or it could be robotic assisted surgery. So that is being done in very few selected centers in the world because of the cost and because of the exclusive training. And what we do here is mini thoracotomy. We call it minimal invasive coronary surgery or mid-cap. So there are a lot of evidence to say that the minimal invasive coronary surgery is better in terms of fewer blood transfusions, less pain, faster mobilization, smaller incision, and obviously patient is able to go back to work early. So this is particularly concerning if the patient is young, a patient who come to us when they are in their 40s or 50s. So we are offering minimal invasive surgery to those patients who need to get back to work early, especially who are younger patients. And a lot of patients would ask for cosmetic reasons. They don't want their sternum bone to be cut, and then they don't want to wait for it to heal. And there are certain category of patients when they are dependent on steroids, or when they are very elderly, or when debilitated, a lot of comorbidities are there. So obviously you don't want to cut the sternum and you wait for the healing. The morbidity may be very high in these patients. So we would go for a minimal invasive surgery. So I just take you through the video. So this is the angiography of the patient. So this patient required single vessel coronary artery bypass. So we give an incision through the left fourth intercostal space. You can see there we give incision about 2 fingers below the nipple, and it is in the mid-clavicular line. So about 2/3 of the incision stays lateral and 1/3 stays medial to the mid-clavicular line. So we divide the intercostal muscles. You see that's the intercostal muscles between the two ribs, and I'm feeling the rib below, and we're doing the hemostasis with the cautery. And then I'm opening the pleura, that is the parietal pleura that I'm opening down. So once the pleura is opened, we do the hemostasis so that we don't have to come back and do that again when we are closing. So the rib space is opened completely. This incision is about close to about 7 centimeters. We have special retractors for this. And most of it is German made retractors, and you can see the lung down, you can see the black portions in the lung. That's because of the tobacco. And there is a special retractor for harvesting the internal mammary artery from the chest wall. So we put in those retractors and then open up the space, but the space is just enough for the surgeon to see and do the surgery, not enough for the assistants to assist completely. And then we start harvesting the mammary, internal mammary artery from the chest wall. So we clip off all the branches from the chest wall and free it from the chest wall and the surrounding structures from the adventitia. So those are the branches going to the sternum bone, and that's a large branch there, you can see. So that's the internal mammary artery, and you can see the heart contracting below. And on the left side is the terminal portion of the internal mammary artery, which divides into two branches. So that is the complete length going up to the subclavian artery on the top. On the left side is the bottom, and we are clipping off the branches one by one. And then the artery is divided. So that's the internal mammary artery completely separated from the chest wall. And then we check for the flows, we clear, and we spray the topical papaverine to reduce the spasms because of the handling of the artery. And that is the flow in the internal mammary artery. And then this is opening up the pericardium. You can see this is the pericardium. We are using the cautery to open up the pericardium, the white structure you see. And that is the diagonal branch of the LAD, left anterior descending artery on top. And this side is the left ventricle. I am pointing finger at the LAD and the diagonal branch. And then we place the mops below the ventricle, so to lift up the heart. And then we put a stabilizer. This is a special equipment, a device which stabilizes that particular portion of the heart where the bypass is going to be done, and remaining portion of the heart continues to contract and beat and generate the blood pressure. As you can see there, so one particular portion of the heart, there's just about 4 or 5 centimeters of the heart, is stabilized, and we reduce the mobility of that portion to enable the bypass operation to be done. And then we prepare the internal mammary artery. So then opening up the left anterior descending artery, you can see there we are making an incision on that. And then we check the patency of the artery. We check whether there are any plaques or calcium deposits that need to be cleared. Proximally and distally we check. Then we use a shunt, the transparent plastic tube kind of device that is put in the artery to enable the blood to flow through the artery while we are doing the operation. And then we anastomose this internal memory artery to the LED. So we have done about close to 150 patients, and the mean age has been about 64, 40% are diabetics, mortality has been 0, and there are no deep wound infections. So this is the usual setup for the minimal invasive CABG, and this is the result, for the minimal invasive valve replacement and CABG. So this is at 2 weeks. And you can see the pictures on the left side is for the at around 1 year's time, on the right side is about 1 month time. Then we are also doing complex coronary artery disease. This is a set of patients where the routine traditional bypass operation is not possible or is refused. So we are doing this category of operations also. So redo operations have been reduced because of the medications which are available now, antiplatelet and lipid lowering drugs have improved the treatment of the plaques, and as well as the PCA has been quite effective in dealing with a lot of initial blockages. Coronary endarterectomy is one operation is being done when the artery is 100% blocked from beginning to the end. So it is possible to remove that plaque and do a bypass operation. So this is what we do. Basically, we open up the artery, remove the plaque completely, and do a bypass. So, and the results have been quite good. And then other situation is where the aorta, ascending aorta is completely calcified, where the bypass is not possible. In this situation, we have got some device now new. We have got a device like this, which is called as enclosed to device. This device can be put on the aorta directly without clamping the aorta. We don't have to clamp the aorta when because of which the possibility of stroke or embolism is completely eliminated. So this is a new device which is available now with us. The other option is that we also do a total arterial bypass where we use bilateral mammary and radial artery to bypass all the 3 blocks. And the another option we have is TMR or transmyocardial laser revascularization in situations where the patient's native coronary arteries are very small or diffuse disease and it is not possible to do an angioplasty or surgery. In this situation, we apply this TMR. TMR is a machine, basically a laser, which is released by direct contact. So we open up the sternum and then apply this directly onto the ventricle. So this creates new channels across the ventricular myocardium and improves the severity of angina. So basically it is a YAG laser which is used in this condition. Now hybrid CABG is another situation, and we have been practicing this now. Mammary to LED we are doing through minimal invasive CABG, and remaining, that is the circumflex and right coronary arteries, are tackled with percutaneous coronary intervention. And a certain category of patients who have got extensive chronic obstructive lung disease, which does not permit us to give them general anesthesia, it is possible to do an awake CABG where we put in high thoracic epidural and keep the patient awake, and we can do the routine bypass operation. Now mitral valve repair is also a new spectrum which has been added recently. In this, we try to preserve the patient's native valve. So, and this is mostly done in patients who've got severe mitral regurgitation. And in this, we try to reduce the size of the annulus, repair the papillary muscle and the cardi, and repair the anterior and posterior mitral leaflets. So overall, majority of the series, the survival rates are anywhere between 70 to 80% with this surgery. So this is the video of the mitral valve repair. As you can see here, that is the valve leaflet. We are putting in an artificial cordia. Artificial cordia are basically structures which attach the ventricular wall to the leaflet of the mitral valve. So this is what we are doing here is now preparing new cordi or strands which will attach the posterior mitral leaflet to the ventricular muscle. So basically there are 4 structures in a mitral valve. One is the papillary muscle, cordi, leaflet and the annulus. So this basically connects the leaflet to the papillary muscle. So we have got the special sutures which can be used to replace the natural chordae, and we call this basically artificial chordae. So this particular case we have done robotically, basically. So that is the papillary muscle which is being held, and we take sutures in that and prepare an artificial chordae. So this is done in patients who have got severe mitral regurgitation, when the coaptation of the valve is not there and the blood leaks back into the left atrium. So we take multiple sutures, and it is mostly about close to about 4 to 5 sutures on the medial and the lateral aspect. So once that's done, we do a saline test to see. We inject saline into the ventricle. You can see nice apposition of the anterior posterior leaflets. So that suggests that the repair is successful. Yeah. Now that is about the mitral valve repair. We come to the heart valves. So we've got these are the category of heart valves which are available now. So in patients who have got valves which are diseased beyond repair, so it can be replaced with a mechanical valve. We can see on the left side there is a mechanical valve which is a bileaflet valve. It has got 2 leaflets which open and close. On the right side is basically bioprosthetic valve. Basically bioprosthetic valves are made from basically cows and pigs. So earlier we used to make the valves from the pig heart valves, leaflets which is taken and were repositioned and mounted on a Teflon ring. Now it is basically largely it is made from the cow's pericardium, which is basically prepared in the form of leaflets, and then we get a bioprosthetic valve. So this is our current generation bioprosthetic valves you have. And the second one is basically sutureless valves which have come. We don't need to take sutures in the patient's heart. We need to just position it there and expand. It will stay in that place. Then third category is basically transcatheter aortic valves, and the valves which are in development now is basically polymeric valves, valves which will not have any reaction in the body.
Sir, 2 minutes left.
Yeah, and the tissue engineered valves. And these are basically 2 of the kind of valves which are Sorin Percival valve, which is in use, is available in India also. We can use this. And this is our Indian valve, which is basically made at Sri Chitra at Trivandrum, and this is also being used in India, but this is a single leaflet valve. Now regarding heart failure, surgery is an option in few category of patients. So what are the options in case the patient has heart failure? So we've got heart transplantation, mechanical support device, and mitral valve repair is possible, and as well as revascularization and restoration. I'll just skip you through a few things. So this is basically heart transplantation. The patient's native heart is removed. So you can say the complete ventricles are removed, both the ventricles and both the atria are removed. Sorry. And the other option we have is, sorry, I'll just take you to another one. Yeah. So in case of failing heart, we have option of inserting a ventricular assist device, a device which will basically augment or partially replace the function of the failing ventricle. So this device takes the blood from the left ventricle, takes it to a pump, and then pump delivers the blood, or it actually pumps the blood into the aorta. And it will look like this. Once it is implanted, the basically the electrical cable wires which come out, and it is attached to a battery pack. So this is Jarvik 2000, which is being used, available in India. Sorry. Yeah. So this is, I just wanted to show you this device, which is available and we are doing in India. So basically sternotomy has been done. You can see the heart has been exposed. So this is basically a coring device. We make an opening in the left ventricle. You see that is a ventricle there. We make a small opening there, and then we put the Foley's catheter. You see the Foley's catheter, which is inflated so that the blood does not leak. Then we core a portion of the ventricle. So one chunk, small chunk of the ventricle is removed, and that inflow is cleared there completely. We clear that of the smaller strands and the ventricular portion.
Sir, 1 minute.
Yeah. So then the sutures are taken on the ventricle so as to place the device there. We connect the inflow device there. So that is how stitches are taken on the patient's left ventricle. So like this, we have an inflow device which takes the blood from the ventricle. It is fixed to the left ventricle. Now the hemostasis is achieved. Now the pump is attached to the device. So that is the pump which is attached to the device. And the white thing you see is the cable, electrical cable that will run the pump.
Sir, please come to conclusion.
We'll just finish this. Okay. So Thoratec is the company basically which manufactures these devices, and it is marketed in India as well. And this pump is placed on the left diaphragm. And the white cable you see is basically the electrical cables that run the pump. And the outflow from this is placed on the aorta. So we have an outflow graft that comes from the pump, and it is attached to the ascending aorta. So that will finally pump the blood, take the blood from the left ventricle. It will come to the LVAD pump, and from there it will go to the aorta.
Sir.
Yeah.
Please explain.
Okay, we can stop here. Yeah, sure. Thank you.
Thank you, Dr. Devendra Singh.
Yeah.
It was a nicely covered topic with video presentation. To summarize, I can say that with this minimal invasive surgery, it is useful with less blood loss, less discomfort to the patient, less pain, less infection chances, and early resumption of the duty. I remember that few years back we used to send a patient of bypass surgery to Ascot Hospital to Dr. Narendra Trehan or at Chennai Hospital.
Yeah.
And then onwards we get some Heart Institute at Baroda, and now we have such facility available here. Thanks, doctor. Any questions? No. There's no questions.
I now request the chairs to present a token of appreciation to Dr. Devendra Singh. Sir. Thank you, sir. Thank you, persons. I now request Dr. Sujata Rane to extend a token of appreciation to our chairpersons, Dr. Prateen Trivedi and Dr. Kalrao. Thank you, Dr. Sujata. We shall start our next session now. I call upon Dr. Milan Thakur and Dr. Prajesh Darji to chair the next session. Dr. Milan Thakur is proprietor Sparsh Occupational Center and he is a member of Central Council Managing Committee IOH Vadodara branch. Also a faculty for AFIH, CIH and IOH Medical Assistant course. Welcome, Dr. Milan. Next slide.
Thank you, ma'am. I now introduce our first speaker, Mr. Rajesh Palkar, sir. He's a MSW from MS University, Vadodara, and also having LLB and having 35 years of experience in field of HR in industries. He is currently working with Deepak Nitrite Limited as a senior general manager HR and IR for more than 5 years and has also a rich work experience of working with Alembic Pharma, Rubamin, JCT Electronics, Sun Pharmaceuticals, FAG, CL India, and held various positions of leadership in HR and IR. We welcome Mr. Rajesh Palkar, sir, for the session. Please, sir. We expect 10 to 15 minute session from Mr. Rajesh Palkar, sir, because you're already a bit late on the schedule. Please, sir, if you can help us.
Good evening. I think time is really a problem, and especially for HR people, when they get a mic, probably the temptation goes on. So I have to be managing the time. Thank you. I'm really happy I think all senior doctors are here. They are all visionaries in their field. I don't want to name anyone because then I'll not be doing justice to all of you. This is always a great pleasure. This is the third time I am talking before such an august audience. So friends, we are talking about basically OH, and then there is an HR perspective. So somebody was asking me, when there is a program of occupational health, so why HR is required? So I think I said that, see, HR is required everywhere. Whether it is E, H, S, anything, HR is required. And it's not that HR is something extraordinary, but HR has to collaborate with OH. So I'll try to manage the time also, but then there will be some pressure would be there at the back of my mind. Fine. Now, what are the challenges on OH front? So, before we really move on, we should understand some of the basics, you know. So, if you see the statistics, there are more than 100 million occupational injuries which happen across the globe, and India has a large chunk of it. In India, there are 17 million occupational non-fatal injuries. So that also is a very, very sizable. So this data is an authentic data, but may not be probably the most latest updated data. But otherwise, this is authenticated data. And you can see that more than 17 million occupational non-fatal injuries. So 17% of the whole globe, they happen in India. And about 45,000 fatal injuries. So this is again a very matter of concern for us. So, of course, I think this soft version of this, if you can share, probably will save some of the time, because some of the major points where I need to address. So we will quickly come to that. Now, this is occupational health according to WHO. So I think you being health specialists, you know better than me in this regard. But WHO has a very, very comprehensive coverage of the health aspect. So that includes safety, that also includes the working conditions, and it has further been extended. The scope has further been broadened. And these are basically the focus areas of occupational health. So 4 major focus areas are there about the occupational health. So you can see these are 4 P's actually. So we will now further move on to the importance. So why occupational health has an importance in an industry or any system for that matter. So occupational health, if it is maintained in a sound condition, it will lead to happiness. And once happiness is there, the employees are happy, probably that is the time when the organization will really get the best out of it. And sound occupational health has a lot of advantages. It helps you in retaining the management, retaining the employees, then maximizes the productivity of the employees. It also ensures that there is a minimum injury, illness. So all these things, you know, they really contribute to the organization from the prosperity and growth point of view. Now we move on to evolution. So this is an area where I'll throw more light. Please do not get distracted if I am not able to maintain the slides. I don't describe all the words and letters in the slide, but this is the background I have created. So I have been working in the field for almost 37 years now. This is 38th year. So I have seen the whole evolution of how OH has moved on. Now I remember in mid 80s, Right now there is a, the biggest chemical company, agrochemical company in India. I started my career with that company. And I still remember, now that company, it has got so lovely facilities now. But that is after 38 years. Now, with the same company, I will not name it for the sake of confidentiality, nothing else. The same company, I still remember in the year 85 when I joined, that was at Vapi, there was one doctor available and he would come maybe alternate day for 2 hours or something like that. And the idea and the intent why the doctor was kept was simply because whenever new employees would be joining, so they wanted to see the physical examination and check whether this person is fit enough or not. No even proper documentation was really speaking there. So that was the time. So the whole OH has evolved in this fashion. Now thereafter what happened was that in the after the Bhopal gas tragedy, our entire Factories Act got amended and the major 1987 amendments came, and that really changed the whole gamut of OH in an industry. And thereafter, we have been seeing that there are a lot of responsibilities, duties have been cast upon the factories, and the appointment of factory medical officer and such concepts have come up. So the second stage of this journey is basically after the amendments in the Factories Act. And thereafter, a lot of awareness kept on happening. Even the trade unions, they became more aware. Political parties also started knowing. So all this entire scenario really helped in creating this kind of an awareness. The next phase is that the economies across the globe kept on growing, and the labor started migrating, and then a time came where even people started migrating from country to country. So this is the new scenario. Now in this scenario, I think industries are not only talking about the regulatory aspects, industries are now really talking about the other aspects which include wellness programs for the employees, and wherein again HR is definitely taking a lead, but under the guidance of the occupational health specialists. I still remember my practical experiences in a couple of factories where I worked. I worked with a company where we were manufacturing color picture tubes. So there used to be, very hectic physical activity. And the picture tubes weighing about 14 to 16 kg was being moved from one point to the other point by each of the workers. So it was more of a manual work. Skill was definitely there, but more manual work also. And under these circumstances, ergonomics really was a major matter of concern. And I remember my friend Dr. Sanjay Rana is not here, otherwise he is very active in most of this. So me and Sanjay Rana, we really took a lot of initiatives, and this is how HR and OH can really contribute to the organization. So that really helped in overcoming a lot of challenges. There were many positions wherein, a person would, if he continuously works for 8 hours, it would take a toll of his back. Some of the concepts like varicose vein and all that, I am not a doctor, but because of the closeness with medical fraternity, I know a lot of things. And so that really helps. So I'll now further move on to another example. In COVID was a scenario that really helped everyone. Everyone had to look at the life in a different manner. Nobody had even thought of what would happen and how the things will be moving. People who were saying that, no, I cannot, I have to go to the office, then only I will be able to get the work done, nothing will move. So this is how, the COVID really taught us a lot of things, and I think it has really played a major
contribution in everybody's life. So during the COVID, with Deepak Nitrite, myself and we have Dr. Jain over here. So Dr. Jain had done a wonderful job with all of us, and Deepak Nitrite has got more than 7 factories across India. So what we did was that under Dr. Jain, we had Karthik Patel, and then the local doctors were there, and they really formed a great team. And I think fortunately, despite COVID at its worst, Deepak Nitrite was able to make probably more than what it normally used to produce. So that is what we could do. And really, the entire workforce really felt motivated also, because the company took a lot of care. So, so this is how OH and HR can come together, and they can make the things really different. And I think everybody has that scope, I'm very sure. So I got another 2-3 minutes. Oh, then it's fine. Okay. So now basically, if you see the common goals which any organization really has is, to reduce the industrial accidents. So industrial accidents can be reduced if there is a constant interaction between OH and HR. And once accidents reduce, naturally it is going to, recently those who are in Baroda are aware that unfortunately for none of the fault of anyone in our company there was a fire, and the kind of losses which we had to suffer. So basically accident prevention happens, then that is a major gain for any organization. Then it also prevents the occupational hazards and diseases. So basically these are the common goals between HR, management, company and occupational health. So if we can strive for that and achieve that, I think we as professionals have really done a great justice. Now how, again HR, how HR can really help OH to steer OH initiatives is mainly because of the, so mainly because of the competencies the HR has, both can really work together, and they can really be complementary to each other. Okay, now here there are certain challenges which probably can be there on OH front. So maybe there can be a lack of knowledge. Of course, all of you are keeping yourself updated, but still there are times when probably you might feel a lack of knowledge in some of the areas. So this can be a challenge for us. Or there can be, the changing working populations are there. So this is another challenge. So maybe we never know what is the kind of practices, health practices, the other population which has migrated has that. So these are some of the challenges which we really have to overcome, and I'm very sure that with the kind of transparency, with the kind of openness, we will be able to overcome these kind of challenges. And I'll just close my discussion with this last slide. So it would really have been more meaningful if we could have had some kind of a panel discussion, because I think my other speakers in my group, they also have very good experience. So if time still permits, maybe 5 minutes or something, we can together we can have one more.
Yeah, at the end of 3 sessions we can plan it, sir.
Okay, fine. So
thank you so much, Rajesh Falkar sir. ઓક્યુપેશનલ હેલ્થ સ્ટ્રેટેજીસ એન્ડ ચેલેન્જીસ જે થીમ છે એની ઉપર આપણે સ્ટોલવર્ટ્સને આજે બોલાવ્યા હતા, પાલકર સરનું ફર્સ્ટ સેશન છે, સેકન્ડ સેશન પીનલ પટેલ સરનું છે, થર્ડ પરમ સારસ્વત સરનું છે. ત્રણેય બહુ જ અનુભવ ધરાવે છે હેલ્થ, HR અને સેફ્ટીની ફિલ્ડમાં, અને એ જ આપણો હેતુ છે કે કોન્ફરન્સની થીમ પર આપણે છેલ્લે ડિસ્કશન કરી શકીએ. સો એકવાર 5 મિનિટ્સ ટોક, તમારા કોઈ પણ ક્વેશ્ચન્સ હશે તો ત્રણેય સ્પીકર્સ સાથે આવીને સંબોધશે. થેન્ક યુ સર.
I request the chair to present the memento to Mr. Rajesh Palkar. Thank you, sir. I request the chairs to call upon our next speaker.
Calling our next speaker, Mr. Peenal Patel, sir. He is a Hydro India EHS leader currently, working for GE Power India Limited, Hydro India Vadodara. He is having a 23 years plus experience in health safety field. Began his work with Alembic Chemical Works in field of EHS and works with Medias, Electronics, Petrochemical, Rubber and Engineering Industries. He has been accredited EHS Roadmap Assessor from Alstom and also Alstom International EHS Passport Holder, Lead Auditor for ISO 14001 and OSAS 18001, Global Hope Assessor and Alstom Zero Deviation Plan Assessor. We are very fortunate to have Mr. Peenal Patel sir today. He has fled right from Bangalore just to attend our conference and convey his regards for GUJCON-2022. We are very thankful to him that he spared his time to come over here and share knowledge with us on the theme, Occupational Health Strategies and Challenges. Welcome, Mr. Peenal Patel, sir.
Thank you very much. Thanks IOH and thanks GUJCON 2022 plus DISH for providing me this opportunity to be in front of with experts over here across the Gujarat state. And I'm really happy to be part of this session to share my thoughts and to share my experience of 26 years in various industries. So we'll talk about HSE perspective in terms of occupational health. Mr. Palkar has already narrated some thoughts about the HR perspective, and within 15 minutes of a span, I would try to give a justice to give you my thoughts or my experience, what I have learned in my 26 years of HSE experience in whole career. So in these 15 minutes, we will try to cover 3 topics mainly. First we'll have an introduction, then challenges, strategy, and then summary. So occupational health, is it a priority in industry? It's a big question. Whatever we are speaking in various forums and whatever we are hearing across India, I'm not talking about Gujarat. Gujarat is quite advanced and we have had a very good journey, what Mr. Palkar has told, and we have reached to certain level in terms of OH. But when we talk about India, are we really understanding or believing that industries have a strong priority for occupational health? That we need to understand. Also, occupational health as a profession. This is also one of the key questions, out of which what I have learned in my 26 years of experience, that at this moment also, yes, there are several occupational health staff which have been dedicatedly working for industries, but still it is not really, I would say, attractive field where more and more doctors want to join this profession. And that's why this is very important topic to understand. And third, how can we make a difference? When we are HSE professional, because I'm part of this team, HSE means I'm basically a safety professional, but when we talk about HSE, I'm part of this team, and when we talk about this occupational health or safety or environment, how can we make a difference? That we'll try to discuss or share what I feel personally. In terms of challenges, what I feel is, we are having a large workforce in India, and at this moment, whoever experts or wherever we are representing various industries, those are very big industry. But if we see India as a large, basically 90% of the population is really in unorganized sectors. So whatever we are talking about occupational health, basically we are normally talking about the occupational health in 10% of the portion where we are in organized sectors. But where are we in terms of unorganized sector? That is also one of the key questions of today. Legislation exists. Yes, there are several legislation, and implementation of this legislation is really not complete. Yes, we are putting our best effort, but still we know by heart that we are not really, I would say, completely implementing everything. When we talk about OH, in OH also we are focusing more on the basic legal requirement or basic legal compliance. What Mr. Palkar has told, okay, initially when he has joined the organization, doctor was appointed only for pre-employment medical checkup. Apart from this, we understand that, okay, pre-employment medical checkup, periodical medical checkup, these are the minimum requirement. But when we talk about the prevention part, because prevention is more important part in occupational health, wherein our contribution is extremely important. Third topic is lack of trained occupational health manpower. I'm not talking about this fraternity, please don't take me wrong. I'm talking about overall scenario in several states where I have been visiting or I have been working in various organizations, because I'm leading one organization across the India where we are having 43 locations in India. And that is also very important aspect where we must have more and more occupational health expert, or I would say people, to join this profession. There is a low priority and spending on public health which is reflected in the field of occupational health as well. It means that yes, we are having a lot of policies at central level in India, but at the same time when we talk about the implementation, providing support, providing infrastructure, it's really a challenge at this moment. Dense population and high unemployment level. In India, we are having dense population. We know that we are a country of 130 crores population. We are having huge unemployment, and we are having big unorganized sectors, and hence occupational health is not at all a priority for the employee itself, those who are working. That is also one of the key challenges what I see. Then one next point is undiagnosed and unreported occupational illness. Yes, in Gujarat, as I said, rightly mentioned, because we are having very active NGOs, active IOH, active DISH, and this is why we are at the advanced level. But it is not exactly the same in other states. So I am not sure that all the occupational illnesses are really being captured at every location in India, and based on which central can make the policy. There is also indifference and apathy of the employer, employees as well as general public, what I have mentioned, and lack of awareness about occupational health issues amongst all the stakeholders. As I said, workers, or I would say unorganized sectors people, they are really not bothered because they are working basically for their food, they are working to earn some money, and they are having that as a priority in India. Concept of occupational health center is new in India, not in Gujarat, but it's almost non-existent in unorganized sector. And you all might be agreeing with my statement that in unorganized sector, almost it is not existing everywhere. When we talk about the construction area, and when we talk about the projects which are being happening in Bihar, Uttar Pradesh, or other states, I should not name some state, but when we talk about those areas, basically it is really a challenging situation in those states. So friends, these are the challenges which India is facing in terms of occupational health. We are lucky having, I would say, IOH as well as DISH, wherein they are active and they are imparting various sessions, technical part. Lot of doctors are having a great network. Lot of occupational physicians are available. Lot of chief medical officers are already there in many big industries. We are really lucky, but at the same time, it is not exactly the same everywhere. And that's my point. So, Now, okay, there are challenges, but when we are working as a professional, we must have some strategy to go for it. Yes, we can propose certain strategy to the government or to the authority, those who are a lawmaker or those who are enforcing those, but at the same time, we also have a strong role to play. So, in terms of strategy, I would like to reiterate that we need to expand occupational health related legislation, and this is already in place. There are a lot of updations which are already happening, but still it's not enough. Development of institution and infrastructure. As I said, yes, there are certain institutions available in certain states, but at the same time it is not adequate. We are having large population, we are having several industries, we are having a big construction sectors, and those sectors are really being ignored, where we are not in a position to handle occupational health as a subject for those sectors. We need to spread awareness of the occupational health related issue. As I said, normally we are talking about the role of the doctor for laymen. I'm not talking about us, but if we talk about the doctor, then they consider, okay, if something goes wrong, doctor has to treat a person, or he need to provide assistance in terms of, I would say, injury management, so that from expert hospitals they can get help and then they can treat the person. But that is not occupational health, and we all know it. From this 2 days technical session, there were several technical sessions, and we have learned that yes, we are at the quite advanced level, but at the same time, we are not really working in terms of prevention part, or we are not putting exactly the same efforts in terms of prevention part. We need to update occupational health and safety legislation and adequate enforcement machinery as well. At this moment, if we talk about the machinery, government machinery, we are having very few people in government because they are also having a less resources. Now we need to understand as a HSC professional, if I am a safety officer, if you are a medical officer, it means that we are a legal position. We are part of the government because we are a legal position. So we need to help government to enforce those legal requirements. At the same time, we need to support industry and we need to add value to the business. So that is a leadership which is missing in some of the areas, and that is very important part. Adequately trained occupational health staff. Yes, we are having very good, I would say, institutes which are creating, or I would say, or developing doctors, safety professionals, environmental professionals. But at the same time, the demand what is there to cover all the other organized sector as well as various small scale and medium scale industry, it is really not enough. Occupational health staff needs to be developed as a leaders rather than only expert. And this is what my main comment. As I said, occupational health staff is really expert, and I believe them as a god, because in 26 years of experience in my industries also, I have faced many accidents. I have seen that. And personally, I have seen that there are certain doctors with whom I have worked, and they have saved life of several people. And that's why I am saying that doctor is really a god, they are expert. But at the same time, we need to develop our skill in terms of management, we call it as a leader. Yes, expert is required to treat the person, but at the same time, we need to become a catalyst between the organization and the government authority, so that we can convince the organization that, okay, how we are adding value to the business, we are not a burden to the organization. And that leadership quality is required, and for this leadership quality, person has to be attached with the shop floor. It means that the person who is having occupational health as a profession, the person who is having safety as a profession, person who is having environment as a profession, they need to connect with the shop floor or factory people. Whenever they are working, they are connecting with the people, they need to do their assessment, how they can prevent those occupational issues or occupational illnesses, or how they can prevent the injuries part. So these are the challenges I would like to reiterate. And I would like to summarize in certain key topics, though I have narrated certain points. Occupational health topic is extremely important and needs to be dealt with by authorities, employers and management staff as a priority. At the starting of the session, I said If we put our heart over here, it is health, at least I would say safety nowadays, yes, it has reached to a level where organization, government, everybody is recognizing that yes, it's a priority, but at the same time, at this moment, prevention part of occupational health is not at that same level. When we talk about the industrial hygiene, when we talk about the ergonomics, we are quite far in various industries, right? So, second point is make occupational health feel lucrative, hence professionals choose to make it as a career. At this moment, if we see 100 doctors, out of 100 doctors, 90, I would say 10 or 15 or 20 doctors are really making occupational health as a profession. Many people are qualified, competent, they can contribute, but at the same time, they are not considering this field to make as a profession, so they are working on part-time, they are providing 2 hours, 3 hours, etc. whenever they are available. So we need to make this field as a lucrative, and it's not in your hand or my hand, but this is a key point where we need to understand that this field, doctor is really an expert. We need to have a certain level so that doctor should understand, doctor will understand that if I am doing a private practice rather than if I will be making this as a career, I can grow, I can contribute to the organization, and I can grow as a personal level. And last point, but not the least, leadership skill. Leadership skill is must in all the profession, either it be it is a occupational health, safety or environment. If we are not developing our leadership skill, we will not be successful in the organization, because majority of the organization or majority of the employer will understand HSC field as a, it is not earning, right? We are not manufacturing. So they consider it as a burden. We need to convince how we are contributing to the business, how we are saving people, and that will be the, I would say, key point in terms of leadership. And people, those who are developing leadership, in addition of the expertise what they have, believe me, they are highly successful in their career. And that's why I said, profession of doctor, safety and environment, serve to save. Let us not make it as a slogan, it should be our personal value. Let us connect with the people, try to save people, and let us contribute to the organization as well as country as a nation, India. Thank you very much.
Thank you very much, Sir Pinal Patel, sir, on how to face challenges in the field of occupational health in India and develop strategies, develop our OHC staffing, and develop OHP leaders in organizations. Thank you so much for your kind advice, sir.
Thank you, sir. I request Dr. Milan and Dr. Prajesh to hand over the moment to Mr. Pinal Patel. Thank you, sir. I request the chair to call upon the speaker for the last session. Thank you.
So, good evening all. With us next speaker is Mr. Param Saraswat. He holds a degree of Master of Business Administration from Pune University. He completed his PG DGC from MS University. He is a certified NCC candidate trainer, certified IMS auditor. Param sir has over the 2-decade experience in human resource in various factories like chemical, cement, fertilizer, software and industrial engineering. Param sir have pretty much holding in a labor relationship management and manufacturing, HR policies and so many fields. And one more thing I speak that he is working in a nice topic which actually needs in post-COVID era. His impact of spiritual way of life on employee work-life balance with specially reference to Vadodara. Over to you, sir.
Thank you, Mr. Chairperson, for a kind introduction, and thank you, GUJCON, for giving me opportunity to speak on my thoughts from HR perspective on the given topic. See, as Rajesh sir, I will take it from Rajesh sir, where he has left. These are the challenges. These are the challenges HR along with occupational health practitioners we need to address on day-to-day basis. I have been strongly advocating to have a culture, right, rather than imposing legally or some kind of a punitive action attached if you are not complying to the safety culture or safety rules and regulations in the industries. Now, government is having its own agendas, fantastic. They are propagating, they want that we should have an approach where organized, unorganized workforce has been well taken care with all measures. But in real field, we need to have a culture. How that culture comes, how HR, what HR can do, what occupational health service providers like doctors, OHCs, paramedic staff can contribute. Recently, in last week, I met Director General of NCC in Delhi. We were discussing on this point. Youth, basically nowadays when we are recruiting youth, they are not having that much of a very respected approach towards the rules and regulations, especially in terms of safety and health aspects. They want to work on their own freedom. So I was discussing with him and I opined to him that if we can inculcate, if we can introduce some kind of a curriculum during their NCC camps, national camps, about health and safety. So this will help later in industries to have a culture of its own. Have you seen any defense services having a safety departments of its own? No. Why they are not having it? Because every individual in itself is a trained safety person. Where in the organization you see we are imposing a lot of rules and regulations. Doctors are there relentlessly working on counseling and coaching, we are regularly following it up, but unfortunately still accidents and incidents happen. I give an example, an operator who is opening the door, that shutter door, the handle slipped and hit his head. Who is responsible? Is there any lacuna in the organization, or it is an approach by a person? So I have been advocating the culture. The culture deficit is leading to such kind of lacunas, accident and incidents, near miss. Now in that case, an operator was not supposed to open the door. He has to wait for the right person. But he was not mentally present in the office. He was not mentally there, he was physically there. He wanted to start the work. So here comes the role of occupational health practitioners. I have been talking to Dr. Kalra various times. I have been speaking to Jensa a lot of times that we should have a psychosocial guidance to the employees, counseling to the employees, so that they should come to the work with the brain, with the mind, mental frame. If you see, if you all must have done a root analysis. If you go into the depth, you will find they were not mentally there at the time of incident or accident. That gentleman was opening the door, he knows that it is not my job, I can wait for the person to come. He is the right one to do. No, but he was not mentally there. He is not willing to wait. Why? Because he wants to move forward with his physical energy, not with the mental energy. In my research paper also, I have quoted several incidences where it is only a lack of your absence of mind and lack of interest due to cultural awareness in our society. These incidents and accidents are happening. Now, come to the topic. These are the parameters, basically, I have summarized, where HR and occupational health team along with the safety team we are on regularly dealing with. Everybody knows it, but my more focus is on work organization hazards. See, every wound, every hurt can be healed by the advanced medical system, medical therapy. But the scar on the mind, the mental health, it requires to bring back. For that, occupational health practitioners has to adopt an integrating approach, which I have been advocating and discussing several times to my team, my OHC team in organization. Now, these are the things which we on routine basis we are doing it. Now come to the strategy. This is, you see, this is something I have taken ethics and value in between. What is ethics? What is values? If we are having strong values, it is not possible that we could not have a culture. What are values? Values are self-defined morals, right? On the basis of ethics proposed by the company or implemented by the company in the paradigm shift of legal compliances. Now, leaving apart, if you see the socio-cycle work environment, psychosocial work environment is most important aspect. Incident happen, we are having advanced medical support, he will definitely get healed, but when he is coming to work, whether he is going to have that kind of 100% productivity, we need to work on his mental health. We need to remove his psychic fear. I give you an example, a person in night shift got tripped when he was working and he came to me that, sir, I want to commit suicide, either you give me a change. I don't want to work there. Believe me, it gives me 6-month rigorous counseling to the person that it is not because you have some operation issues. No, it is because you have a mental block now. In that area, I fall twice or thrice. There is certain negative energy. I don't want to work there. So all these mental blocks we have to work upon. That will lead to a healthy company as well as a happy employee. So I will not take much of time because we need, as Palkar sir has already, given a directive, he's senior to me, we will have a panel discussion. So remaining my time will be utilized in panel discussions. I know you GUJCON team is quite, having a very tough schedule for last 1 month. And with the thanks note to the GUJCON team and congratulations to GUJCON team for a successful drive. Thank you very much.
Thank you so much, sir. Such a nice session. So now every occupational health physician has to work on well-being of the employees and their mental health. So definitely we will work on preventive measures. Thank you so much, sir.
Thank you, sir. Now, if audience have some questions, maybe Pinal sir, Rajesh sir, maybe you can come up on this stage. And if we have any questions, then maybe we can discuss. Before that, sorry. I request Milan and Prajesh to felicitate Param sir with a memento. Thank you, Param sir, for giving us those moments to have one discussion. So if there are no questions, only one question to all of you. What is that one capability that you define that an occupational physician should have to overcome the challenges for the future? One by one, maybe.
Okay. So I'll just recapitulate your question. What is it that as an ability the OH specialist, physician must have in order to be successful? Okay. I think good question. See, OH, as far as you are all doctors, so coming back to IQ, probably you are one of the highest IQ holders. So that's not an issue. But from a management perspective, what I would feel is that I think especially those who start their careers in the early stages, I have observed, what I have observed is that they are good in terms of the medical knowledge and certain other aspects. But when it comes to, because in a large organization, when you are working as a FMO, Factory Medical Officer, then there are chances that you would be countered by unions, or maybe the union leaders will there, or not only that, human mind is very funny. So it's very easy to say that people are always positive, people are negative also. So now in these kind of situations, I think you must understand how to deal with the people, the interpersonal skills should be there. Then even the knowledge of some of the legal aspects, that is one area which you should try to keep on adding to your knowledge. Because number of times there are certain notifiable diseases are there, and many times some of the employees, they have got something else, and then they try to correlate that with your organization's production or product or process. So in this situation, if you have got probably if you have acquired enough knowledge about the process of your company, or maybe about the MSBS of the, so that will really help. So I would request and appeal to all these, those who are having a career in occupational health and they want to be successful. So just try to add on these competencies to your already strong background. That's it.
Thank you, Rajesh sir. Penal sir, only one competency at the top of all the priorities.
Yeah. So for me, basically, if you want to be successful as a health professional or a medical professional in the organization, as I said, person has to connect it with the shop floor. He need to spend time with people. He need to do all the risk assessment involving people, working as a part of cross-functional team, and then to make an action plan, rather than making one Excel sheet as a health risk assessment to demonstrate to the auditor to show that yes, my organization is having this, and then this will not work. If we are part of the organization, if we are connecting with the people, if we are having a great network with the people, and if people will understand that yes, we are working to protect them, and for sure they will accept us, and then we can grow in the organization. And there are several examples in front of us, those who are contributing in various organizations. Many doctors have presented and they are extremely successful because they have been connected with the ground. This is my key point.
Hello, sir. Yeah. Taking forward, in my view, adding to what Palka Saab and Mr. Patel has said, integrated approach. See, every organization is having a different process, and if FMOs can bring on integrated approach and help HR making employees more capable and capacity building. Integrated approach means the medicine you can bring some ancient Indian traditions as well. For ergonomics we talk about chairs, you can talk about yoga postures. So that integration approach will give you a more edge as well as understanding the process and related disease or stress associated with the current stress. Thank you.
So this is for HR. Sir, when we organize such kind of conference at different forum, we talk many big things. Okay, we do this, that, this is, but whenever you go to industry, whenever you visit the shop floor, the scenario is entirely different. Being a HR personnel, sir, I would like to know you, why the safety and health is not priority of most of the company. That is one thing. Second thing, whenever you talk about the recruitment of medical staff, okay, there is again, sasta ma sastu kon malse. Sir, why this is approach for the medical professional? This is for HR, sir.
Okay. This is a hard reality, and I have also seen this. And I think one of the Pinal Bhai had, I think you had presented one data. Probably out of 100, 90% of the organizations, they are unorganized or not in the large scale. So basically this is a major problem. But now if you see, if you just make a quick survey, let's say of 50 leading industries in and around Baroda. So all this, most of these leading companies, even if they are not falling under the respective schedule or the Factory Act provision, despite that they are having almost most of the organizations out of this 50 or 100 would be having full-time medical officers. But if you talk about the smaller companies or the unorganized ones, so there is a challenge. And very rightly you said, Sastama je avse koi, and if he can spend more time, so that there can be a paper formality can be completed. So these are the real challenges. And I think awareness has to happen right from all the levels. CII and other bodies should also take it up.
So sir, on behalf of IH Vadodara, my appeal to just highlight during your forum, just respect doctor, the staff, and whenever you are going to recruit them, just respect the salary part also. So you just highlight in your forum, sir, please. Because we doctors usually not good negotiators. Most of them.
Adding to Palkar sir, your questions, sir, it was your question to HR, right? Being HR, so I would also like to add on what Palkar sir has said. Time is changing now. See, every new generation is not ready to work where they feel insecure. During our time, it might, we compromises on certain social structure, and now the generation is very particular about this. So time is changing, and organization is giving more importance to health and well-being of an employee. So you rightly said it was a hard reality, and so far it has been relaxed, and we are sure in coming days we will be having a fantastic companies having all the medical facilities and ensuring well-being and happiness of the employee. Happiness index is coming in a picture nowadays.
And so the reality is the renowned company expects same. That is the problem.
So in that case, basically, we can take an opportunity by having a presence of Mr. Palkar, because he is representing HR. So they need to make a level where doctor will get automatically, I would say, a position in the organization. At this moment, if we compare, because this was also one of the point as a challenge what I mentioned. If doctor is being provided or offered 70,000, 80,000 or 1 lakh rupees as a starting salary when they are joining the organization. Whereas in today's scenario, if we see person who is an engineering graduate from the renowned college, he is taking 22 lakh rupees. This is reality. And that's why I said, and this was the reason I told that we does not mean me, but somebody has to take this as a point and to work that this profession needs to be made as a lucrative, so that more and more doctors can be attracted to make it as a career.
Sir, one thing I told you, that doctor is one of the prime person in industry. What I feel, being a senior doctor, okay, they will respect to me. But those who join our doctor community, you will not get a AC chamber. You will not get something. That is a very harsh for doctors. Those who are coming in the industry for a short time, for 2 years, 3 years, they will be harassed by department. I am truly frank to you. So many doctors I met with me, Sahib, HR department हमने हैरान करे. I don't know. HR department हैरान करे के ना करे, पर these are the feeling of the doctors. These are the feeling. કે ના સાહેબ ને મળવું હોય તો કોઈ ટાઈમ જ નથી, 2 દિવસ 3 દિવસ. So they doctors, FMOs, new FMOs, those who are having experience of 3 years, 4 years, 5 years. I met with so many occupational physicians. They feel sometime. And regarding the salary, So many times, as you told it, that somebody is getting a 20 lakhs, 25 lakhs, 30 lakhs. But doctor, na, tamare to 1 lakh rupiya mein aau hai to aao, nahi to જોઈએ. Such time of, અરે 1 કલાક નહીં સાહેબ, 2 કલાક તો ડોક્ટર આવે જ છે. I am just request to you that the doctor should be get some respect in the company. Okay, you are agree with me and you can say anything.
For the information of all three of you, when Dr. P.C. Jain sir was the president, અમે લોકો એક tariff committee બનાવી હતી, જેમાં we did a survey of all the industries in Gujarat and we prepared a guideline, tariff committee 2013. In that we devised 2 groups, visits of doctors within Vadodara, visits of doctors outside Vadodara. That was made in 2013. And for the information of all of you, IOH Vadodara was the first branch to do a database study of all the pay scales of all the FMOs. Part-time, full-time, 2 કલાક, 4 કલાક, 8 કલાક, બધાવાળા. We fixed the package 30 kilometers within the limit of Vadodara. Per visit 2200 rupiah and 600 rupiah petrol na. See, every consultancy people, whether it is safety professional, HR, when you are deployed on a returnship basis, there are 2 things. One is the visit charge, professional fees, and second is the travel fees.
Very true.
In the days of petrol being so costly,
Yes.
now it is time for IOH Vadodara to have another review of the tariff committee. But then once the tariff committee is there, I myself as a secretary wrote to about 13 bodies in Gujarat. And believe me, the first person to benefit was my president. So he benefited because the minimum guideline was city ni andar 2200 rupiah to 600 અને તમે વિઝિટમાં ના જાઓ તો પેટ્રોલના પૈસા ના લો, પણ 2200 રૂપિયા પર વિઝિટ તમારે લેવા જોઈએ. And many of us were not aware that when you go as a consultant, you have 2 charges. One is the retainership fees, the professional fees, and second is the travel charges. So I think in 2022, Jain Sahab, once we make the tariff committee, I think all of us who are working in the industry, we should stick to that. And I think we'll have to take help of HR professionals and people like penal, so that doctors are paid well. And secondly, when you are paid well, 1 રૂપિયો મળે તો 5 ગણું કામ કરવું પડે. પછી તમે એમ કહો કે 1 રૂપિયો આપું અને હું 100 રૂપિયાનું કામ કરું તો કંપની ના ચલાવે. I have received complaints from HR also कि कामत साहब ये बंदा काम नहीं करता, कोविड का टाइम था, उसकी फ्रेंड ने ना बोला वो विजिट नहीं कर रहा है. What should we do? Then I said sack him. Because we believe as a professional body, if a doctor does not visit his industry in times of COVID, we should sack him. So when you have power, you have responsibility. And when you have good money, you have to give the output. So I think the ultimate message is, the challenges are there, but there are strategies to solve the challenges.
I'll just highlight here one point. See, many times I have also seen, because worked in this region only, so many times those who are part-timers or they visit 2 hours, 3 hours, there also there is some kind of an unethical competition. And then they will say that, no, I will let him charge 2,000, I am there for 1,500. So that is one area, as Dr. Kamath has very rightly said, all of you must set a certain benchmark, and below that you should not compromise. Because once it happens, because I still remember when I started my career in HR, there was one company in Baroda, Chandan Metal or something. So I hope I'm not criticizing Chandan Metal, but our entire batch was called for interview, and then he was only saying, Ketla 500 જોઈએ, 600 જોઈએ, કેટલા જોઈએ? So then we had decided, no, we will not go there. So that way, we have to adopt this strategy.
Thank you so much, all 3 elite speakers, for coming over here and sharing your presentation and a symposium. We thank you all right from heart, all team of IOH Vadodara and delegates. Thank you, sir.
Thank you, sir. I request Dr. Sujata Rane, Chairperson Scientific Committee, to hand over token of appreciation to the chairpersons.
I'll request delegates to sit for 5 minutes. We will like to introduce our whole GUJCON committee on stage, and then you can leave, please.
Thank you, Dr. Sujata. I request Dr. Millan to give the concluding remarks. Thank you.
It was a very nice conference, and I thank all delegates for coming over here. I will thank all of you first, and I will like to introduce to you to all our managing committee team of GUJCON 2022. બધાએ બહુ મહેનત કરી છે 3 મહિનાથી આ કોન્ફરન્સ માટે, જેના લીધે આપણે અહીંયા આવી શક્યા છે, બેસી શક્યા છે અને સરસ આયોજન કરી શક્યા છે. ડૉક્ટર પીસી જૈન સાહેબ, ચેરમેન શ્રી GUJCON 2022, પ્લીઝ કમ ઓન સ્ટેજ સર ફોર અ સ્મોલ introduction photo of our committee. Dr. R.C. Saxena, President IOH Vadodara. Dr. Kishore Parikh, Joint Secretary IOH HQ. Dr. J.R. Kamath, Dr. Kamal Jain, Dr. Shirish Kumar Gandhi, Zonal Director Vadodara. Chairman Fundraising Dr. Mitesh Shah, Chairman Delegate Promotion Dr. Rakshit Akruwala. Dr. Sujata Rane, Chairman Scientific Committee. Dr. Samir Chaudhary, Chairman Souvenir Committee. Dr. Dinesh Prajapati, Chairman Cultural Committee, Joint Organizing Secretaries, Vadodara, Dr. Nishant Mistry and Dr. Kalrao Thakkar. I request you all on stage, please, one by one. Dr. Khyati Dave, Dr. Kalpita Shringarpure, Dr. Amar Rathi, Dr. Pratin Trivedi, Dr. Rikul Shah, Prajesh Darji, Sandeep Thakkar, Amar Joshi, Yatish Shah, Dr. Mihir Sheikh, Dr. Pragnesh Patel, Gaurang Pathak, Divyang Patel, Dr. Bhavin Dave, Dr. Hitesh Fadia, Dr. Jaydevsi Virpara, Dr. Prakash Shah, Dr. Prajesh Darji, Dr. Sachin Kulkarni, Dr. Jitesh Hadia, Dr. Jitesh Patel, and our IOH office staff, Jinal Ben. If somebody can call, yeah, Jinal. I hope I have not left out anybody from our committee. In case I missed anyone, please come on stage. GUJCON 2022 Managing Committee, IOH Vadodara. સો એક રિક્વેસ્ટ કરી ડેલિગેટ્સે જેટલા પણ છે કે આ બધાને તાળીઓ વધાવીએ જેણે તમારા માટે આટલી મહેનત કરી છે. હિપ હિપ હુરે. આવી જવાનું ને. હા. સોરી.
Kathy,